very good morning to our distinguished guests. We are really sorry for the delay. We'll begin with the first session for today. The session is on hepatology. For the same, can I please invite Dr. Munish Kumar Sachdeva, Dr. Manoj Joshi, Dr. Amit Mandot, and Dr. Ajay Bhalla to please chair this session. I would also moderate the session. I would also like to invite Dr. Amrish Sahani, Dr. J.R. Mahapatra, Dr. Ram Krishna Barnal, Dr. Hari Prasad Yadav, Dr. Rajeshwar Yadav to please chair this session.
Good morning, everyone. At the outset, I think we must really applaud Dr. Anil Arora for organizing this academic feast year after year. And we are starting our morning session with hepatology. Our first speaker is going to be Dr. Neeraj Saraf, who will be talking about immunosuppression in liver transplant. You know that in all solid organ transplantation, there has to be a delicate balance about the immunosuppression to prevent rejection and to also prevent complications due to the immunosuppressive agent. And I think all of us should know, whether we are doing transplants or not, all of us should know about what has to be the optimal dose. And for that, Dr. Neeraj Saraf would be talking about.
Thank you, chairpersons and moderators. And thank you, Dr. Anil Arora and Ashish and Praveen for inviting me here. So I remember when I joined Ganga Ram as a transplant hepatologist, Dr. Anil had done a meeting called Liver Transplantation, Has It Come of Age? I think that was 2006 or 7. And I think transplant was just starting at that time. Today, about 1,000 transplants are done every year in Delhi alone, and probably maybe about 2,000 transplants in India. And I think there must be at least 10,000, approximately 10,000 transplant recipients in the country. So yes, a gastroenterologist who's not actively involved in transplant, I think must know the basic nuances of liver transplantation, and immunosuppression is probably one of them. So this is the timeline of how immunosuppression has developed. And as you can see, the main activity started here in the late 90s when tacrolimus was introduced. Before that, there was a lot of rejection, a lot of mortality in liver transplantation. But after the introduction of CNIs, especially tacrolimus, things started improving, and the outcomes in liver transplantation became excellent. So these are the various drugs which are available as immunosuppressants in liver transplantation. So you have pharmacological immunosuppressive agents like steroids, CNIs, which include cyclosporin, tacrolimus, then antimetabolites, which mainly is mycophenolate in liver transplantation, mTOR inhibitors, everolimus, which is the newer one, which is now in use, and I'll talk of that a little bit. There are some T-cell depleting agents, very rarely used, mostly for rescue, for rejection. And then there are some biological immunosuppressive agents like alemtuzumab, basiliximab, and dacilizumab, etc. Now, these are mostly induction agents. And again, they are more commonly used in kidney transplant. And in liver transplant, we really don't use, most centers would not use induction immunosuppression. So when we approach a patient of liver transplantation, there is an induction phase. And like I said, the induction phase is very uncommon in liver transplant. But when it has to be done, it is usually done now with basiliximab. Maintenance agents are the ones I think which we need to know. And since the topic is about what a gastroenterologist needs to know, I think it is about maintenance, because these are the people who he will be following up later after the transplant. So the main agents are the CNIs, which is tacrolimus, the mTOR inhibitors, which is everolimus. Then you have antimetabolites, mycophenolate, and steroids. So it's basically these 4 drugs which play the most important role in preventing rejection in liver transplantation. So this is just to show the mechanism of action of various drugs. And the everolimus is a mTOR inhibitor. The mycophenolates, they arrest the cell cycle in the S phase. And then you have tacrolimus, which is a calcineurin inhibitor. So these are the main three agents which are used in liver transplantation. So the main backbone of immunosuppression in liver transplant for the last 20 years has been calcineurin inhibitors, and it still remains. The mechanism of action of inhibition of intracellular small molecules, cyclophilin for cyclosporin A and FK binding protein for TAC, and thus they prevent the activation of calcineurin molecule. Subsequently, transcription of important cytokines like interleukin-2 that are essential for T lymphocyte activation is inhibited. So they basically inhibit the T lymphocytes and cause immunosuppression. They have significantly improved the short-term and long-term survival of grafts. And current data shows that the rejection rates are to the tune of probably 10 to 15% in the first year with these immunosuppressive agents. They do have side effects, and I'll talk of that a little later. Major side effect of the CNIs is renal toxicity. There's some neurotoxicity. Tacrolimus is diabetogenic as well, and if you compare it to its counterpart, cyclosporin, it causes more diabetes as compared to cyclosporin. So there's a lot of data on tacrolimus, and it is now the drug of choice in CNIs, and it has replaced cyclosporin. And this is a meta-analysis which compared the two CNIs, tacrolimus and cyclosporin, and in terms of 1-year mortality, rate of rejection, graft loss, side effects, everything tacrolimus is better, except if you look at diabetes. So tacrolimus, the only place where it scores lesser points is that it causes more diabetes. The second major group of drugs is the antimetabolites. Azathioprine, not really used a lot in liver transplantation, so it's mostly mycophenolate, and they diminish the proliferative response of T and B lymphocytes. Antimetabolites are components of the earliest immunosuppressive regimens. And this is how they act. There is the inosine monophosphate molecule, and mycophenolate decreases IMP dehydrogenase and blocks the formation of GMP derives rapidly proliferating and T and B lymphocytes. So, but as a class of drugs, they are less efficient than, they're not as strong as the CNIs, and mycophenolate can cause some GI toxicity, and it causes bone marrow suppression. I'll again show a slide on the side effects. So antimetabolites are very important as a second drug with CNIs, but they are never primary drugs. So you never put a patient on only antimetabolites. There would be high rejection. You can put a patient on only CNI, he will do very well. So basically it's a combination of CNI plus antimetabolite, which we use, and that has a synergistic effect, and you can decrease the dose of both the drugs and thus cause lesser side effects. The third group of drugs, which I think in the last decade or so has become very popular, is the mammalian target of rapamycin inhibitors, or the mTOR inhibitors. There are two major drugs. The first one was sirolimus, and we've been using that for the last 10 odd years. Everolimus is relatively new, and I think it's probably been about 3-4 years now that we have started using everolimus, and the use of sirolimus has gone down. Everolimus is a derivative of sirolimus with an extra hydroxyethyl group at position 40. And apart from its immunosuppressive effects, mTOR inhibitors are known to have anti-proliferative effects, reducing the risk of post-transplant recurrence of cancer and de novo malignancies. So mTOR inhibitors, there's a lot of data that they should be used in patients who are transplanted for HCC, because they will reduce the recurrence of HCC as compared to using CNIs. So mTOR inhibitors, again, they don't come without side effects. There's dyslipidemia, proteinuria, and sometimes leukopenia. A very common side effect is oral ulcers, And a lot of times we have to actually discontinue the drug because of bad oral ulcers. Earlier, it was thought that it causes hepatic artery thrombosis, so it was never used early on in the liver transplant period. But now I think there is a lot of experience and data that suggests that it really doesn't have any extra effect on hepatic artery, and it can be used. Although it does cause delayed wound healing, and that is something we need to keep in mind when we use mTOR inhibitors. So what is the current place of mTOR inhibitors? It's basically used, like I said, in HCC. It can be used to prevent de novo neoplasms. And another important area is renal impairment. So patients who have renal impairment because of tacrolimus, these are patients we switch to mTOR inhibitors in the long run to prevent TAC-induced nephrotoxicity. This is just to highlight the side effects. So as you can see, CNIs, nephrotoxicity, diabetes, metabolic syndrome, these are the common side effects of CNIs. mTOR inhibitors, the most common side effects are metabolic syndrome, dyslipidemia. Steroids, we all know, they cause hypertension, diabetes, dyslipidemia. They have effects on the bone long-term. But fortunately, we can stop steroids mostly in 3 to 4 months, and we really don't need to continue long-term steroids. MMF, the major side effect is on bone marrow. So that can suppress bone marrow, it can cause leukopenia, thrombocytopenia, and a common side effect is GI causing mostly diarrhea. But again, we see this less in liver transplant patients. We see this more in kidney transplant patients where the dose is higher. This is something which I want to just highlight is metabolic syndrome, just 1 or 2 more slides. Metabolic syndrome is a major issue in liver transplant now. And NAFLD is probably the leading indication for liver transplantation now. And there's a lot of de novo metabolic syndrome occurring in liver transplant recipients because they gain weight and they develop diabetes because of immunosuppression. So that is something we have to keep in mind. Most of the immunosuppression causes metabolic syndrome. So we need to optimize their doses. The only drug which does not cause or has effect on metabolic syndrome is MMF. This is just a flow chart to show what is generally done. So in the first 3 months, you could use TAC monotherapy. Most centers would not do that, maintain levels of 5 to 10. The standard practice is to use TAC plus MMF, keep a level of about 5 for TAC and add MMF. And in some cases, everolimus can be used. And this is what we're interested in after 3 months. So again, TAC monotherapy, not used often, but you keep levels of 5 to 8. But if you're using TAC plus MMF, which is a standard combination, then a level of 3 to 5 plus MMF is good enough. We really don't chase TAC levels after, about a year after transplant. So if the person has even low TAC levels, his LFTs are normal, you don't have to really chase a level. So it's believed that every person has his own level and you really don't have to chase a definite number. Now, the concept is now shifting from protocol-based immunosuppression to individualized immunosuppression. And this is based on adverse effects and the beneficial effects. So the concept is you tailor the immunosuppression according to need of the patient. And these are the various conditions in which immunosuppression can be tailored. I already talked of giving mTOR inhibitors in liver cancer, mTOR inhibitors in renal dysfunction. In non-alcoholic fatty liver disease, I would keep the CNIs and the mTOR inhibitors at the lowest possible dose and give them MMF because that has the least potential for metabolic syndrome. So to summarize, immunosuppression consists of an induction and maintenance phase. CNIs, mTOR inhibitors, antimetabolites, and steroids, these are the 4 groups which are the main drugs. CNI plus MMF, I think, is the most standard protocol world over, and with steroid withdrawal at about 3 months, and this is the most common protocol. Immunosuppression must be tailored according to the need of the recipient. So depending on if he has metabolic syndrome, if he has renal dysfunction, if he has HCC, we need to tailor the immunosuppression. mTOR inhibitors is a new class of drugs which is very useful for HCC and renal dysfunction. Renal dysfunction is the main and leading cause of toxicity of CNIs, which continue to be the backbone of immunosuppression in liver transplantation. And I think this is a newer concept that protocols should be evolved to decrease metabolic syndrome post-liver transplant and prevent de novo or recurrent NASH, which increases liver as well as cardiac mortality. Thank you.
Thank you, Dr. Neeraj, for simplifying such a difficult topic, such a difficult way to manage liver transplant patients. From the chairpersons, any questions? We can take one question from the house. I think we will follow that. Yes.
Dr. Neeraj. Dr. Neeraj.
Yeah, Dr. Manish.
Yes, a question basically with increasing pandemic and what you said about NFLD and especially common use of TAC. So what is your advice to these group of patients who are already getting transplant for NFLD and you are going to put them on NAC, this TAF? So other than monitoring with, advising them exercise and monitoring their metabolic profile, what
So
extra
in
you do?
terms of immunosuppression, see, you cannot do away with TAC. TAC is still the backbone. So you try and minimize the dose as much as possible. And like I said, I would, earlier the concept was we used to stop MMF at 1 year after transplant. But now what we do is keep MMF because MMF is safe. So lowest possible dose of TAC and MMF, that's a good combination.
Dr. Ashish.
Excellent talk. For a gastroenterologist who's following these patients, maybe 6 months, 8 months down the line, how often should he repeat TAC levels and what levels should he maintain? And the second question is there any regime where the immunosuppression is totally off, maybe after a few years?
So as far as TAC levels, I think it again depends on how the patient is doing. If his LFTs are absolutely stable, you're not making any. So if you're making any change in the dose, I would always do a TAC level within a few weeks to make sure that, you're not increasing or decreasing the levels too much. But for, in the first, let's say in the first 3 months, I would do TAC levels every 2 weeks. After that, probably once a month for the first year. And after the first year, once in 3 months, after a few years, even once in 6 months is good enough. And I'm sorry, the second question.
Is there any regime where you can totally remove?
So there have been studies on tolerance and doing away with immunosuppression, but there's really no data to suggest that. You always have anecdotal cases where patients themselves stop it and nothing happens to them. But then we have plenty of patients who stop it and they come back with bad rejection. So I think at present we cannot recommend stopping of immunosuppression.
Thank you, Dr. Neeraj, for excellent information
you.
on immunosuppressor. Now I'll invite Dr. K. Narayan Swami to speak on hepatopulmonary syndrome in cirrhosis.
Good morning. At the outset, I must congratulate that Professor Anil and his team has taken a great effort to bring us a wonderful academic program in the after long COVID pandemic. My topic today will be this hepatopulmonary syndrome in cirrhosis. You all know that will be this over the past 3 decades. There has been increasing the awareness about that will be the 2 important pulmonary complications of a liver disease. One is hepatopulmonary syndrome, second is portopulmonary hypertension. While there is a increase in growing literature and the impact of these complications, the survival is post-transplant, but there is the pathophysiology as well as will be the optimal therapeutic strategies are still not well recognized in case of management of hepatopulmonary syndrome. So hepatopulmonary disease increases mortality as well as worsen the lifestyle. As far as is concerned, the prevalence, comes to the 4 to 47%. The children also is present 3 to 10%, but there is no difference in that is a prevalence among the age, sex, and our etiology. But there is a recent study has come from the transplant center where a 970 patient where they have a preponderance of the highly percentage seen in the women with have a CLD patient, with a HC patient as well as a NASH patient to have the high prevalence that. But without any intervention, it is The 5% survival is only a 20% case of CLD with the HPS. The causes may be the CLD of virtually of any etiology, most common with the portal hypertension without cirrhosis. Some acute liver disease also, especially ischemic hepatitis, but Chiari syndrome may have that is associated with this. There are three mechanisms is causing the hypoxia and the hepatopulmonary syndrome. One is all know that will be this most common fundamentally having pulmonary arterial, that is the pulmonary capillaries and capillary bed dilatation is causing that is hypoxemia, that is the rapid passage of that is blood from that is a pulmonary capillaries to the pulmonary vein, so they are causing the ventilation perfusion mismatch. Second will be this shunt, there will be this right to left shunt causing that is poor oxygenation blood reaching that is pulmonary vein. Third is the diffusion capacity of the oxygen is reduced due to that is the diffusion distance is increased due to the dilated pulmonary. Second is what is the current understanding of that will be the hepatopulmonary is a pathogenesis. Most common the study, well studied and established will be the common the ligation study in the rat model, where they found that be after ligations development will be portal hypertension and proliferation of cholangiocytes may causing that will be the high that is endotoxins as well as increase the TNF alpha, and also from that is a bacterial translocation there is a rising that is a endotoxins will cause that is a monocyte influx in the pulmonary capillaries. In turn, it will produce it will be this nitric acid, carbon monoxide cause the pulmonary vasodilatations, and the endothelin induced the pulmonary endothelium dysfunctions causing also is a increase will be nitric oxide synthase, and in turn produce a nitric oxide produce that is pulmonary vasodilation, and simultaneously also produce the pro-angiogenic factors will be VGF and PDGF and PAGF, also the causing that will be angiogenesis also shunt formations. What is new in the pathogenesis in the hepatopulmonary is that is loss of that is ATP, the alveolar type 2 cells is lost because of the apoptosis in hepatopulmonary syndrome. The ATP cells basically physiologically produce a surfactant. The surfactants maintain the integrity of the alveolus. Here is because of this will be the diffusions of defective. The common, when come to the clinical presentation, common clinical presentation is most of the hepatopulmonary present is asymptomatic. Most of them it is unrecognized. So it may present as insidious onset progressive hypoxemia. And in addition to that, there are two well described but less observed will be the two characteristic features. What is not pathognomic, but it is specific to hepatopulmonary. One is a platypenia and orthodeoxysia. And as far as the physical examination found will be it is cyanosis, fatigue, digital clubbing, spider may not be very specific to hepatopulmonary, but maybe is associated with hepatopulmonary syndrome. So how to diagnose will be this and staging of the hepatopulmonary syndrome. There are three variables to diagnose will be hepatopulmonary syndrome. One is will be there should have a liver disease, the portal hypertension with or without cirrhosis. Second is the oxygenation defect. The oxygenation defect by measuring that will be partial to the oxygen should be less than 80 millimeter of mercury, or alveolar arterial gradient should be 15 millimeter of mercury, whereas in age group more than 65 where it be a 20 is a difference. The pulmonary vascular dilatation should be there as well to diagnose epilepsy, evidenced by that is a positive study from the contrast echo study or lung perfusion scale. And the staging is done by that will be this by mild, moderate, severe according to the basis of that is the partial presence of oxygen. What are the diagnostic tool to diagnose the hepatopulmonary? One will be basically whenever we used to have that is any hypoxia, we used to intend to have that is do that is oxygen saturations by using the pulse oximeter. The oxygen saturation comes to less than 95.6% in a sitting position is a diagnostic, but most of the time it is to have a very less sensitive, only the 28%, and have been diagnosed in only 71% patient of a severe hypoxia. But to overcome this, there are some biomarkers coming up. Will be this to diagnose, will be to identify that there will be cirrhosis with HPS, without HPS. One among these vascular cell adhesion molecule 1 as well as a von Willebrand factor angiopoietin 1. The levels which is determines will be whether it's the cirrhosis with the HBS or without subjects. But it needs a larger study to have before the brought into a clinical practice. ABG, you know that this will be one of the important tool to have find out will be the pulmonary arterioalveolar the gradient, as well as to find out the ventilation perfusion mismatch. These are the imaging studies, may not be very specific, but have some findings in the X-ray as well as a pulmonary function test. Now we come for the CT test. CT also is not very specific, but have been found out by this dilated pulmonary arteries will be increase the pulmonary artery to alveolar, that is a bronchus ratios. This is one of the most important study. That is a gold standard study where you have been diagnosed will be the right to left shunt by hand agitated saline infusion of the periphery. You can see that will be the bubble opacifications will be a right and left heart. If it is a confined to the right heart alone, there is no any passing in the left heart, this will be normal. When it comes to that is left heart, as that is opacifications, where see that will be there must be a some shunt, right to left shunt. If it is occurs within a 3 cardiac cycle, that is will be diagnosed of intracardiac shunt. If it is more than the 3 to 6 cardiac cycles, will be intrapulmonary shunt. The next study will have that is useful to find out once again the right to left shunt is more specific. That will be here we using that is a large albumin particle more than 20 micrometer. Here the study is considers a positive. It is more than 6% uptake in the brain. It's more sensitive to. So here you'll be, I'm showing that is one picture where there will be this a lung perfusion study done. It will be a 47-year-old female with a very severe hypoxia. That is will be less than 50 millimeter of mercury, where the brain uptake is comes to 53%, and the overall body uptake comes will be the 58%. The advantage of that is lung perfusion can using the techniques 19 macroaggregate will be it is a quantify the shunt. That is very essential to find out there will be the preoperative mortalities and higher specificity. What are the disadvantages? It have a lower sensitivity than a contrast echo study, but it have a cannot distinguish also intracardiac or intrapulmonary shunt. CT pulmonary angiography, it is not routinely done. It has been done when the patient have a persistent hypoxemia who have not responded to have that is a inhaled fewer oxygens, as well as a need for any intervention in the form of coil embolization in the case of arteriovenous malformations. There are some grading is be type 1 early, type 1 to advanced, type 2 is a discrete form. These are the pictures. See that will be this first one. They see that here will be this advanced form. There will be fungi appearance. The type 2 is will be this discrete arteriovenous fistulas. And what is the new in the diagnosis of hepatobiliary? You can use in the ultrasound. Here will be the according to the basic concept will be this hepatobiliary syndrome increase the cardiac hyperthermic circulation cause the structural change in the cardiac structure that can be measured indirectly by the color Doppler sign. Then recently have been Samarin has conducted a study in the ultrasound by an adult patient confirmed the HBSS and found there will be lateral volume is more than 50 ml is conformity of the HBSS when compared to non-HBS patients. The management issues, you all know that will be it is only definitely managed liver transplant is a reason. All patients with mild to moderate HBS should be evaluated for 3 to 6 months with the ABG, and all patients with a possibility less than 60 millimeter mercury should be evaluated at the liver transplantations. All patients with having oxygen saturation less than 89 or possibility less than will be 50 millimeter. Heart rest or exercise or while sleep should be provided the supplemental oxygens. And many experimental therapies are under investigation, but they tried but not have been such a definite benefits. Liver transplantation is the only thing. Without that, liver transplant is the higher the mortality will be 78%. With the transplant, will be 21%. Complete resolution of HBS will occur more than 80% of cases within 6 to 12 months. Patient may require the months of oxygens after liver transplantation. Post liver transplant, non-resolution is very rare. It will be less than 5%. The international societies of transplant society have brought out the standard exemption policy for the such a case of severe hypoxia, with the consideration of the having the since HBS is a progressive and the post LT is the highest mortality in the very severe. And the second is that the severity of HBS does not correlate the severity of the lung disease. How to optimize the perioperative care, it will be very important to have the good outcomes. Continuous intraoperative monitoring and consider for the echo, then the early extubation to avoid the VAP, and the delivery of 100% inspired oxygens and monitor, and goal-directed therapy for fluid therapy. This is one of the concepts. In spite of the post-transplant, where we found there will be this refractory the hypoxemia, that is a post-transplant refractory asthma. If you have the risk factors, having a pre-transplant partial oxygen is less than 50 mmHg, and the intrapulmonary shunt will be more than 20%. It may have that is a post-transplant hypoxemia. The management will be tried with the tunnel motion various methods. Now, non-surgical therapies, so the investigational therapy have been tried, but the various benefits are occurred, but the overall survey is not much improved. My conclusions, all patients with the chronic liver disease with dyspnea should be screened for HBS using ABG. So far, no definite plan for therapy for HBS except a liver transplant. Thus, all patients should undergo expected evaluation of liver transplant. Novel therapies are needed that either to resolve and cure the HBS or to slow down its progression to secure the successful liver transplant. Thank you very much for the patience.
Thank you, Dr. Narayan Swami. That was elegant. Just one question. A patient newly diagnosed cirrhotic in outpatient, how would you screen that patient for HPS? What would your strategy be? And would you want to screen every patient for HPS in an outpatient clinic? We're not talking of sick patients in the wards.
That's only we have in this, whenever chronic liver disease come to our OPD, we have a simple screening modality or be this come across will be this, that is a pulse oximetry where assess there will be the saturations less than 96% being a sanding position, still one of the clue for that. But associate the background you must have that will be the, whether there will be have the in-serious onset progressive hypoxemia with the associated some of the specific findings of platypnea, orthopnea is there. We can proceed with it. Further will be strengthening by ABG where you can find out the alveolar arterial gradient. Then it's a glue for your being HPS.
Any question from the audience?
Dr. Swami, why we don't have so much of rewarding in terms of nuclear scan or echo? Most of the time when we subject these patients with hypoxemia, mild or moderate, but the diagnostic criteria where echo and nuclear scan is very important. It's not so rewarding. What is the reason you feel about that in real time? The mass, this nuclear scan and echo.
Yeah.
In a highly suspicious cases also, you get a negative scan. So what is the reason you feel in most of the time? Is lack of common the real-time experience, or what is the reason?
I think he's answered that earlier, that if you do a contrast echo, the bubble scan, you will be able to pick up. And now with the new criteria where left atrial volume of more than 50, that is a soft criteria in nearly 85 to 90% of patients. So you'll probably pick up. It's a new modality to check, and we'll be able to do that. I think we'll close the session here. And we'll thank you so much, Dr. Sam.
Next talk will be by Dr. Gaur Chaudhary. Now, may I request Dr. Gaur Chaudhary to please come up to deliver his talk. He will be talking about when to and when not to do tips in patients with cirrhosis. Dr. Chaudhary, please.
Thank you very much, chairpersons and moderators. Thanks to Anil and Ashish and Praveen. Nice to be here. Just to give a background, tips came into India in a very big way in the 90s. And at Sanjay Gandhi Institute in Lucknow, we were in fact one of the first to do it. I remember Bajal went to Japan, came back trained, and we used to do tips, and a lot of referrals used to come from all over the country. Quite a bit of time has passed, and it's good to have a relook at what is tips. Basically it is a method by which blood from the high pressure portal system is made to bypass the liver and go to the systemic circulation. So in simple terms, that's what it is. And when do you think of doing it for a liver cirrhosis patient? Well, there are three sets of complications of liver cirrhosis. One is primary liver cell failure issues, low albumin, jaundice, coagulopathy, One is HCC, and the other is something related to portal hypertension. So I just want to bring your focus to only portal hypertension. That's the only place where, if at all, tips would have a role. And even there, we have to tweak the indications. So in portal hypertension, we have difficult GI bleed, difficult to manage with endoscopy or what have you, different ectopic varices, congestive gastric portal hypertensive gastropathy, intractable ascites, and sometimes hepatohydrothorax. Hepatic hydrothorax can sometimes be a very vexing problem. You know, one of the things that has happened since the 90s till today has been that there has been an increasing success and confidence in liver transplant. And liver transplant today, I would say, remains the most optimal choice for managing a patient with cirrhosis with complications. However, if suppose you think of a poor man's alternative to managing a complication of portal hypertension for some time, TIPS is still there. TIPS is transjugular intrahepatic portosystemic shunt. Some people spell it with a TIPS. Some people write a double S because of the systemic shunt part of it, but both of them are acceptable. So the primary indication or reason for thinking of TIPS is complications of severe portal hypertension, intractable, difficult GI bleed, ectopic varices, congestive gastropathy, intractable ascites, and hepatic hydrothorax. So this is what happens. Our interventional radiologist says they have got better by the day, and now they're able to put in a tube from the jugular vein, make a pierce all the way into the right branch of the portal vein and put in a shunt so that the portal vein blood goes straight to the systemic circulation, bypassing the liver. The end result is something like that. You have a little metallic shunt put in there between the right branch of the portal vein and the hepatic vein. And this is what it looks like in terms of radiology. The portal vein is flowing so easily all the way up to the inferior vena cava. Now, what are the consequences of this bypass? And the consequences are that obviously the portal pressure would come down, but then, the liver has this effect of clearing the ammonia and toxins from the blood. That doesn't happen. So the blood ammonia levels would go up. Once you have high volume blood from the portal system going into the systemic, you have pressure on the heart. So people who are elderly with frail hearts develop congestive failure. And of course, there are issues with the stent. Sometimes it can get blocked. Now, there are global guidelines for everything for that matter. So these are what are the global guidelines on where you can think of using TIPS. It's not that you must use TIPS, but you can think of using TIPS. To the left, you will find most of the indications are related to bleeding due to portal hypertension. And on the right, you have recurrent refractory ascites and refractory hepatic hydrothorax. Okay. Now you have to understand that when TIPS came at the same time, many other developments occurred. I think endoscopic management of bleed have improved by leaps and bounds over the last 20 years or so. So the requirement for using some other strategy has actually declined because you're able to manage much of it. Good medicines have come, like terlipressin for that matter. Ectopic varices, glue has come for gastric varices. But in spite of all that, there is still some patients who might actually not be very amenable to treatment. So these are the international guidelines where they have strong indications and weak indications. So the strong indications are essentially rescue therapies for difficult bleeds. So I'll just sum it up by telling rescue therapies. Rescue could mean acute bleed which is not resolving, or it could mean recurrent bleeds which are not resolving. So basically it's a whole long list of rescue therapies. Gastric varices used to be one of them, but now BRTO is another equally good interventional method, perhaps physiologically better. And of course, refractory ascites and hepatic hydrothorax continue to be vexing problems. With regard to the stent, so when I remember Dr. Bajal came back, we were that time using the bare metal stents. And you know, the bare metal stents, what happened is that in a year, almost 2 or 3 times, the patient would come back with a recurrence of the problem because the stent would get blocked. So blockage rates were pretty high. Thereafter, in 2000, there was a new technique or technology developed. It was called a polytetrafluoroethylene covered stent, which made the blood flow smoother and the rates of clotting inside the stents came down. So that's today the standard of care. The flip side is that, you know, when we started doing tips in SGPGI, it used to cost 50,000 rupees. Now with the new stents, it's about 4 lakh rupees. So obviously new devices are more costly. What could be the complications? So complications can pertain to the technique. So jugular injury, atrial perforation, capsule laceration with intraperitoneal bleeds. In fact, there have been vexing problems which we have faced in our experience. And some of them are rather too sick to tolerate them because they're already cirrhotic, coagulopathy, very high requirement of blood and so on and so forth, and early shunt occlusion. Elderly people with poor cardiac function, congestive cardiac failure. But the most horrific and I would say troublesome complication which I have faced as a clinician has been hepatic encephalopathy. You know, they keep going, flipping in and out of coma. And during my tenure in my previous hospital, I was in charge of looking at the ICU patients post tips. And many of them, you know, you salvage them by making their bleeding stop, but they never woke up. And one day passed into another. For 2 weeks, they would be in deep coma because of high ammonia, going up to 300 in the blood. And post tips liver failure. So, you know, once the portal blood completely bypasses the liver, so in some patients, the liver actually starts going down because it doesn't really get so much of nutrients. What are the contraindications? So today I would say that before thinking of tips, think more about contraindications. Anybody with a poor liver function, little elevated bilirubin, coagulopathy, indicating poor hepatic synthetic function or poor hepatocyte function, it's a bad candidate for tips. So if it's a primary portal hypertension problem with reasonably okay liver, you can think of it. Patients with cardiac problems, elderly people above the age of 65 have been found to do badly. And if you have patients with a whole lot of other comorbidities or HCC. So to conclude, I would say that TIPS is a good salvage technique for intractable portal hypertension bleed. It can be useful in intractable ascites and hepatic hydrothorax. But I must tell you one small thing as a tip from a person who has failed a lot. You know, the patient comes and then don't give him an expectation that everything will be hunky-dory. It isn't. So the response to bleeding is usually good, impressive, because the portal pressure comes down. The response to hepatic hydrothorax and intractable ascites is actually only about 50 to 70%. So you might still have a patient coming back to you pretty unhappy, telling that, look, I did all this, and now it's still there, the problem. And in addition, I also have encephalopathy. So that can be an issue. The major issue now is hepatic encephalopathy, and therefore careful patient selection remains the key. Thank you very much for your patience here.
Thank you, Dr. Chaudhary, for a fantastic talk as usual. But we often talk about tips. Why is it not so common? Because of complications or because of technical problems?
Very good question. So, in fact, I was thinking of doing that. I see a whole lot of stalwarts here who have seen about 40 years of practice. How many of you in your practice are doing more than 10 tips in a year? Ganga Ram? No. Dr. Rai, Dikshit, Anil, no. So you see, the technology comes, it serves a purpose. Then we say, wow, this is the final answer for a lot of problems. And then you find a little bit of disillusionment. And therefore you find that in the audience itself, anybody from your side doing a lot of tips? Mahanti, peerless? No. So that's been the decline in popularity of tips. So
So
Dr.
the
Reed.
thing, sorry.
What I feel is because as a hepatologist or maybe as a gastroenterologist, we have the impression that probably the patient has jaundice or patient is child B. We normally do not ask for tips in these type of patients. Even if patient has bled 2 times, 3 times, because of our inherent issues that probably we think that after tips the patient may worsen, his hepatic functions may further deteriorate and he may go into encephalopathy. Plus the cost of the tips is also high. So these are the factors which combinedly probably from our society point of view are not going up.
absolutely.
yeah.
And I think, Praveen, I mean, maybe you're a little younger than us, but the first experience of liver transplant in India, I hope you know, the first 7 all died.
I agree.
So our mortality rates for liver transplant were very high when we started. Okay. Today, I think the success has come to 90%, which means that, if you have a better option and if you can convince the patients, that's a more lasting effect. And tips would at best give you some respite for 2 to 3 years only. So that's the other
Definitely.
part.
You answered. I was just saying that I think in the West, tips is still being used as a bridge between transplantation. Whereas here we are happier doing our patients, sending them for transplant than getting a tips done.
Excellent talk. I just wanted to ask you that as compared to Bayer, the PTF covered stents do have less incidence of hepatic encephalopathy as has been reported.
No, very good. So, there's no point in having a stent put in getting blocked. So I think that the PTFE stent is still good, but it comes in 2 sizes. The standard one is a 10 millimeter size, that's 1 centimeter, and there is one which is a 8 millimeter size. So wherever there is a little bit of a doubt regarding that how much ammonia might go in, it's better to use the 8 one. So although your portal pressure reduction might be a little modest, but at least your chances of encephalopathy may be less. Or Guruji has come.
No, I just wanted to know your comments on use of tips for hepatic venous outflow tract obstruction.
Okay, I didn't touch upon it because the topic given to me was cirrhosis. But I personally think that in India, where surgery for that condition is more difficult, especially with our interventional radiologists who are doing a fantastic job, I think that is a very important role. And we have had a lot of patients doing very well on the long term in that particular setting. But today's topic was cirrhosis.
So one quick question, what antiplatelet and anticoagulant after tips?
We have had a lot of debate on that. So the question is, aspirin, your clopidogrel, yes or no? The debate is open because most of them work on the arterial side. So, that's used after coronary bypass and cardiac stents. What do you use on the venous side? Venous side, we have been using anticoagulants. Cirrhosis is a state where there is a degree of a coagulation failure. So no protocols work, but ultimately you do have to individualize patients and make sure things go well. I think the PTFE stent in terms of long-term patency is good. If at all the coagulation is just too normal, which is unusual, you could probably add a small degree of an anticoagulant, but the rest of it is all debatable. I think you were in Lucknow, we tried the aspirin clopidogrel that time. I think we gave it up.
Oh, well, I think you are discussing on tips and cirrhotics. And obviously, in cirrhotic, tips is not a cure.
Absolutely.
There is no medical intervention which is a cure. All the treatment you do cirrhotic complications for a variceal bleed or a refractory ascites. The problems are there in cirrhotic because of hemodynamic problems. So obviously, tips is non-panacea.
So what he said, it's a bridge to transplant.
Not
if the
panacea.
person,
You are buying time.
Absolutely.
However, there is a rider. Many cirrhotic today has an underlying etiology. When you are buying time and you can treat etiology well, right? Viral hepatitis is a different question. Even alcoholic liver disease is a different question. Now the natural course, right? There may be different. That is point one. So tips you should not write out because you can manage such patients actually. with various other complications and prolong their life, particularly when transplant is an extremely difficult situation in a country like ours, where TIPS is available. And as Dr. General Anand pointed out, TIPS actually is a curative therapy in HVOP. We have done 450 or 500 aims and published, right, with a long-term follow-up. Biggest problem is TIPS block. Average patient over a 5 years period needed 2.5 TIPS. And the anticoagulant we use try to keep the INR, because cirrhotic is not only hypocoagulable, it can be hypercoagulable. That debate you know. So you have to keep the INR. So while you say it is not a cure, it is a bridge to transplant, it can bridge to the other curative therapy. That's the only point.
Thank you.
Thank you so much.
Thank you.
Thank you so much, Professor Chaudhary. A big round of applause for such an excellent session.
Our next talk is hepatitis B in chronic kidney disease and its management. And to deliver it, we have Professor V.K. Dixit from BHU.
Thank you, Chairperson and moderators. At the outset, I would like to thank Dr. Arora for kind invitation and to be part of this. Friend, hepatitis B in CKD patient presented with a distinct clinical problem due to immunosuppressive effect of the renal failure, susceptibility to de novo infection and non-scobular transmission, and the long-term implication of the morbidity and mortality and change in clinical course after the clinical transplant. So what are the peculiarities of hepatitis B in dialysis patient? It's more prone to become the chronic carrier due to their immunosuppressive state, relatively milder, but they have relatively mild course, infection often asymptomatic, and normal or only slight elevation of the transfusion is there. What are the risk factors actually for hepatitis B infection when the person is on dialysis? There is a frequent transfusion required by the patient and presence of hepatitis B positive patient within the same dialysis unit. Non-segregation, initially we had the units where there were not segregated units and lower prevalence rate of the hepatitis B vaccination among the dialysis patient. And hepatitis B, basically DNA traverses the dialysis membrane during the high flux dialysis. So that's why the degree of infectivity of dialysate and ultrafiltration remains controversial. And there is a less risk in the patient of peritoneal dialysis. What are the factors actually which reduce the prevalence of hepatitis B infection dialysis patient? Screening of blood products for hepatitis B and anti-HBC, implementation of the infection control measures, reduced need for transfusion after the advent of erythropoietin, and the hepatitis B vaccination, which should be taken in the grand scale. How will you assess the patient coming with hepatitis B before going for dialysis? We have to have three importance as you do surface antigen, anti-HBS antibody, because you want to see whether the patient is immunized or not, or patient has a head infection, or anti-HBC. An anti-HBC positive patient with a titer more than 10, actually, they should be considered as immune, either through vaccination or prior infection, and they need not to give the vaccination, but they require monitoring in future because anytime they can have a seroconversion. Now, surface antigen negative and anti-HBC negative, anti-HBC negative, no prior exposure, they has to be vaccinated as soon as possible. So routine toss for hepatitis B while on dialysis. The surface antigen positive patient, dialysis should be done in an area segregated from the main dialysis unit. An isolated anti-HBC positive patient, just to rule out the occult infection by doing the DNA, and then you plan accordingly the management. What are the recommended HBV testing in the patient with the maintenance hemodialysis? Now, these are the routine tests, like a liver function test you do every monthly, surface antigen, anti-HBC antibody, anti-HBS antibody, HBE, HBDNA, and ultrasound, as you do routinely in all your patients. Now, infection control measures should be actually emphasized in the dialysis unit, and these are the universal work precaution, barrier practices like wearing gloves, etc., hand washing, and routine cleaning and disinfection procedure. Provision of the sharing instrument or medication among the patient, regular screening of the surface antigen status is non-immunized individual, and hepatitis B vaccination of the patient and the staff, isolation of the patient with the chronic or occult hepatitis B infection during dialysis, and the exclusion of the dialysis from the surface antigen positive patient. Now, once you have a patient, then how will you treat the hepatitis B in the CKD patient? Now, prior to availability of the nucleoside analog, clinical outcome in the dialysis patient was inferior. Only less than 5% of the dialysis patient with the chronic hepatitis B, they die of the liver disease. However, the majority of the death is due to CVDs. So treatment basically indication are usually same as in the non-CKD patient, relying on ALT, DNA levels, and fibrosis stage. Biopsy is preferred over the elastography if the need arises. Certain patients with the CKD or renal transplant might be receiving immunosuppressive drug for which prior or prophylactic treatment for hepatitis B is required in order to prevent from the seroconversion or flare of the hepatitis B. Always prefer a high barrier resistant drugs for treatment like tenofovir, TAF, or entecavir. Pegylated interferon, they don't have much of the role because of the side effect and they are intolerant and it is not drug which is preferred for the treatment. Now, what is more important is you require dose modification according to the creatine clearance. So if you have GFR creatine clearance, more than 50, you can give as usual dose as is prescribed in the patient who is not having disease or control, healthy control. But if there's a decrease from 30 to 50, then reduce to half. You give like 0.5 milligram because entecavir is definitely preferred drug over this tenofovir. So you just give the half dose. And if it is further the clearance is less, then you can give the drug like every 2 hours. Or if the person is on hemodialysis, then definitely every 7th day you give that drug. So you modify the dose according to the clearance or the GFR level. So you estimate the estimated GFR and then accordingly you titrate the dose. As for the tenofovir is concerned, again, like if it is more than 50, every 24 hours, it is 30-49, every 48 hours, and 10 to 29, every 72 or 96 hours in hemodialysis over 7 days or after 12 hours of dialysis. TAF is relatively better drug for that matter because even for, if it is more than 15 milliliters, you can give the full dose, 25 milligram daily. But if it is less than 15, then you can give the hemodialysis days, or if it is less than 50, without hemodialysis, then insufficient data, we don't have recommendation. Vaccination should be taken in the large scale because it is important for both preventing susceptible persons from acquiring hepatitis B. And in case controlled cholestasis, the risk of hepatitis infection patient on hemodialysis were reduced by 70%. So it is recommended to vaccinate the patient in early course of the disease, and a booster dose can be given to patients who are isolated, anti-HBC positive, but HDNA negative to simulate the production of the anti-HBS. Patient on the maintenance hemodialysis should be tested for level of anti-HBS 1 to 2 minutes after the administration of the last dose of vaccine. And if they are having protective levels, you don't give. If they don't acquire actually the sufficient, like more than 10, then they should be given the booster dose, or they should be repeated the course. Now, you can also measure, actually enhance the immune response by giving the double vaccine dose, like 40 milligram instead of 20 microgram, administered in deltoid area. Additional doses may be required because normally you give 0, 1, and 6, but you can also give the 0, 1, 2, and 6 months. Administered early before the GFR declines, and patients should be refrained from smoking. This is just vaccination schedule. What we basically highlight is basically these patients should be given a double dose, and according to the age, you can actually select the dose. And you can also not only the double the dose, you can also give the, sometimes the schedule also may be enhanced, like you can give 4 doses. There could be a possibility of waning immunity because all patients with the immunity to hepatitis E should undergo the routine screening for the anti-HBs titer at least annually to detect the waning immunity. And administrator actually booster dose when you find the titer drops below like 10. And vaccination failure sometimes can occur if you are having the failure to achieve more than 10 international, even in spite of the after 1 to 2 months of completion of vaccination. HBV infection in renal transplant patient prevalence in endemic areas is around 15% and declining trend due to the hepatitis B vaccine. So all patients undergoing renal transplant should be tested for hepatitis B DNA and HBE prior to transplant. Surface antigen positivity should be the increased risk of death and allograft loss. Liver disease is a leading cause of death among the renal transplant patients. And with the advent of antiviral therapy, overall progress has improved. Risk factor for the reactivation is important factor, and patient, particularly if it's on immunosuppressive therapy or stage of recipient, whether it's serological or virological marker, and serological virological stage of donor, risk factor for de novo HBV infection. And particularly if the person is donor HBsAg positive and recipient is negative, it's more chance. If the person is hepatitis B negative, anti-HB is positive, then it's relatively less. And if the person is hepatitis B positive and anti-HB is positive, then it is further less. So this increase the actually DNA proceed in person with these patients, they increase the HB DNA, proceed the transaminitis, result in hepatic failure, decrease allograph in patient survival, and risk of the hepatic failure and death. Preventive therapy should be considered in this patient, and either you can give as a preemptive strategy or you can use the prophylactic strategy. HBH positive renal transplant donor, particularly kidney from HBH positive, even from a hepatitis B, anti-HBC positive donors are not promoted, and reason being potential to transmit HBV to recipient patient. Now, I will just summarize the case. We like to give the consensus point actually, a meeting which was held by ANISAL and ISN. What they recommend actually, the serum creatinine estimation is recommended as an initial test for assessment of renal function in patient with liver disease. And the estimated GFR should be assessed using the MBRD 6-based equation. Creatinine clearance overestimates the GFR, and cysteine C actually is considered a good marker for the liver renal function. And 24-hour sodium excretion or measurement of urine spot may be used to predict the diuretic resistance. Non-invasive tests should be recommended as the initial test for assessment of liver fibrosis stage among patients with the ESRD with the liver disease and have a good negative predictive value. Whenever your non-invasive tests are discordant or no coexisting, the liver disease coexist liver biopsy should be indicated. And early CKD patient up to the CKD level stage of 3A, percutaneous liver biopsy may be done safely. Hepatitis B screening all CKD patients at the time of diagnosis and prior to initiation of dialysis. And hepatitis vaccine should be recommended in patients with a hemodialysis or peritoneal, pre-SGA, and kidney transplant recipient. Patients with renal failure should receive the higher vaccination doses as mentioned earlier. In renal transplant recipient, anti-HBs levels should be checked every 6 months to 12 months and booster dose administered whenever the level falls below 10. Strategy to improve vaccine response like GM-CSF or IL-2 or intradermal injection are not recommended. And nucleotide are recommended as the first-line treatment, and TAF, entecavir, and PDF, tenofovir, they are preferred choices. For subject receiving maintenance hemodialysis, tenofovir 300 mg or entecavir 0.5 mg every 7 days after hemodialysis session is recommended. All renal recipients who are hepatitis B positive should receive the lifelong antiviral prophylaxis with the TAF or entecavir or the TDF. And hepatitis B negative and unvaccinated should receive the hepatitis vaccination with double dose as a accelerated schedule, and anti-HB titers should be checked. HBsAg negative, anti-HBC positive should be monitored for hepatitis B and ALT every 6 months. Patients with ascites should be evaluated with the SAG for new insert or worsening of the ascites, and salt restricted with the loop dietitian may be initiated in the grade 1 or grade 2 ascites in patients with the CKD. LVP, these things should be avoided. Avoid fluid overload. Tips usually should not be recommended. And for diagnosing hepatitis B-related kidney disease, kidney biopsy with demonstration of HBV antigen histology is recommended. Entecavir, TAF are the preferred drugs in the view of their antiviral therapy. Thank you very much.
Thank you so much, Professor Dikshit. We can have one question from the house, if there is some. I think, thank you so much. We'll move on to our next session now. Our next session is going to be on, it's going to be on something different. It's a role of exercise and diet in managing fatty liver disease. I think this is something which we don't practice. We do preach a lot, but I guess we all have to put it into practice also. Dr. Vijayan Singh Chandel will be talking about it.
Thank you so much, Chairpersons. Good morning, ladies and gentlemen.
At the outset, I would like to thank Professor Anil Arora, Dr. Ashish, Dr. Praveen for having given me this opportunity to deliver a lecture in front of this August gathering. The topic for my today's talk is role of exercise and diet in managing fatty liver disease. So fatty liver, as all of you know, is the most commonest lifestyle disorder, and it is associated with multiple other lifestyle disorders like diabetes, hypertension, metabolic syndrome, dyslipidemias, overweight, and morbid obesity. And lifestyle modification is the most important treatment modality for all these lifestyle diseases. And exercise is the number one treatment for all these diseases. Exercise basically could regulate hepatic lipid metabolism by modulating hepatic beta oxidation and reducing hepatic lipogenesis. Exercise can ameliorate NAFLD by regulating SRE, BP1C, and PPAR gamma expression and activities. Hepatic inflammation, another major event in NAFLD, is also a key transitional event that progresses from a simple steatosis to NASH. And aerobic exercise basically decreases the expression of pro-inflammatory mediators like TNF alpha and interleukin 1 beta. So in overweight or obese NAFLD patients, weight reduction mediated by dietary and exercise therapies that decreases the liver fat content. A 7 to 10% reduction in body weight can lead to significant reduction in hepatic steatosis, improved NAFLD activity score, and even reversal of NASH. So human data clearly demonstrate that regular exercise itself reduces liver fat, and it can do so even in the absence of clinically significant weight loss. Various exercise regimes, they affect liver fat content, though there is no definite evidence to recommend one exercise over the another. But aerobic exercises, they have been shown to have an effect on hepatic fat content in most of the studies. And resistance exercises may provide an option to patients, those who are unable to perform aerobic exercise because of poor cardiorespiratory reserve. So choice of training for patients with NAFLD should be tailored based on patient's preferences and on the highest likelihood of continuation by the individual patient in the long term, because this is the most important thing. Once you are doing it, you have to continue it for a long term. So exercise, what is the best time to exercise? It is basically in a fasting state, and there is a 20% more efficient in losing weight than once you are exercising after taking meals. If you want to burn 100 calories, you would require to take at least 2000 steps, or you need to walk 1 mile. But what is the speed of your walking? That is also important. If you're walking at less than 70 steps per minute, that is hardly effective. It is as equivalent to being in a sedentary lifestyle. If your speed of walking is 71 to 90 steps per minute, that is usually recommended for patients who have poor cardiorespiratory diseases. And for a normal person, if you need to walk, the speed should be 91 to 110 steps per minute. For a patient who needs weight loss, the speed of walking should be 111 to 130 steps per minute. And this is the best exercise for weight loss. Which exercise is best? Is it aerobic exercise or resistance exercise? The literature shows that both the exercises, they improve NAFLD with similar frequency, duration, and period of exercise. That means around 40 to 45 minutes per session, 3 times a week for 12 weeks. Resistance exercises, they are more feasible than aerobic in patients who have poor cardiorespiratory diseases. And high intensity interval training, HIIT, which has recently come up, it is also equally effective and less time consuming as compared to aerobic and resistance exercises. So resistance exercise, basically strength or weight bearing training exercises. They have a direct calorie effect on exercise. They have a greater post-exposure fat oxidation. There is energy required to recover from resistance training session, and that may be the significant use in weight loss programs. So for weight maintenance, you need to focus to increase the volume of exercise. And for improving cardiorespiratory fitness, the focus should be to increase the intensity of exercise. So based on the current evidence, it is recommended that 150 to 300 minutes per week of moderate to vigorous intensity aerobic exercise should be performed on a minimum of 3 days a week for hepatic benefits in patients with NAFLD. Various aerobic exercises are walking, jogging, swimming, or bicycling. While evidence supports that prescription of aerobic exercise is the first instance should be done in all patients, but performing resistant training for 2 to 3 days per week, 3 sets of 8 to 12 replica may provide an additional benefit for optimizing insulin sensitivity and improving muscle strength and function. Then is the role of diet. Mediterranean diet has been studied exclusively and it has been found to be effective in both all the lifestyle disorders in maintaining weight loss. A Mediterranean plate should contain ideally 50% fruits and vegetables. 25% of diet should be from proteins like legumes, fish, and meat, and 25% should be from grains, rice, pasta. 1 glass of red wine is allowed, and 1 to 2 servings of olive oil can be taken. So a Mediterranean diet, basically you should daily consume whole grain foods at the meal, most of the meals. The plant oils should be preferred. Fruits should be taken 2 to 3 times per day. Vegetables should be taken in abundance, and nuts and legumes should be taken 1 to 3 times per day. Fish, poultry, eggs twice a day, or dairy or calcium supplement should be taken 1 to 2 times per day. But you should sparingly be taken red meat, butter, white rice, white bread, white pasta, potatoes, soda, or sweets. Fiber gap, which is a term used once you have reduced fiber intake, that may also contribute to NAFLD progression by microbiome depletion and increased gut permeability with intestinal translocation of bacterial lipopolysaccharides that can lead to insulin resistance, inflammation, and oxidative stress. So non-digestible fibers should be taken. Those are called prebiotics, and they undergo fermentation by microbiota, and they release short chain fatty acids, which are beneficial for our microbiota. So to increase these prebiotics, we should increase fiber-rich foods like fruits, vegetables, cereals, and whole grains intake that should be encouraged. So dietary prescription for any patient who needs to lose weight should be that calories intake should be 1200 to 1500 kilocalories per day for females and 1500 to 1800 kilocalories per day for males. If a patient is morbidly obese, then you need calorie deprivation of 500 to 1000 kilocalories per day. The total caloric intake from carbohydrates should be 50 to 60%. From proteins, it should be 15 to 20%. And from fats, it should be 20 to 30%, out of which saturated fat should be 7 to 10% only, and trans fat should be less than 1% only. The aim should be to lose weight at 0.5 to 1 kg per week, and patient should be losing more than 10% of body weight, and it's important that that should be maintained. And shifting most of the daily calories intake in the morning meals is beneficial for weight loss. Intermittent fasting, this is a newer concept which has recently come up and has been gaining weight in the recent studies, and it basically acts by 3 important hypotheses. One is oxidative stress hypothesis, circadian rhythm hypothesis, and ketosis. Oxidative stress hypothesis basically decreases mitochondrial energy production, and it decreases free radical production, and there is less of inflammation. Circadian rhythm hypothesis, basically there is a suprachiasmatic nucleus which synchronizes with the feeding times with the liver, pancreas, adipose tissue, and muscles, and that leads to optimized energy metabolism. Ketosis, basically you are shifting metabolism from carbohydrate metabolism to fat metabolism, and that causes ketogenesis, and ketogenesis then reduces adipose tissue and decreases LDL levels and increases the HDL levels. So intermittent fasting, basically it has multiple benefits and it can benefit brain health. It counters fatty liver by metabolic rhythms, reduced steatosis, and better cellular defense mechanisms. It maintains gut integrity by enhancing the microbiota. It blocks white adipose cell hypertrophy, and it prevents brown adipose cell whitening. It reduces the heart aging, and it preserves muscle fitness. Now, glycemic index was an important index which was being discussed over the years, but nowadays insulin index is being discussed, wherein you see what is the insulin response in response to any food you take and how much insulin is secreted over a period of 2 hours after you take any meals. So any meal which has no carbohydrate obviously would have 0 glycemic index, like eggs, butter, chicken, mutton, they have very low glycemic index, but that doesn't mean that they don't lead to insulin secretion. So to counter that, insulin index is being used. And if you look at these items, butter, egg, chicken, meat, they have an insulin index of 20 to 25. So all the patients who want to reduce weight, we should emphasize that they should take foods which are low in insulin index, and glycemic index should not be encouraged to monitor in patients who want to lose weight. So for all patients of NAFLD, a dietary prescription should be to drink mostly water, unsweetened tea or coffee, avoid sugary beverages like soda, juice, lemonade, and sports drinks. Half of your plate should be fruits and vegetables. Aim should be for non-starchy vegetable intake and whole fruits intake. We should choose leaner proteins like fish, poultry, beans, and nuts. Limit the use of red meats, bacon, and other processed meats. We should choose whole grains like brown rice, oatmeal, or whole wheat pasta. And remember, portion size is important because whatever you are taking, ultimately that has calories and that may hamper weight reduction. Thank you so much for your patience.
Thank you very much. And this is a burning topic. I hope there must be some questions.
To give a very good account of the whole thing, but I would like to say, what is the role of keto diet? Because it's coming up in a big way for the weight reduction.
So basically intermittent fasting and keto diet, this has recently come up and it has been found to be equally effective. And as I said, the hypothesis, there are 3 different hypotheses which are being described that this keto diet might help. One is that because keto diet, you are switching the metabolism from carbohydrate metabolism to fat metabolism. And once you are fasting, you are not taking anything orally, but your body still needs some calories. And for that, the fat is being burned, and then you are doing ketosis. And that ketosis is leading to fat burning, and then fat burning further decreases the liver fat. And that helps in countering all the mechanisms which lead to fat deposition in the liver. And once you are having ketosis, your adipose tissue comes down. And once the adipose tissue, the visceral adiposity is reduced, that is the main factor which helps in reducing NAFLD and other lifestyle diseases.
So I have 2 questions for you. Number 1, can you please define what is intermittent fasting? Because there's so much of confusion with regard to the patients because they don't understand what really it means. Sometimes they want to skip breakfast, sometimes they want to skip dinner. And my second question to you is, are they allowed to have pulpy juices?
First is intermittent fasting. Basically, there are 2 schools of thought. One is you fast every alternate day, or another is you take a meal during a window period of maybe 6 to 8 hours, and for 16 to 18 hours you are fasting. Fasting doesn't mean that you don't have to take anything during those 16 to 18 hours, but you are allowed water, you are allowed green tea, you are allowed tea without milk, you are allowed coffee without milk. So during all those 16 hours, you have to be hydrated, obviously, and you can take all those items during those 6 hours, but solid carbohydrates, fats, proteins, you are allowed in 6 to 8 hours window only. And most important is that you should be taking breakfast and lunch, but if you skip dinner, that is most important, because once you skip dinner, you have a fasting period of 16 hours, unless because you are sleeping. Once you are sleeping, you hardly require anything to eat. So it's important that you should take breakfast and lunch, and you can skip dinner, or you can take maybe an early supper at 6 o'clock. After that, you remain fasting, and next morning you take breakfast at 10 o'clock or 11 o'clock. And the more you stretch, the better you would be, because initially it would be difficult for anybody to fast for 16 hours. But once you get used to it, then you can prolong it for a prolonged period of time also.
The pulpy juices.
Pulpy juices, see, once you are taking fruits, you are taking all the fiber also with that. You are taking fruit juices also with that. And if you compare the insulin index of pulpy juices and fruits, the insulin index of almost all the fruits is 50 to 60. And insulin index of fruits would rise by 80 to 90. So basic aim in any patient, in a normal individual, if you want to reduce insulin resistance, you should be decreasing your insulin levels. Because once you decrease your insulin level, then your insulin sensitivity would be high. You would not be having insulin resistance. So basically, once you are taking any food which has high insulin index, insulin levels are rising. And once you are taking any food which has a low insulin index, then insulin levels would be on a lower side. And aim should be to keep your insulin levels on a lower side.
And lastly, sir, you mentioned about the red wine. I mean, Can they have it every day?
Oh, it is recommended in a Mediterranean diet because it has been found that it helps in cardiac health. It is good for your heart. That is what is recommended.
Can we stop the session now? Thank you very much, Dr. Chandran, for your nice talk. And may I now request Dr. Ramesh Roop Rai to please come and deliver his talk on nutritional assessment in patients with cirrhosis. Dr. Rai, please.
Good morning. At the outset, I wish to thank Dr. Anil Arora and Dr. Praveen and Dr. for Ashish for the kind invitation. Sorry, sometimes as you go old, sometimes you miss the name. We encounter such a situation in everyday time, and we are so much engrossed that what should we do for these patients? Such a bad state of affairs, the child patient comes to you. And we are many a times saying that probably it's a hopeless situation. To change the gap. Change. So the issue is that with many of the armamentarium we have today in our hands to improve the outcome of these patients, something can be done which is probably going to alter the whole situation. We are doing so many things for taking care of the etiology and other things. So malnutrition is one of the most important complication of cirrhosis, and malnutrition is a major predisposing condition for the development of frailty and sarcopenia, and is associated with increased mortality and morbidity. And we know that compensated cirrhosis patients have almost 20% patients have malnutrition, and decompensated cirrhosis, they have almost about 50 to 90%. So almost the child B and C, all of these patients have these things. And decompensated cirrhosis, along with the malnutrition and muscle depletion and sarcopenia, have a very bad outcome in most of the situations. They have more of hepatic encephalopathy, bacterial infections, recurrent ascites, and post-transplant also they have a very bad outcome. And in the surgical outcome also are very bad. So progression of the malnutrition is associated with progression of the liver failure. And as we go from A to B to C childs, the issue goes on becoming very bad. So why should we assess malnutrition? We must understand that it is probably a potentially modifiable condition, and improvement in nutrition is associated with decreased morbidity and mortality. And cirrhosis-related complications are there, and hospital admission and the period of stay is. So there is a particular of importance to identify malnutrition in patients with cirrhosis so that nutritional therapy can be instituted. In this year, when we are celebrating the Amrit Mahotsav of our 75 years, we are really searching for some Amrit for our patients, and probably a nutritional modality for our patients of malnutrition may prove Amrit for these group of patients. Issue is that in our clinical practice, we are not assessing our patients for malnutrition. And if we are not assessing, we are not taking care to give them nutritional therapy. So we have to, and why are we not doing it? The reason is very important, that we are so busy practitioners, and we take care of the ascites, we take care of the complications and other things, and we do not give point to the patient as to whether this patient should be given nutritional therapy or not to be given therapy. And we do not have a validated definition of malnutrition. But in 2021, the practice guidelines from ACG has given that an imbalance in deficiency or excess of nutrition that causes measurable adverse effect on tissue, body form, body shape, size, composition, or functions, and or clinical outcome. So it's a broadened malnutrition definition has been given. So you can encompass all your things. And as we know that malnutrition is causing frailty and sarcopenia. So they are the two phenotypes which are there. Are they interrelated or they are independent things? Issue is, it's not progressing. So as we know that malnutrition is inadequate intake of the macro and micronutrients, inadequate uptake of macronutrients and excess intake. And there are multiple factors which are there, which could be cirrhosis related, other system related, or physical inactivity and other things. And they all independently can also produce frailty and sarcopenia. And malnutrition causes frailty and sarcopenia. So we have to encompass the whole issue into assessment of malnutrition, frailty, and sarcopenia, because it is causing health-related quality of life compensation. So how to assess in a patient about malnutrition? And Royal Free Hospital and NPT is a rapid test which should be done in 3 minutes, validate against Royal Free Hospital as SGA, and discriminate patient into low risk, medium risk, and high risk. And you have a performer by which you can assess that whether this patient has got a score which is low risk, moderate risk, or high risk. And all those patients who are in the moderate or high risk, they should be assessed for a clinical nutrition assessment as to whether there is protein or fat or carbohydrate or micronutrients assessment should be done in all these patients. So this busy slide just shows that if you have a patient who is underweight and he has got child C, he has to be assessed for sarcopenia with the help of considerate CT scan and DEXA or bioimpedance assessment. So you can change and find out that this patient has got malnutrition or not. Now, if the frailty has to be assessed, there is many tools which are there to assess the frailty, but two most important are the Karnofsky performance status, which says that it is low performance, moderate performance, or high performance, or liver frailty index, which is also called most of the times to come into play, the robust or pre-frail or frail by this. So what is this particular thing? So liver frailty index has been found to be useful by hand grip, chair stance, and balance. And by a calculated formula, you can find out and say that the patient has got a robust one if it is less than 3.2, pre-frail 3.2 to 4.5, and frail liver frailty index is more than 4.6. Or a 6-minute walk test can be performed and to find out that this patient has got frailty. Because frailty is very important, the contraction of the muscles has to be maintained and frailty should be done. Assessment of sarcopenia is done by many of these ways. In this, anthropometrics are very common. Bioelectric impedance are very important. DEXA, ultrasound, MRI, and CT. CT imaging currently is the gold standard in assessing the muscle mass in cirrhotics. And in this, it has been shown that if you want to do tomography, there is a special software which is there by which you can assess the skeletal muscle of the patient, and skeletal muscle index has been found to be very useful in assessing that high morbidity or mortality is there or not there. Assessment of sarcopenia can be done with BMI, but fluid overload has important role to play. And using ultrasound for ascites, dry body weight can be calculated by subtracting 5% for mild ascites, 10% for moderate, and 15% for severe, or additional 5% for edema. So body mass index can play. So if they're less than 18, it should be called as. Another way is to do with the help of anthropometric methods, that is MAMS, in which trifold skin thickness is also taken into care. And MMS is calculated, which can tell you about the lean muscle mass at MAMC, mid-arm circumference minus 3.4 1/4 and tri-skin fold thickness, you can assess this patient has got. But this is very poor in the, and it cannot be equated with the CT scans for the SIM. So it is very important to do it. And another one is bioelectric impedance analysis has shown that you can find out the lean mass or body cell mass, and it has been found to be useful. It is bedside, it can be performed. The machines are not available all the time, so it cannot be performed in many of these patients. And it is, you can say that by phased angles, which show good reliability, even in patients with fluid retention, which is a very good tool, which is there. Ultrasound has been found to be useful, but it is not very commonly applied because it has not been assessed in many of the studies, except the Punita Tannan's study, which they have done it. Another thing is that muscle mass by MRI can be done. It is equated to CT, but it is not very commonly applied, and it's very costly one. Another thing which you can say is by DEXA, again, it is not a very commonly available method for all of us. So what we have to understand that various tools which we have in with us, we can assess the malnutrition, we can assess the heredity, and we can assess the sarcopenia. And sarcopenia has been studied most of the times as compared to frailty and malnutrition one. So we have to understand that we, as a clinician, should sensitize ourselves that all those patients who come to us for the cirrhosis management, we assess their malnutrition, screen for malnutrition, assess for frailty and sarcopenia, because this is very important that we must educate our patient and caregivers about the association between malnutrition, frailty, sarcopenia, and their outcomes. The outcomes can be improved with the help of nutritional therapy. So we should reassess all those patients who come to us, identify contributing factors, and all those management strategies should be planned according to the contributing factors. So we have to sensitize ourselves, and we have to sensitize the caregivers and this one. So malnutrition is one of the most important things. And if you provide the nutritional therapy to these patients, it may prove a game changer for these patients. Thank you very much.
Thank you, Professor Rai. And I think we are already running late, so we will close our first session on hepatology today. Thank you so much. Thank you, Chairperson, and my co-moderator.
So can we request you to please be on the center of the stage for a picture? Sir, can I also request all the speakers to please be a part of the picture? ये है. We'll begin with the session, second session on hepatology. Can I please invite Dr. Pankaj Puri and Dr. Ajay Duseja to please moderate the second session. Can I also invite Dr. Ajit Khanal, Dr. S.K. Mishra, Dr. Anil Kumar, and Dr. Ravi Daswani to please chair this session.
Good morning, everyone. So I think you're already late, so straightway I'll invite the next first speaker in this session. The talk will be given by Professor A.C. Anand, who's the professor and head of gastroenterology at KIMS Bhubaneswar. And he'll be speaking to us on diabetes in patients with liver disease, how to manage and when to refer. Sir.
Thank you very much. And very good morning to all of you. It's a great pleasure to be here, and I'm grateful to Anil, Praveen, and Ashish for this opportunity. Can I have my slides there? Yes. I've been asked to talk about the association of diabetes with liver disease, how to manage, and when to refer. There are three kinds of associations which are possible between diabetes and liver disease. Firstly, type 2 diabetes is a known risk factor for development of non-alcoholic fatty liver disease and cirrhosis. Second is, diabetes can coexist with any other form of chronic liver disease, and there it increases the severity and accelerates the progression of liver failure, leading to significant increase in liver complications and mortality. And third is, liver cirrhosis can cause diabetes, and it is called hepatogenous diabetes. We all know that almost 100% patients with liver cirrhosis would have insulin resistance, 60 to 80% will have impaired glucose tolerance, and 20 to 60% patients will have diabetes mellitus. Cirrhosis of all etiologies can have association with diabetes, as I have mentioned. And a survey was conducted among the physicians, and it was found that most of the physicians underestimate the prevalence of diabetes and impaired glucose tolerance in cirrhosis. A word about hepatogenous diabetes. This term is not included in currently valid national and international classification systems describing the etiologies of diabetes mellitus, but it is an entity that needs to be recognized and treated. Diabetic liver damage can be caused by many pathophysiological changes in diabetes. I will not be going into this because my main focus of talk will be about management of diabetes in chronic liver disease. But it is important for us to realize that diabetes not only leads to chronic liver disease, but also in the end stage liver disease, it increases the risk of hepatocellular carcinoma, increases the risk of variceal bleeding, SBP, hepatic encephalopathy, and also decreases overall survival among the cirrhotic patients. Even after liver transplantation, diabetes is known to increase the complications of the surgery. Post-transplant mortality is also increased among diabetic patients, and new onset NAFLD after transplantation is much more common in patients who have diabetes. On the other hand, liver can also lead to development of diabetes, and this topic we have recently reviewed, and I'll not discuss in detail here, just mentioning that cirrhosis can cause insulin resistance and also pancreatic beta cell dysfunction, and that leads to hepatogenous diabetes. It is important, I said, to recognize that hepatogenous diabetes is different from type 2 diabetes, and the main differences are listed here. The onset of diabetes occurs after the development of cirrhosis in these cases. The association with metabolic syndrome is usually absent in many of these cases. For example, patient who comes with hepatitis C related cirrhosis or hepatitis B related cirrhosis may not have any evidence of metabolic syndrome. There is no family history of diabetes in such cases often, and diabetes related micro and macrovascular complications are distinctly less common. Possibly patients don't survive that long to develop these complications. Fasting blood glucose and HbA1c is usually normal in these cases, and abnormal glucose tests are common, and the risk of hypoglycemia is much higher in all cases of liver cirrhosis because the glycogen stores are depleted. So this is the summary of what I have said so far. We can have type 2 diabetes, which also increases the risk of coronary vascular disease. Diabetes can also lead to NASH, steatosis, fibrosis, and cirrhosis at times. And this vicious circle can go on. It has been shown that NASH and fibrosis increase the risk of coronary vascular disease over and above which is caused by the metabolic syndrome. That means metabolic syndrome doubles the risk of coronary vascular disease. But if NASH is present, the risk is higher as compared to just the metabolic syndrome. So let's come to management of diabetes in cirrhosis. There are some special issues that need to be addressed. First, I have already mentioned partially, is difficult to diagnose this disease because there is fasting blood glucose levels may be normal or lower, and hemoglobin A1C levels are poor indicators of glycemic control in these patients. Hepatic encephalopathy and cognitive impairment may affect self-management of diabetes in these patients, and if they require a supervised management. Apart from that, in liver cirrhosis, there is altered drug metabolism and distribution and excretion of drugs, which changes their pharmacodynamic properties. There is high risk of hypoglycemia. There is malnutrition and sarcopenia associated with cirrhosis of liver, which will increase the nutritional requirements. Renal dysfunction is also common in patients with cirrhosis, and there is a risk of lactic acidosis with certain drugs. Hepatotoxicity of some oral hypoglycemic drugs is existing, and that should be avoided in such cases. About diagnosis and monitoring, the first 2 points I have already said. The hemoglobin A1C level is an unreliable index in cirrhosis because the red cell survival in these cases is reduced because of hemorrhage, coagulopathy, hemolysis, splenomegaly, and therefore we get lower than values which should be indicating the glycemic control. Glycated albumin and fructosamine may more realistically reflect the glycemic status over last 2 to 3 weeks, but these tests are not yet validated and they are not routinely available. Therefore, one has to resort to frequent self-monitoring of blood glucose. Self-monitoring has one disadvantage, that nocturnal sugars cannot be measured. Therefore, the continuous glucose monitoring systems, which are now available in certain places, can be considered for use in such cases. The overall management approach remains same as the management of diabetes mellitus. The bedrock of management remains nutrition and lifestyle changes, smoking cessation and lipid management, and same goes true for patients with cirrhosis also. This is followed by use of oral hypoglycemic agents and insulin as a last resort. There are certain situations where we have a lower threshold of using insulin earlier, and I'll talk about it a little later. Nutritional assessment has been just now told to us by Dr. Ramesh Roop Rai, and it is well known that malnutrition and sarcopenia are very common in patients of cirrhosis. Almost 80 to 90% people will have these abnormalities. On the right side of the slide, there is one study which is shown, which indicates the spectrum of malnutrition in these patients. Almost 1/3 of the patients with cirrhosis and diabetes had sarcopenia. On the other end of the spectrum, about 1/3 patients had obesity present. And in between, half the patients had myosteatosis, and neither was present in about 22% of cases. So a patient may not only have sarcopenia, they may also have sarcopenic obesity, and this needs to be managed. Therefore, the nutritional plate of diabetic patients with cirrhosis will be slightly tweaked to give higher values of protein. Proteins are recommended at the level of 1.2 gram per kilogram per body weight. But if the patient is malnourished, we recommend 1.5 gram per kilogram body weight. And as is true for all the diabetics, we avoid all the refined carbohydrates. Complex carbohydrates can be given with low glycemic index. And this was very well brought out by Dr. Chandel just about 15 minutes back. Total calories that are required are about 35 to 40 kilocalories per kilogram per day. And if the patient is obese, we can reduce it to 25 to 30 kilocalories per kilogram per day. We should, both polyunsaturated and saturated fats can be given. These patients require, because of cirrhosis, small frequent meals, a late night snack, and supplemental micronutrients can also be given. Now, diet and exercise is the most effective treatment for non-alcoholic fatty liver disease. NASH resolution as well as fibrosis regression has been found to be proportional to the degree of weight loss. So if one can lose about more than 10% of body weight, 90% of NASH resolution has been achieved, and 45% of fibrosis regression has also been achieved. Even in the other etiologies of cirrhosis, when it is present along with diabetes, one must recommend diet and exercise. This also helps in improving the diabetic control. It also treats the sarcopenia. So the details of diet and exercise have already been discussed by Dr. Chandel, so I'm not going to discuss that, but I'd like to mention that as clinicians, we often lack the training, tools, and time to effectively motivate the patients for lifestyle interventions. Successful practice needs committed counselors to bring about a behavioral change. And the usual steps in doing that are smart goal setting for the patient, identification of the barriers to achieve those goals, devising a coping plan to overcome these barriers, and monitoring and rewarding the progress in these patients. The basic principles of drug management remain roughly the same as in the management of diabetes elsewhere. The first line, as I mentioned, is lifestyle changes, and metformin is the first drug that is usually started in these patients. And we also need to find out here that does the patient have cardiovascular, atherosclerotic heart disease, heart failure, or chronic kidney disease. This is from the American Diabetic Guidelines. And certain drugs are recommended if there is a atherosclerotic heart disease. Certain drugs are recommended when there is a heart failure present. And if CKD is present, certain drugs are recommended, and one can use linagliptin preferably in these patients. Now, GLP-1 receptor agonists and SGLT2 receptor inhibitors are now becoming more and more popular in management of diabetes everywhere. And same is true with diabetes and chronic liver disease too. If there is no risk of heart disease, heart failure, or CKD, then first principle in treating a cirrhotic patient with diabetes is to avoid hyperglycemia. And for that, we can use any one of these four drugs, group of drugs, and they can be used in the sequence which is dictated by presence of comorbidities. If the patient is obese and one has to promote weight loss, then we can use GLP-1 receptor agonists and SGLT2 inhibitors, or lastly, DPP-4 inhibitors. If the patient has encephalopathy, obviously the patient, if is unconscious and is not able to manage on his own, then we can switch the patient to insulin. But if the patient has minimal hepatic encephalopathy and can be managed as an ambulatory patient, then acarbose or alpha glucosidase inhibitors can be given to these patients. This chart indicates the effect of diabetic drugs on NASH. Pioglitazone is the only approved drugs for the indication of NASH. It reduces cardiovascular risk. This is a little controversial because there is probably it's wrongly written here. It increases cardiovascular risk. Effect on the liver fat is beneficial, and liver histology also improves. All the other drugs have good effect on cardiovascular risk and may reduce the hepatic fat, but effect on the liver histology is not very clear. I'll take up all these drugs one by one so that if there are any special features, I can discuss with them. I have tried to summarize these 5 points about each drug. I will not be discussing mechanism of action, which of course remains the same as in non-cirrhotic diabetic patients. I'll be talking about fatty liver disease, compensated liver disease, which is not due to NASH, decompensated liver disease, and what is the final verdict. For fatty liver disease, it is useful for NAFLD, but has not been shown to be effective for treatment of NASH. For compensated liver disease, it is useful, but may not be useful for decompensated cirrhosis. For decompensated liver disease, there is very little data, and some people have reported increased mortality in decompensated liver disease. But final verdict is that it is the most commonly used drug, and dose reduction is required in child B, and if at all, it is used in child C. The advantages of using metformin are it reduces the HCC risk by 50 to 70%, reduces the risk of hepatic encephalopathy by 8-fold because it inhibits glutaminase, increases overall survival nearly mean of 11.8 compared to 5.6 years. Risk of lactic acidosis has been highly exaggerated because the incidence in cirrhotic patients, especially compensated cirrhotic patients, is not much, provided the renal functions are normal. Sulfonylureas I have shown in the red color here because they increase the risk of hypoglycemia. The advantage of sulfonylureas are that they are the cheapest drugs available, and some people may not be able to afford more expensive drugs, and therefore they can be used for fatty liver disease and compensated liver disease, but they are not recommended for decompensated liver disease. Glibenclamide, which is a longer acting one, is contraindicated, and relatively shorter acting drugs can be used in child's A cirrhosis. Pioglitazone, I mentioned, is the only drug which is approved for use in NAFLD and NASH. In compensated liver disease, it can be used, but one should be cautious of major cardiovascular events and weight gain. In decompensated liver disease, there is no data of use of this drug, and therefore pioglitazone can be used only in child's A patients. Alpha glucosidase inhibitors, I mentioned earlier, it is not useful for NAFLD. Compensated liver disease can be used because it decreases the ammonia level and improves the intellectual function in patients with low-grade hepatic encephalopathy, reduces ammonia level. For decompensated patients, it is not recommended and it is rarely ever used. DPP-4 inhibitors can be used in NAFLD, but they have not been shown to improve the histology. In compensated liver disease, they may be useful, but may need to be cautious of cirrhotic decompensation and hepatic failure, which has been shown to be higher when they are used for treatment of child's A cirrhosis. There is very little data for use of decompensated CLD. Vildagliptin is considered contraindicated, while other drugs can be used in child's A cirrhosis. GLP-1 receptor antagonists are the useful drugs for NAFLD, but its effect on NASH is still being worked out. There is limited data on its use in patients of chronic liver disease of other etiologies. The final verdict is that liraglutide is contraindicated in child's B and C, while dulaglutide and semaglutide can be used. They are contraindicated in decompensated cirrhosis. SGLT2 inhibitors, they are useful for NAFLD, but for NASH, results are not known. Limited data about compensated liver disease. It ameliorates ascites and edema, and there is limited clinical data, but it is promising. However, the final verdict is it is allowed in child's A and B. One should be cautious of the risk of urinary tract infection and hypotension due to volume depletion. Insulin is not useful for fatty liver disease, may not be useful for compensated liver disease, and one has to be cautious because there are some reports of increased mortality, HCC, and cirrhotic decompensation, hepatic failure with the use of insulin in these patients. It is recommended only as a last resort. For insulin therapy, one can temporarily switch to insulin if there is an acute complication like bleed, encephalopathy, sepsis, HRS, or diabetic ketoacidosis. Otherwise, one should switch back to oral hypoglycemic agents in child's A cirrhosis. I was also asked to talk about when to refer the patient for specialist consultation. Most of the patients with fatty liver are treated by general physicians. However, if the fibrosis is diagnosed, the patient should be referred to a gastroenterologist or a hepatologist. And in this situation, the gastroenterologist or a hepatologist should plan the treatment for cirrhosis and fibrosis reversal and refer the patient back to general physician for following it up. On the other hand, most of the diabetics are also treated by the general physicians. And if they are finding it difficult to control, then the patients are referred to endocrinologist. However, if the patient has both, that is diabetes and cirrhosis, he is usually referred to a gastroenterologist. And gastroenterologists should realize that if it is easy to control the drug, then he plans the treatment for both. Otherwise, in the complicated cases, multidisciplinary care is required. There are no guidelines for referral, and I think this is one thing which we can discuss over the question answer session. I will summarize by saying, since my time is up, I'll not really summarize anything. I'll just be repeating what I've already said. Thank you very much for your attention.
Questions from the chairperson? Any comments from the chairpersons? We're running a little late. And Ashish,
Yeah.
only one comment, please.
Okay.
We are running late.
How high dose of metformin can be given? Is it same as 3 grams in non-cirrhotic or is it less?
If the
especially
liver
if-
functions are absolutely fine, we can use the normal dose. But as the liver functions start deteriorating, the dose has to be modified. We have to half the dose that is being given, especially for Child's B patients.
So this data on metformin shows that dose up to 1 gram decreases HCC and is recommended its use. But in decompensated cirrhotics, more than 1 gram per day is not recommended. Last please.
Thank you. What is the target blood sugars to be maintained in cirrhotic patient? We know they have a risk of hypoglycemia. So how tight the control should be?
Not very tight, but all the same, the blood sugar level should not be too high also, left too high, because that would increase the risk of all the complications of chronic liver disease.
So 150 to 200 rather than?
Yes, about 150 to 200.
Sir.
Thank you, sir. I think
Thank
we are
you.
running very late. From one teacher, we should now request our second teacher, at least my second teacher, Dr. Acharya, please. Thank you. Thank you.
Sir, can I request you for a picture? I'll invite the moderators and the chairpersons for the next session. Dr. Praveen Malhotra, Dr. Shaukat A. Zargar, can I please request you to moderate this session? Dr. Manoj Kumar Shah, Dr. Gaurav Chawla, Dr. Asim Prakash, and Dr. Nirmal Yadav to please chair the next session.
Sorry, Shaukat, तुम्हारे पहले आ गया. Should I start with your permission or you want to say?
I think we'll go directly to Dr. Acharya, who will be delivering a lecture on plasmapheresis. I have to only say one thing, that since plasmapheresis facilities are available in most of the hospitals in the whole country, I think it's imperative to know that what is the role. I think at the end of the lecture, I hope that he will make us very clear which patient to send to plasmapheresis and what is the benefit out of this therapy. Thank you.
Very difficult note to start with by Dr. Jagar, because I myself don't know the answers. And I must at the outset convey my deep appreciation and thanks to Professor Anil Arora, Ashish, Praveen, and the whole organizing team to have invited. And plasmapheresis or removing the various toxins, various antibodies, various cytokines from circulation across the diseases where they are involved in pathogenesis is a very age-old story. And we know in neurological conditions like Guillain-Barré and myasthenia gravis, the circulating antibodies are removed by plasmapheresis. Now, during last 2 decades, we have learned that liver disease, particularly acute and chronic liver diseases, are inflammatory states. And they are associated with multi-organ failures, which causes death. And the pathogenetic mechanism that has been associated with this multi-organ failure is this inflammatory state and the liver damage inducing huge amount of pro-inflammatory cytokines which spills over to circulations and affect, there is a crosstalk on which detailed pathogenesis between liver, kidney, or liver, other organ has not been clarified. Therefore, we don't have many biomarkers in such patients to predict who will develop kidney failure or other organ failure. However, what we know that in such condition, there is a cytokine storm. And you can remove because plasmapheresis is an established therapy. These are the initial days of use of plasmapheresis in liver failure. And the results are absolutely inadequate to take cause a standard of care. I will show you some data. Well, as I told, it has been plasmapheresis or plasma exchange has been predominantly used in liver disease, in serious liver disease like acute liver failure and acute and chronic liver failure, on which some data exist. And interestingly, all these data, whether controlled or uncontrolled studies, shows promise. And that's a good hope because the liver failure, both acute and chronic, you don't have medical treatment or magic treatment to salvage them. They have a high mortality. And we also know that is there a pointer here on the, which to, we also know that only definitive option is transplant, and we also know the organ shortage on that. And particularly when this is necessary for patients with advanced liver failure like acute or chronic liver failure. We also know in both acute liver failure and acute chronic liver failure, there are various circulating chemicals like ammonia, various cytokine who are modulator of systemic inflammatory response syndromes, right? Because of various immune, I will show you a cartoon for that, resulting in multi-organ failure. And the hypothesis is plasmapheresis, high volume plasmapheresis, and recent studies in standard volume plasmapheresis. They remove this modulator, which spills over, and therefore may prevent multi-organ failure and death. In fact, if you see the EASL and INSL ALF guideline, in 2017 and 2020, you will be surprised to see the early high volume plasmapheresis in acute liver failure particularly has been strongly recommended as the grade 1 evidence level of 1, and grade of recommendation is almost 1. Because based on one single randomized controlled trial done by the European group, particularly in UK, Finland, and Copenhagen. However, there are many randomized, non-randomized control studies. When the patient becomes sick, you don't have organs. Many centers subject them to plasmapheresis, and later on, retrospectively, they have analyzed. And many of these studies do not have comparator groups to make a meaningful conclusion. Few of these studies which has a comparator group, which are not randomized, indeed in comparison shows that they have a survival benefit. In acute and chronic liver failure, in contrast to acute liver failure, the evidences are less robust. But well, the promise is there in this uncontrolled study. There had been one Chinese controlled study in an HBV reactivation is acute and chronic liver failure, where is shown the survival benefit. Now, I was telling about the cytokine storm. Now, this is a cartoon, looks complicated, not very. You see, there are red and there are the other colors. The red mark, red things are the cause of pro-inflammatory cytokine. If you see first with the liver damage, hepatocyte death, here, 1, I have written, you release various DNA. And you know, DNAs are covered by histone proteins. And this is a high mobility group B protein, which is very important protein. These are chaperone protein for the DNAs, which helps in their replication, in their transcription. And they are a form of cytokine, which is binding site to macrophage, neutrophils, and monocytes. to activate them. They are very interesting molecules. And this actually results in both acute and chronic liver failure. And these, when they binds to macrophage and they liberate a lot of pro-inflammatory cytokines, simultaneously, it activates monocytes, which further release pro-inflammatory cytokine and recruit neutrophils, forming a cascade, and neutrophil is further cytokine. Think all your innate immune cells are in response to liver damage, thinking that their foreign molecular pathogen are attacking it by releasing cytokine, because this is a decoy for foreign infection. And this cytokine, when spills over, will call multi-organ failure. You can remove these by high volume plasmapheresis, and this will remove the damage associated molecular pattern which I described. And simultaneously, ammonia, which is cause of cerebral dysfunction, can be also removed. And many other mediators which assist them can be removed. This is the hypothesis. Once they are removed, your tissue regeneration starts. The inflammatory cytokine decreases, other organs get protected. This is pure conjecture and hypothesis. But there are certain initial studies to show the proof of concept. Now, in acute and chronic liver failure, besides this mechanism, it is further complicated by migration of gut bacteria to the circulation, because the liver no more functions as a barrier. As a result of which, this further causes endotoxemia and increased cytokine storm, adding fuel to the fire. So this probably also can be removed by the plasmapheresis. Usually plasmapheresis today in all hospitals uses two forms of vaccine. Of course, the basic principle is the same. They remove the blood from the venous side and remove the plasma by a plasma exchange machine, which remove the formed element by either centrifugation. Depending upon the size, they will settle down and plasma can be separated, or depending on a filter, where you can filter, right, the plasma and separate the formed element, and both are, and then you replace it equivalent amount of donor plasma or fresh frozen plasma. Now, this is the first randomized controlled trial, multicentric European controlled trial, which I want to present in little details to show the proof of concept that indeed it can work in acute liver failure. This was done in 3 centers in UK, Copenhagen, and Helsinki. And they took 12 years to include 180 patients, 92 patients in high volume plasmapheresis group, and about 90 patients in standard medical therapy. And if you see the overall survival markedly better in those group of high volume plasmapheresis than standard medical treatment. Let me remind you that in both groups, they followed the King's College criteria to transplant, and anybody who fulfilled the criteria, they didn't wait, and they subjected them to transplant. However, those who are listed, half of them transplanted and half were not. So half of the patients who indicated liver transplant should be subjected to liver transplant, could not get liver transplant, also had high volume plasmapheresis. In them, the survival was better. Therefore, overall survival in high volume plasmapheresis was good. And the amount of plasma they removed, I found it was very impractical in our setup. About 15% of body weight, that is about average 10 liters of plasma they remove. And you have to replenish same amount of plasma or more plasma. Over 2 to 2.4, this is 2 to 3 days over. There's a large volume of plasma demanding on your blood bag. And if you see those who fulfilled the prognostic criteria of transplant could not be transplanted, in comparison to standard medical therapy, has significantly better survival in that study. So even though they didn't get transplanted, they had a survival. But when they analyzed the further subgroup, those who were transplanted, initially they have an organ and they fulfilled the indication of King's College criteria. In them, high volume plasmapheresis didn't make much difference because they immediately transplanted. And if you see the interval between transplant, least and transplant is about 3 to 4 days only. So they quickly got the transplanted before they got the benefit of high volume plasmapheresis. So they didn't get benefit. But the other group who didn't get transplanted, in them, there was increased survival. And they were predominantly paracetamol, but there were some non-paracetamol. They didn't find any difference. And they also compared early HPV, that is less than 3 days and more than 3 days. They found those who have early HPV has a trend to do better. And in them, the immunomodulators were also less, because in a subgroup of patients, they also tested those hypothetical immunomodulators which are associated with multi-organ failure are changing or not. In fact, they further saw that when they compared both groups, the mean arterial pressure was better. The pressure support were much lesser on day 3. And if you see, the biochemical changes also were documented. And if you see liver specific scores, all improved, right? And they postulated this is because of removal of these vasoactive substances and cytokine substances removal. But they saw the proof of concept. In fact, in 20 patients of high volume plasmapheresis, right, both early as well as late, and about 11 patients of standard medical therapy, they saw that these DAMs, pro-inflammatory cytokine, monocyte activated cytokines, and neutrophil counts all decreased, and in comparison to standard medical therapy. And therefore, in the same study, they provided this proof of concept that you can remove this cytokines from the circulating blood in this serious group of patients and improve their survival. Problem is, the most patients are paracetamol. And there is a long period, 13 years to include, I found 180 patients in 3 centers where paracetamol-induced acute liver failure is very high. Therefore, I suspect, even though they were randomized, there are many patients in between were excluded. So my question was the select cases. Interestingly, lactate, which is a very important, I didn't give the data, of prognosis didn't decrease. And average in many centers, about 20 liters, 10 to 20 liters plasma were given over 2.5 days. Now you must understand our resources. Third thing, I didn't get any information on whether early HPV, where they're transplanting, is masking the transplant indications and therefore delay the transplant, because you saw the transplant gives benefit. And if you delay, they may succumb without a transplant. So we have to divide prognostic marker on this patient of high volume plasmapheresis will survive with this therapy, like medical therapy will survive, which is develop prognostic marker, and who will survive on plasmapheresis. And the probability of sepsis, hemolysis, hypothermia, removal of antibiotics and antifungals has need to be further clarified. But however, based on this has been recommended as evidence level 1 and grade recommendation 1 by both INSL as well as EASL recently. Now, if you see the other studies, there are many uncontrolled studies which I have mentioned here, right, in combination. Problem is interpreting them. Most of them are, as I told, retrospective, and therefore select cases and small numbers. Etiology is mixed. Comparator groups are missing. Plasma exchange regime is different, not uniform. We don't know. They have used at random and sometimes has combined with renal support system or hemoperfusion system. And duration at will is very unclear, and amount of plasma given depending upon availability. So very difficult to comment. But overall the result, if you see, all results shows there is a biochemical improvement and there was improvement in survival, right? And etiology specific studies were lacking. Despite all this lacuna, the promise was there, promise is there. This is the Indian study from ILGPS by Rakhi. She took 20 patients because we cannot afford high volume plasmapheresis. She used normal Boswell, that is about 5 liters per day over 2 to 3 days. And she showed that indeed there is a good response, and they are all viral hepatitis patients, right? And they were all sick patients. You see, they had advanced encephalopathy, AKI, right? High ammonia level, high INR level. And they also show that cerebral edema, there was hemodynamic improvement, lactate improved, ammonia improved, INR improved, and cytokine also improved, and survival also improved. This is a viral hepatitis. There was predominantly paracetamol, 2 RCTs in acute liver failure, which showed benefit. But for that, in a liver unit, you have to develop a plasmapheresis system to do it regularly. And which is, I know, in most of the center is not available. So the transfusion services has to be now tied up very effectively because there's a large number of patients and can be tried in others to see. The meta-analysis of uncontrolled study indeed shows this promise as well of plasmapheresis. And if you see, this is a recent report which evaluated all form of liver support system, right? And did a meta-analysis. And these are the data. So these are actually 12 studies they included. And all the 12 studies have used various liver support system, right? And patients were also non-homogeneous. And 12 studies had comparator, not randomized comparator. If you see, this is all form of, MARS, high volume plasma exchange transfusion, extracorporeal liver acidic charcoal hematopoiesis, biological detoxification using ion exchange reagent or charcoal columns, which are used in MARS. And maximum trial has been in MARS and biological detoxification. Therefore, the lines are thick, right? And they have the maximum studies. So therefore, the result, if you see, very falsely, that biological detoxifier has a better result in comparison to other, but high volume plasmapheresis is equally good. But if you see the strength, the yellow is bias of all these studies. See the yellow. And plus is, right, very low quality, very heterogeneous, very unhomogeneous patient. None of these studies fulfills the scientific criteria to be used except high volume plasmapheresis. That's the only, this analyzed all studies that has been published till now. And in ACLF, there is no proper randomized control. There are about, I found there are about total 15 studies, right? There are 10 cohort and 2 case series, and all Chinese studies, mostly HBV reactivation. No study used high volume plasmapheresis. Most studies use 2 to 4.5 liter plasma exchange, not 15% of the body weight. And no sessions were, most number of sessions were non-uniform, as they liked it. But they have combined also with other support system, but they showed improved survival, right? And this is one study in Chinese studies where they showed indeed there is an improved survival, not only on short term, they found in a long term, 5-year survival, also better amongst those who were supported in plasmapheresis. But this has never been repeated. And they found in a multivariate analysis, along with the other factor, plasmapheresis was important variables for determinant of survival. And the meta-analysis also shows that there may be marginal better effect of plasmapheresis in such patients. Question is whom to give? Dr. Jargar asked very clear questions. How to select this group of patients? Who needs plasmapheresis? You have acute liver failure, acute and chronic liver failure. You have your prognostic marker at the baseline for both and for ACLA between 7 to 10 days, both ESL as well as APSL. Now, you are developing this prognostic marker for liver transplant. Those who fit in, they should be transplanted, otherwise mortality is very high. The other group, you may continue with medical therapy. But in ACLF, the game is a different game. All patients who survive, again, have cirrhosis, and ultimately within 1 to 2 years, they will die without a transplant, right? In them, plasmapheresis will be a bridge, right? When acute liver failure, whether plasmapheresis is a cure, because liver transplant is a swap, because there's another disease you are giving. That is a big question. The big question is whom to give in acute liver failure. And you saw the data. It is early high volume plasmapheresis, which is beneficial, then the late. If you do early, by day 3, according to our prognostic model, we decide. But if you subject them to early, within first 3 days, you don't know, right? Whom to transplant, whom not to transplant in the process. So we need to refine this further, right? What we have got, Dr. Jargar, to your question, that plasmapheresis helps. It improves survival. It probably prevents multi-organ failures, right? People have done trials, but whether first line of care, when to use it, is not clear, and we need more study to clarify that. So in summary, I will say plasma exchange has provided the proof of concept that high volume plasmapheresis, and one Indian study shows even standard volume plasmapheresis can be a therapeutic option to improve survival in both in acute as well as acute and chronic liver failure. Question is, can it be standard of care? I discussed the gaps and the problems, and therefore maybe more refined, properly designed study to answer this question, that at hospitalization, whom to offer plasmapheresis, whom to not. We need dynamic models for that. And we have to devise this, and prognostic models on HPB, we have to find out. And for now, plasmapheresis, I say, performed in the randomized control trial with stratifications, using baseline prognostic markers. And in them who are likely to die, in them plasmapheresis should be offered first to see whether there is improvement survival, because as such, in acute liver failure, say 40 to 50% you survive, and with plasmapheresis you get in another 20 to 25% from the other group who need transplant, you have a 75 to 80% survival. So that is a refinement you need, right? And resources of this therapy will remain a constraint. Therefore, I have written the last line, miles to go before we probably decide, and it will be still now will be further refined. Thank you very much.
Thank you very much. I think probably were lost a lot of time. 4 minutes extra by Dr. Acharya.
Sorry?
4 minutes extra.
4 minutes extra?
Yes, yes.
I'm so sorry.
So I think probably the message is very clear that I remember the first report came in the 70s about this therapy for liver disease from Japan. I think down the train, when almost 50 years, I don't know when that study will be done. Probably message has been that it may be beneficial, but we're not very clear. Thank you very much. Want to make, okay, one comment.
What do you think?
It's a very nice talk as always. So I think I just wanted to add on that we just finished a randomized control trial on ACLF, uniform group of alcohol associated ACLF. And this is accepted now in Journal of Apheresis, so should be available very soon. So this was a small group of around 30 patients, 15 in each arm. And as you rightly said, many of our patients do not have prospects for liver transplant. So what we chose was, based on the ARC score, a moderate kind of ACLF, those who did not have prospects for liver transplant, kind of, one group we gave the standard volume plasmapheresis and the other was standard medical treatment. We could show the reduction of cytokines, improvement in MELD and the ARC score, but there was no difference whatsoever in the 30-day and the 90-day mortality.
That's a big problem in ACLF. You see, Ajay, you understand ACLF is different. ALF is different. Acute liver failure, you have a naive liver. Your other organs are fine. In a cirrhotic liver, which has suddenly deteriorated, it is a long-standing hemodynamic changes. Now, you don't expect to make a remarkable difference in them unless you replace, give them a new organ. That's very clear. You may use it as a bridge to transplant. Now, somebody will ask me, sir, what the hell? Why the cytokine let it go down, right? Let the endotoxin go down, let the ammonia go down, let the bilirubin go down, let the INR improve, but patient must work out, no? If the patient doesn't work out, what will do with all this INR and cytokine? That's the big question we have to answer.
Thank you very much, I think, Dr.
Thank you.
Acharya.
Thank you
I think you'll all agree with me that he reviewed the whole topic very nicely and gave us account. I think final decision is all of us with the clinician. Thank you very much.
Sir, can I request you for a photograph, please? Sir, in the center of the stage. For the next session, can I please invite Dr. Sitaram Chaudhary and Dr. Pankaj Puri to please moderate this session. I would also like to invite Dr. Bhavesh Thapa, Dr. Marina G. Bhattarai, Dr. Balwant Singh Gill, and Dr. Pratim Pradhan to please chair this session.
May I request Dr. Sanjay K. Satapathy for talk on immunotherapy for hepatocellular carcinoma.
I would like to thank Dr. Arora, Dr. Ashish Kumar, and Dr. Praveen Sharma for this opportunity. I've been asked to talk immunotherapy for hepatocellular carcinoma, recent updates. How do I move this? I have no conflicts of interest or financial disclosures pertinent to the contents of my presentation. So liver plays a very important immunoregulatory role. The arterial and the portal blood supplies expose the liver to many gut pathogens. The vasculature contains specialized immune cells, including macrophages, liver sinusoidal endothelial cells, natural killer cells, and the innate T cells. Along with the liver lymphocytes, the liver sinusoidal endothelial cell plays a very important role in the innate immune response to viruses, bacteria, as well as tumors. However, the liver also encounters a number of non-pathogen antigens from food, damaged cells, bacterial degradation products, leading to promotion of tolerance over immunity. In chronic liver disease and cirrhosis, there is inflammation and immune dysregulation. This immune dysregulation is pretty common and leading to high predisposition for infection. The precise mechanisms behind immune dysregulation in chronic liver disease vary based on the underlying etiology of the liver disease. However, the general characteristic is shared. There is a general characteristic that is shared in the cirrhotic pathophysiologies. There is a pro-inflammatory environment with high level of cytokines, subsequent DNA damage, oxidative stress, and hepatocyte necrosis. And there is structural damage causing compromised cellular function and leading to impaired immune surveillance. Among patients with untreated hepatitis C, hepatitis B, NAS, inflammatory changes will be ongoing. In HCC tumors, they have been shown to include immune cell infiltrates. About 25% of the hepatocellular carcinoma tumors have high inflammatory scores with high level of tumor infiltrating lymphocytes. These tumor infiltrating lymphocytes are associated with a high ratio of CD4 T cells to CD8 T cells. The CD4 T cells are the regulatory T cells, resulting in dysregulated immune response. The presence of the tumor infiltrating lymphocytes is believed to be suggestive of an attempted anti-tumor immune response. However, the immune response is muted due to abnormal cellular distribution. Here, this figure shows in a patient with HCC, there is a high expression of PD-L1. In addition, there is also high expression of PD-1. This PD-1 and the PD-L1, which is a programmed death ligand 1 signaling, it reduces activation of CD8 plus T cells, resulting in increased immune tolerance. Among patients with HCC, later cancer stage was shown to be associated with a very high level of PD-L1. High PD-L1 expression has been associated with worse overall survival in hepatocellular carcinoma. There is a meta-analysis, 7 studies published between 2009 and 2016. They have shown high levels of PD-L1 are associated with significantly worse overall survival. Increased PD-L1 expression was also associated with several findings, including worse disease-free survival, higher level of tumor differentiation, more vascular invasion, and higher level of alpha-fetoprotein levels. Systemic therapy in liver cancer has been challenging. HCC tumors are considered to be resistant to systemic chemotherapy due to increased expression of resistance genes that has been identified in these tumors. Fibrosis and cirrhosis impede the blood flow to the tumors. Systemic chemotherapy may be poorly tolerated in patients with a liver disease. Unlike other solid tumors, there is very few druggable targets that have been identified by genetic characterization. With this background, immunotherapy gives us a big hope. The approach are multiple. There are 2 main approaches of immunotherapy: boosting existing immune response or stimulating de novo immune response. In order to boost existing immune response, there are 3 different options has been identified. One is checkpoint inhibitors, and which we'll elaborate a lot today, blocking inhibitory cytokines and vaccine and oncolytic viruses, and stimulating de novo immune response. The options are antigen targeting antibodies and adaptive cell therapies. In adaptive cell therapies, where T cells are transferred from either from a donor or from the patient itself. It is cultured in increased numbers, they're modified, and they're retransfused to the patient to have an anti-target effect in the tumors. Immune checkpoint inhibitors, they activate the immune system. How does it do? If I draw your attention to the figure, here there is a tumor cells on the top, and here is the T cells. Now the tumor cells is expressing PD-L1, and they bind to the PD-1, and this makes the tumor evade the immune response. Now, if you block this PD-L1, by blocking the PD-L1 or the PD-1 leads to recognition of the tumor cells by the T cells and leads to tumor cell death. So this is the fundamental principle behind treatment with the immune checkpoint inhibitors. There are 2 forms. One is of checkpoint inhibitors. One is the PD-1 and PD-L1, and other one is CTL4. And there are other checkpoint molecules that also has been identified. So this activation can then recognize the cancer cells and target them to cell-mediated cytotoxicity. I'm now going to elaborate the current use of immunotherapy in hepatocellular carcinoma over the last few years that has been identified. The first one is the Keynote 240 trial. This is pembrolizumab for patients with previously treated hepatocellular carcinoma. 2 trials came out. The initial was the phase 2 trial, where there's an open label single arm trial, and the overall response rate was 17%. And a Keynote 240 randomized double-blind phase 3 trial, where the patients with advanced hepatocellular carcinoma, intolerance to or progressive disease on or after sorafenib were included. They were all Child's Puget, BCLC stage B or C with a good performance status without any invasion to the main portal, where 413 patients included. They included pembrolizumab 200 milligram to 78 patients versus placebo with the best supportive care. And their co-primary endpoints were progression-free survival and overall survival. And they have pre-specified statistical significance. And the secondary endpoints were overall response rate, duration of response, disease control rate, time to progression, and the safety analysis. Interestingly, they failed to reach the pre-specified level of statistical significance for both overall survival and progression-free survival. However, overall response rate was significantly higher with the pembrolizumab versus placebo, and median duration of response was 13.8 months with the pembrolizumab. Pembrolizumab is approved for use as a second-line hepatocellular carcinoma treatment based on phase 2 data. However, phase 3 trial did not reach pre-specified co-primary endpoints. CheckMate 040. nivolumab for advanced hepatocellular carcinoma. This is again, initial open label phase 1 to 2 trial in adults with hepatocellular carcinoma with a child poor class A and B7, and they include an escalation phase and a class A patients with expansion phase with the good performance patients. They have 3 groups without viral hepatitis and Hep C and then Hep B groups. And then there is a group with an dose expansion phase. With this, they established some safety and tolerability, and they advanced to the CheckMate 459, where they compared nivolumab versus sorafenib as the first-line therapy for advanced hepatocellular carcinoma. This is an international open-label randomized phase 3 trial. The minimum follow-up was 22.8 months. Adults with advanced hepatocellular carcinoma ineligible or progressive disease after surgical or local regional therapies were included, all child's A and ECOG 0 and 1. Primary endpoints or overall survival, they have predefined threshold for statistical significance, 371 patients compared to 372. Until progressive disease, unacceptable toxicity, or consent withdrawal, they were continued. Again, the predefined threshold for statistical significance for overall survival with nivolumab was not met. Although nivolumab demonstrated clinical benefit, the overall response rate with nivolumab was 15% compared to sorafenib. So it did show benefit, but did not met their statistical significance. So nivolumab is also approved for use as a second-line hepatocellular carcinoma treatment based on phase 2 data. However, phase 3 trial fails to reach the primary endpoint. The most important trial that came out is the IM-Brave 150. Is a game changer. Atezolizumab plus bevacizumab versus sorafenib for first-line treatment of hepatocellular carcinoma. It's a multi-center randomized open-label phase 3 trial. They're randomized to atezolizumab bevacizumab combination, 336 patients with sorafenib, 165 patients. They included all child's A patient, good performance status, and unresectable hepatocellular carcinoma, and patients with locally advanced and metastatic disease, treatment until progressive disease or intolerable toxicity. Co-primary endpoints again were overall survival and progression-free survival. 40% of the patients included also had macrovascular invasion in this study. This study have a significant benefit. Overall response rate was for HCC specific, modified RECIST with the atezolizumab bevacizumab combination was 33.2% versus 13.3%. Complete response was 10.2% versus 1.9%. And you can see overall survival on the figure on the left, 85% versus 72%, and 55% versus 37% progression-free survival. Quality of life also was significantly better, as you can see in this diagram. And the safety was also compared to the sorafenib was very well tolerated. Diarrhea was one of the most significant side effects, hypertension. And one other thing that is highlighted when you are using atezolizumab bevacizumab is the bleeding risk. Upper GI bleeding rate in the combination group was 7% versus 4.5% in the sorafenib group. And this was consistent with historical data using bevacizumab for hepatocellular carcinoma treatment. Some of the key warnings using atezolizumab and bevacizumab combination is number 1, immune-mediated pneumonitis, hepatitis, colitis, and endocrinopathies. And also remember, these patients included were patients child class B and C cirrhosis or prior organ transplant were excluded in this study. So this has not been recommended to use with this. And bevacizumab also has some warnings, especially GI perforations. And if patient had a surgery within the last 28 days or incompletely healed wound, that are not recommended. And recent hemoptysis, variceal bleed, fistula, uncontrolled hypertension, proteinuria, and congestive heart failure is not recommended. So NCCN guidelines recommend atezolizumab and bevacizumab as the preferred option. Although there are other first-line options, sorafenib and lenvatinib, which are the TKIs or the tyrosine kinase inhibitors. But there's only immune checkpoint inhibitors that has been approved for first-line therapy is the atezolizumab and bevacizumab combination, and not only approved, it is approved as the preferred option. The second-line options are numerous. We have the 2 TKIs, regorafenib and cabozantinib, and ramucirumab, especially in AFP more than 400, which is an anti-VEGF monoclonal antibody, and the 2 other immune checkpoint inhibitor that is approved as a second-line treatment is nivolumab and pembrolizumab. And beyond that, we do not have good options, and there are several trials the patients can be referred to, and the best supportive care is the only option in those patients. So what are the emerging immune therapy in hepatocellular carcinoma? So first, combination of checkpoint inhibitor studies are underway. Combination therapies with anti-PD-1, PD-L1 antibody, and anti-CTLA4 antibody simultaneously has been shown to increase the activation of CD8 plus cells and increase the number of activated CD8 plus cells in the tumor. Here in the figure, you can see that there is the tumor cells where you have the tumor cells releasing the cancer cell antigen that are presented to the APCs. And now, when they're presented to the APCs and they're recognized the T cells, these T cells now, once they're blocked with the anti-CTLA4 antibody, they can be trafficked and they're homed into the tumor cells. And they're increasingly recognized when you combine with the anti-PD-1 and PD-L1 antibody with a better immune response. So here are some of combination of the immune checkpoint inhibitors with other systemic therapies that has been underway, or some of them has been already in the market. Now, if I draw your attention here, in the center, we have the anti-PD-1 and PD-L1 inhibitors. And here is the durvalumab combination with tremelimumab, which is a CTLA4. So it's a combination of PD-1, PD-L1 inhibitors with CTLA4. Then nivolumab in combination with ipilimumab. Then atezolizumab and bevacizumab combination already talked about, which is already in the market, and sintilimab and bevacizumab combination. And there are TKIs, lenvatinib and the cabozantinib, the multi-tyrase kinase inhibitor in combination with immune checkpoint inhibitors are also underway. So these are the key ongoing phase 3 trials with immunotherapy combination for the first-line treatment of advanced hepatocellular carcinoma, the LIP-002 in combination with the lenvatinib, which is a TKI with the pembrolizumab, which is the immune checkpoint inhibitors comparing lenvatinib. Then Himalaya trial, which is a durvalumab in combination with tremelimumab versus sorafenib. Then the Cosmic 312, which is a cabozantinib, which is a TKI, again, combination with atezolizumab. And then nivolumab in the checkmate 9DW, nivolumab with ipilimumab combination. I'm going to go over a little bit on those trials, some of them important results. The Himalaya trial, which is a combination of this durvalumab, which is the CTLA4 inhibitor, the immune checkpoint inhibitor, and the tremelimumab, which is the CTLA4 inhibitor, has shown to improve survival compared to sorafenib. In this, there is a single dose is given, single dose of tremelimumab, then followed by monthly durvalumab, and they found the combination they tried has shown 20.1% overall response rate versus single agent 17% durvalumab versus sorafenib only 5.1%. Checkmate 040, which is a combination of nivolumab, again immune checkpoint inhibitors with ipilimumab, which is a CTLA4 antagonist for advanced hepatocellular carcinoma. They used variety of combinations, different arms, which is the nivolumab 1 milligram with ipilimumab 3 milligram every 3 weeks, and then nivolumab 3 milligram with ipilimumab 1 milligram Q3 weeks versus nivolumab 3 milligram every 2 weeks with ipilimumab every 6 weeks. So different combination, they used it, and they found the best combination was the arm A, which is the combination of nivolumab of 1 milligram with ipilimumab 3 milligram every 3 weeks in this study. Immunotherapy and the combination of the TKIs, why this is beneficial. What has happened in TKIs have been shown to lead to upregulation of PD-L1, and the concurrent inhibition of PD-L1 may delay resistance and extend survival. So complete inhibition of the survival pathway is difficult with monotherapy due to the presence of alternate survival pathways. So when you combine with immune checkpoint inhibitors, you may get a better result. And the reason for this is in this figure. In the figure you see in the upper panel, you have a normal blood vasculature and the abnormal vasculature in the tumor cells and normalization of the vessels once you use TKI. So the normalization, because in the impaired tumor blood flow may facilitate immune evasion by the tumor cells. So when you normalize with the TKI, you improve the blood flow of the tumor that may enhance the outcome of the immune therapy. And this is, the TKIs may modulate the immune microenvironment and may impact response to immunotherapy. I'm not going to go through the detail. This is an animal experiment that have shown in mouse models, low dose of sorafenib was shown to activate CD8 T cells and decrease myeloid-derived suppressor T cells and regulatory T cells. These changes could inhibit tumor growth and reverse immune response. LIP-002 trial that has evaluated lenvatinib, again a TKI, and pembrolizumab, which is the immune checkpoint inhibitor. Again, they have found the median progression-free survival 9 months and overall survival of 22 months. So beyond this combination of immune checkpoint inhibitors, TKIs, and all these therapies, what are the other strategies that has been evolving? Immune checkpoint inhibitors can be combined with potentially curative therapies such as ablation or resection, local regional therapies like TACE, or systemic therapies. And depending on the disease stage, early, intermediate, and advanced, this combination can be used. So there is benefit of this combination. Immune characteristics have been identified as risk factors for recurrence following resection and ablation. Both the immunoscore, which is a measure of the densities of the CD3 plus and CD8 plus cells in the tumors, and PD-L1 expression levels have shown to predict recurrence after resection. Surgery and radiofrequency ablations may alter this immune microenvironment, triggering proliferation of the tumor cells, releasing tumor antigens and stimulating the anti-tumor response, and shifting the balance between pro-inflammatory and immunosuppressive therapies. And here is an example of how it does in TACE. In TACE, local regional therapies have been shown to induce inflammation, increase the level of tumor-associated antigens, and alter activation of the immune cells. This may result in increased anti-tumor immune response from the T cells. However, the immune effects induced by the TACE alone are not believed to contribute significantly to the anti-tumor activity of TACE. So the addition of immunotherapy with the TACE may synergistically improve the immune response and increase the anti-tumor activity. And there are several, and with that, there are several trials currently underway. I just outlined on this slide. Immune-related adverse events, there are many: hypophysitis, uveitis, pneumonitis, adrenal insufficiency, enterocolitis, arthralgia, rash, autoimmune diabetes, pancreatitis, hepatitis, hypothyroidism. There are several of them. The general principles for managing these immune-related adverse events, particularly for hepatitis, that it could be mild, moderate, or severe. Is mild, you can do supportive care, consider holding. Moderate, you can redose if toxicity improves, and you may consider using along with the steroids. Or if it is severe, you have to discontinue. Monitor closely and start high-dose steroids, usually 1 to 2 milligram per kg per day with a slow taper over 1 month. If not improving in 1 to 3 days, then increase the immunosuppression. And this is where we stand in immunotherapy for hepatocellular carcinoma in 2022. The combinations for earlier stages of cancer with these immunotherapies are underway in the trials, but what is available is a combination in the advanced stage of HCC. And summarizing, checkpoint inhibitors targeting PD-1 and PD-L1 and CTLA-4 are active, tolerable, clinically beneficial against advanced hepatocellular carcinoma. At present, the best available first-line treatment for advanced hepatocellular carcinoma is the PD-L1 blockade with atezolizumab and VEGF blockade with bevacizumab. PD-L1 expression has been associated with acquired sorafenib resistance, so combination therapy with checkpoint inhibitors may lengthen the time to progression. There is yet an almost complete lack of suitable biomarkers to guide development of checkpoint inhibitors and their combination. TKIs may modulate immune microenvironment and may impact subsequent response to immunotherapy. Immunotherapy is likely to synergize local and local regional intervention in earlier stages of hepatocellular carcinoma. Other promising forms of therapy, such as additional checkpoint inhibitors, adaptive cell transfer vaccination, and virotherapy are currently underway. Thank you so much for that.
Thank you. Very nice talk, sir. If any, yeah, this is sir.
A nice talk, Sanjay. I think just 2 days back, we were discussing this subject, in the department. And there's a concept of what we call the tumor microenvironment, which is so, important in causation and the progression of any tumor, and in particular HCC, and has a relevance as far as the immunotherapy is concerned. So we discussed 2 issues, and if you can maybe enlighten us on that. In comparison to other malignancies, how is tumor microenvironment different in HCC? Because if you see, immunotherapy works less effective in HCC in comparison to some of the other malignancies, say melanoma and all. So what's there in the microenvironment? That is number one. Secondly, within HCC, the etiology does matter. Even in I Am Brave, if you see, this worked lesser for NASH HCC in comparison to virus, right? So what is, again, the etiology wise also the tumor microenvironment would differ. So these are the 2 very important issues in relation to immunotherapy, number one. The second question to you is about, all the guidelines and even the BCLC, flow would say that use them as a upfront first line treatment. BCLCC not fit for, say, surgery or LRT, go for immunotherapy, metastatic disease. But in clinical practice, we have been doing, patients who have been exposed to, say, TKIs, undergone LRT, and are progressors on that, we have actually used immunotherapy in that. Your experience on that as a second line, treatment regimen.
Yeah, I'll take the second question first. You are absolutely right. The patients who are exposed to sorafenib like TKIs, and I mentioned in my lecture as well, there is an increased expression of the PD-1 and PD-L1 when they're used in these particular patients. And even if they're progressed, now they have increased PD-L1 and PD-L1 expression. When you combine with immune checkpoint inhibitors, lead them to have a better response. So I totally agree with you that approach is definitely a very good approach for treating patients with HCC. And in the first question, I don't know whether there is a good, because they share the same pathophysiologies. The tumor microenvironment, they share the same pathophysiologies, especially in all the liver diseases. I'm not very clear if there is a specific difference in hepatitis B versus hepatitis C versus NAS. There's continuous ongoing inflammation, and the tumor environment are almost the same. Maybe there is a relative difference in terms of the expression of certain type of cells, but not otherwise a specific difference that I'm aware of. Thank you.
Thank you, sir. Thank you. Anything from the chair? Okay. We close this session here. Thank you.
Thank you, sir. We will now be having the inaugural ceremony. There is a slight change in the program. I would request Dr. Anil to please come on the stage.
Good morning, everybody. I hope you are enjoying the academic feast. We are sorry to interrupt the academic session because Dr. D.S. Rana, who is incidentally the chairman of Board of Management at Ganga Ram Hospital, and is the first man in the history of Ganga Ram Hospital who has been elevated to the chair of Chairman, Trust Society of Ganga Ram Hospital. So we are privileged to have him along with Dr. Jayashri Sood, who is the Secretary of Board of Management at Sir Ganga Ram Hospital. And let me reiterate it right at the outset that it is because of the constant, unfettered, unconditional educational grant and the moral support by the hospital authorities of Sir Ganga Ram Hospital that we have been able to smoothly and confidently conduct these regular exercises on CMA and hepatobiliary disorders almost for the last 2 decades. We are lucky to have them over here, and we would like to invite them for a light lining ceremony. Dr. Rana and Dr. Sood, please. Ashish to take over, please.
Thank you, Dr. Arora. I would also like to invite Professor Ajay Duseja, Dr. Ramesh Roop Rai, Dr. K. Narayan Swami, Dr. Sandeep Nijhawan, and Dr. Premashish Kar to come to the inaugural ceremony and for the lab lighting. And Dr. Anil. I would like Dr. Rana to say a few words before.
Good morning to all of you. On behalf of Sir Ganga Ram Hospital, I welcome you all to this academic feast which is being organized by Dr. Anil Arora for the last 20 years. Every year I see very good attendance in this conference. I am for the last almost 10 years I attend. Most of you must be knowing me. I must tell you that the Department of Gastroenterology was started by Dr. S.K. Sama sometimes in late 70s. He worked hard, and later in the 80s and 90s, he introduced and promoted Dr. Ranjit Sood and Dr. Anil Arora take up the reins of the department. Both became shining stars. One star we lost to, I will not say lost, he joined Medanta Hospital and he took over then later on. And he has done really very well. I know the amount of energy he has got, that he has got practice, which he does till almost till midnight. Then he has got a lot of research papers. Such workshops he regularly conducts and takes part in various activities. And at the same time, I'm very proud to say here that his kids also, he's also educated at AIMS, MBBS, MD, and all DM. But his kids are also from there only. And they are also so intelligent, you know. So we are really lucky to have you, Anil, here with us. And Ganga Ram Hospital is proud of you. At the same time, I would like to stress that we at Ganga Ram Hospital, apart from providing ethical and healthcare to all sections of society, we have equal commitment to academics and research. And just to say a few words, that we are the largest center of National Board of Examination, having DNB in nearly 42 subjects, and many courses have been introduced by Ganga Ram itself, you know, which are recognized by National Board, you know. At the same time, we are not only known for something like clinical research, we have got a very well-established department of research, where research is being done at molecular level. And the research department, we funded a lot over the last 1 decade. But I'm glad to see now that almost 70% of the funds of the research department, they are from extramural grants, national and international both, you know. So that sort of commitment we have got for research. And these sort of activities, they are going in each and every department. With these few words, I wish you a great success for this conference, and I hope that you will enjoy this academic feast and share your knowledge over the next 3 years. Thank you very much.
I would like to invite Dr. Jayashree Sood to say a few words before we do the lamp lighting.
Good morning, dear faculty. A warm welcome to all of you from our hospital. Dr. Rana has told a lot about our hospital, and the only thing that I would like to add is about the Institute of Gastroenterology headed by Dr. Anil Arora. Nowadays, a few years ago, we did not have too much interaction with them, but for the last couple of years, we are there all the time, mostly all the time. And it is commendable how many POEM procedures that they do besides other endoscopies and ERCPs. So I would really like to congratulate Dr. Anil Arora and his team for the tremendous work in which they are excelling. And once again, welcome to this program, which of course I have been attending for the last couple of few years, and I'm sure all of you will benefit from it. Thank you very much.
Let me also reiterate over here that it is because of the inherent strength and the confidence provided by the head of anesthesiology, Dr. Jayashree Sood, that we are blatantly able to do POEM procedure confidently in their presence. Because if we think something goes wrong, they are at our back. We already finished around 432 cases of third space endoscopic procedure, and full marks to the constant support and the zeal with which they push us up to do whatever is possible. Thank you, ma'am, and thank you, sir. May I now request Dr. Sandeep Nijawan, who is the president of ISG, Dr. Ramesh Ruprai, Dr. Ajay Duseja, Dr. Premashish Kar to please, and Dr. Narayan Swami to please come and help us light the ceremony.
Dr. Praveen Sharma, my co-secretary, also.
It is such a
सूर्य ब्रह्म शिव विष्णु गजानन जिन चरणों को सेवते सूर्य ब्रह्म शिव विष्णु गजानन जिन चरणों को सेवते हम शिशु है अज्ञानी माता इन चरणों का प्यार दे वीरा पानी तार दे तार दे तार दे माँ सरस्वती शारदे माँ सरस्वती शारदे मूरख हम नहीं जाने जननी पूजन वंदन ध्यान को मूरख हम नहीं जाने जननी पूजन वंदन ध्यान को आदि शक्ति कर क्षमा हमें आदि शक्ति कर क्षमा हमें पूजा के उद्गार दे वीरा पानी तार दे तार दे तार दे माँ सरस्वती शारदे माँ सरस्वती शारदे
Thank you. A special thank you to our chief guest and the guests of honors. We'll begin with the next session. For the same, can I please invite Dr. Premashish Kar and Dr. Ashish Kumar to please moderate this session. Also, can I please invite Dr. Gagan Saini, Dr. Shering Sharpa, Dr. Arvind Gubi, Dr. Ritesh Shesh to please chair this session. Thank you.
I have the pleasure to invite Dr. Sandeep Nijahan, who is the professor of the Department of Gastroenterology at SMS Medical College, to deliver the lecture on the management of HCC. Does the etiology matter?
Good morning, ladies and gentlemen, chairpersons, moderators. At the outset, I'd like to thank Anil, Praveen, and Ashish for the kind invite. The topic for today for me is management of HCC. Does the etiology matters? Then there are no practice guidelines on such a subject. So there'll be, I mean, you all know that liver is a very unique organ. It is a single organ. And HCC occurs mostly in cirrhotic liver. Almost 90% of the patients of HCC have underlying CLD. And management of HCC not only depends on the tumor, but it also depends on the underlying liver dysfunction. So as far as management of any tumor, may it be other tumor or HCC, we want to prevent the tumor. That is prevention of HCC, which is often neglected in clinical practice. Then if there's occurrence of the tumor, We have to treat that. And then prevention of the recurrence of HCC post-treatment. As far as etiology of hepatocellular carcinoma is concerned, we have common ones, which actually include almost 90% or more. Chronic HBV infection in the eastern part of the world. Then we have HCV infection again in this part of the world because it is almost on the cure on the western side, and we are also reaching to that. Then we have got NFLD, which is presently the commonest cause in the Western world, but it is closely taking over the world over. And then we have alcoholic-related liver disease. So all these 4 diseases are actually combine and take more than 90% of the brunt. Then we have other etiologies, hereditary disorders, Wilson's disease, hemochromatosis, alpha-1 antitrypsin deficiency, glycogen storage disease, and association with ataxia telangiectasia. Then we have other diseases like autoimmune liver diseases, membranous obstruction of the IBC. Cigarette smoking is actually associated with tumors all over the body, including liver. The chronic OCP use and alpha-1 toxin B1 exposure can also lead to. As far as chronic HBV infection is concerned, it is the most common cause of hepatocellular carcinoma in the developing world, especially in Southeast Asian countries. Hepatitis B virus actually integrates into the host DNA, that is CCC DNA, and that leads to mutation and causation of HCC. But at the same time, HBV infection leads to chronic inflammation, chronic hepatitis, regenerative nodules, and HCC, and there also it plays a part to cause hepatocellular carcinoma. So there are multiple pathways to cause HCC in hepatitis B infection. Then available antivirals actually, they have a role to inhibit the activated part of the hepatitis B, but it doesn't affect the integrated part of DNA. So it does take care of the chronic inflammation, thus by reducing with the antiviral therapy, and may have a role in prevention of HCC. So what all can be done to prevent HCC in a chronic HBV patient? That means a known patient is there of chronic HBV. We have to regularly monitor his DNA level. We have to do LFT. We have to do fibroscan just to see that there is a progressive disease, there's a ongoing chronic inflammation, there's a replication on the basis of DNA, and that helps in early detection and use of antivirals. And by using these antivirals, we can control the hepatic insult, we can control the inflammation, hence prevent the occurrence of HCC. Management of HCC, once it occurs, in a case of HBV infection, it is standard to any HCC treatment, depending on the size, the numbers, whether you subject these patients to resection or they go for transplant or they go for just a supportive therapy, or as have been mentioned in the previous talk, that we can go to actually immune therapies in these patients. Prevention of recurrence of HCC after transplant is also very important. Recurrence of HBV infection post-transplant can occur almost 50% in a cumulative 2-3 years time. And post-liver transplant antivirals will prevent chronic inflammation in the HBV graft, and hence it prevents the HCC recurrence at the same time. And subjects who receive HBIG in the early course and antiviral for a long time in a perioperative period thereafter prevents the development of chronic HBV infection post-transplant and subsequent HCC. As far as HCV infection is concerned, the incidence presently is mainly in the developing countries, but there also the HCV infection is decreasing, and prevention of development of HCC in HCV infection is by direct antiviral agents, which are being given for curative intent, and they are to be administered in all patients where HCV RNA is detectable in spite of even normal LFTs. So you give treatment and you cure these patients and you prevent development of chronic complications like HCC. As far as management of HCV related SCC is concerned, direct antiviral agents, even after development of SCC, decreases the progression of SCC and may actually downstage it. That means by giving a direct antiviral agents, we cure the SCV infection in the setting of SCC, and thereby we improve the liver functions, we improve the MELD score in these patients, and we downstage the SCC. And it has been shown by downstaging this, there is an improvement in survival indirectly in these patients. And direct acting antiviral agents decrease the incidence of decompensation of cirrhotics. Hence, one may opt for a lesser invasive procedure. That means in a decompensated patient with SCC, where you can't give treatment for SCC, but once you actually improve the decompensation, maybe you can give some treatment of to these SCC patients. Prevention of recurrence of SCC in post-transplant setting in SCV patients. That means if there is a recurrence of SCV post-transplant, direct antiviral agents can be given. Direct antiviral agents should be given if pre-transplant SCV RNA is positive. There is no doubt about it. And as it prevents the infection of the graft, it decreases the incidence of cirrhosis of the graft and the recurrence of HCC post-transplant. As far as NFLD is concerned, it is actually the most common cause of HCC in the West. It will soon surpass HBV infection in most of the areas of the world and will become the first cause of the hepatocellular carcinoma. So prevention of cirrhosis and HCC is very, very important. Prevention is the best modality to for the treatment. So it has been shown that moderate intensity exercise and weight reduction has been shown to decrease the progression to HCC of NFLD, and statins by their anti-inflammatory action have a favorable action on the lipid profile, might decrease the occurrence of hepatocellular carcinoma in future. Metformin, again, it inhibits the mTOR pathway, which gets activated in patients of hepatocellular carcinoma, so it might decrease the incidence of HCC in NFLD patients. Optimized control of diabetes, it will improve steatosis, further inflammation, and ongoing to cirrhosis and hepatocellular carcinoma. The problem is the non-cirrhotic HCC. They usually present late because they are asymptomatic in the course of the disease, and there is no monitoring and screening in NFLD patients, those who are asymptomatic. So there has to be a formulation of a surveillance strategy in patients where there is a direct conversion of patients of fatty liver going to HCC, though the incidence is not that common. Management of HCC in NFLD patients, again, there should be a standard management guidelines for as for any other hepatocellular carcinoma after development. And prevention of recurrence post-transplant, this is very important because there has to be continuation of lifestyle modification, which will be beneficial for the post-transplant liver, and it will prevent other comorbidities also. But weight reduction, control of diabetes, dyslipidemia, continuous physical activity, that is little difficult in these patients because of associated comorbid conditions. So the overall prognosis, again, post-transplant in patient with HCC is poorer than other etiologies because of the associated significant comorbid conditions. Ethanol-related HCC, it is a neglected fact that alcohol is a recognized carcinogen at the dose of 10 grams per day, but the data is scarce, but the worldwide alcohol contributes to almost 30% of all HCC cases. Alcohol-related HCC have more liver function impairment because of the associated severe liver dysfunctions. They present with advanced stage. They have a larger tumor. They are multifocal and are associated with portal vein thrombosis. There's adverse prognosis of alcohol-related HCC because of the poor surveillance, poor patient compliance, their delayed cancer detection in these patients, and less frequent access to the curative therapies. Prevention of HCC, again, in the setting of etiology of alcohol, there should be education regarding chronic alcohol non-use, medical treatment. There should be involvement of the society for such implications. Abstinence leads to regression, fibrosis, and cirrhosis to some extent. So if there is abstinence in these patients of cirrhotics, even we can actually prevent formation of HCC in these patients. Management of established HCC, alcohol abstinence reduces the chronic inflammation and hence decompensation. So as is important in HCV infection, HBV infection, where with the antiviral therapy, we reduce, we make the liver functions better. Same is with the alcohol abstinence. And abstinence for 6 months helps in listing these patients for liver transplant. And prevention of recurrence post-transplant, essential to stop alcohol, because post-transplant there can be recurrence of the disease, and at the same time alcohol interferes with the immunosuppression effect, suppresses metabolism also. As far as other etiologies are concerned, autoimmune liver disease, it's a rare cause of HCC. There is prevention of HCC in these patients if they are on immunosuppressants, as it controls inflammation, decompensation, and development of HCC, and continued immunosuppression will decrease the incidence of HCC post-transplant. Immunosuppression prevents the early detection of residual HCC cells, and sirolimus is thought to have anti-proliferative activity. So even these long-term immunosuppressive therapies in a patient post-transplant autoimmune liver disease does help. And recurrence of autoimmune liver disease to the tune of 30 to 50% in a cumulative time complicates the post liver transplant course. Wilson disease, again, rare disease, data is not much. And early detection of the disease, chelation, decreases the chronic effects of copper on the liver, resolve inflammation, progression of cirrhosis and HCC, and liver transplant in the setting of acute liver failure, decompensated cirrhotic, actually corrects the genetic defect. Hemochromatosis, chronic inflammatory iron accumulation causes oxidative stress and hence hepatic inflammation leading to cirrhosis and HCC. Treatment is safe and effective, but early recognition plays a key role. But these are the poorest population to survive post-liver transplant because of the secondary effects of iron on heart, and there are more frequent infections and the risk of recurrence. Alpha-1 antitrypsin, actually rare etiology, no treatment available, liver transplant is cured. Alpha-1 alpha toxin B1 toxicity, prevention is by maintaining hygiene and cleaning grains before the consumption, and no recurrence of HCC post-transplant. So I'd like to conclude by saying that HCC management is dependent on the liver dysfunction measured by MELD score. Treatment of etiologies of HCC does improve the liver dysfunction. Early treatment of etiology may prevent hepatocellular carcinoma. And if we go to the etiology, even they may help out in preventing the development of hepatocellular carcinoma. In HBV and HCV related HCC, antiviral are very important along with the treatment of HCC to prevent reinfection and recurrence. In ALD and NFLD related cirrhosis, there is a deficient surveillance and they present late with a poor prognosis as compared to HCV and HBV related cirrhosis. So it is an unmet need for active surveillance in this special subgroup. Risk of HCC is low in autoimmune disease. Recurrence of autoimmune disease occur almost 30 to 50%, complicating the post-transplant course. Thank you for your kind attention. Thank you.
Thank you, Dr. Nijaman. So we can have few questions. I would start the ball rolling. What is the contribution of diabetes in causation of HCC in isolation as well as in combination with other etiologies? So, and should we have a different surveillance strategies when patients?
You see, diabetes comes into a part of metabolic syndrome. So there is a common association of NFLD and diabetes in these patients. It is the commonest cause of NFLD going to NASH and cirrhosis and HCC. And as this is one of the important etiologies for HCC, and the behavior of these patients post-SCC treatment is worse than other etiologies because of the associated other comorbidities which do occur with diabetes.
Congratulations, sir, for the excellent presentation. Sir, how do you manage the patient with hepatitis C virus-related SCC who has presented for the first time in advanced or terminal stage?
You see, actually, SCC, those who present with HCV-related cirrhosis, advanced liver disease, if their performance status is not good, then we have to keep this patient on supportive care and treat HCV infection if it is associated. It has been shown that giving direct antiviral agents in these patients will improve the liver functions. It may actually downstage the liver functions, and they may go to a stage where you can provide them a loco-regional therapy or chemotherapy.
Sir, do you start chemotherapy at the same time, or what you do for the HCC?
You see, actually, for giving chemotherapy in these patients, the MELD score should be good, their child status should be good, and if they are in advanced stage, we'll try to actually improve the liver functions first, and then we may combine it with antiviral treatment, anti-chemotherapy.
Thank you, sir.
Very nice talk, sir. So we know that NASH is becoming a very important cause of HCC now. So the issue is the occurrence of HCC in a non-cirrhotic background in NASH. So what should be the strategy for surveillance, and how do you manage such patients now?
Yeah, actually, it's a very difficult question to answer because, you know, these patients from NFLD without going to cirrhosis can go to HCC. So they will not travel to cirrhosis and HCC. So they are difficult to catch up. These are one of the proposed causes of etiology of cirrhosis in a patient where the etiology is not known. So difficult to catch these patients. So surveillance is very, very difficult in these patients. But these subgroup are very important as it's actually, you know, epidemic disease. So even a small percentage will have a greater part.
Sir, do you see, of late they have seen a phenomenal rise in the number of patients with NAFLD without an HBV or HCV. Does nutrition has got a vital role in preventing HCC?
See, actually, there is a study from Korea where they have compared 3 types of diets. One was vegetarian diet, and one was vegetarian with combination of meat and only meat. And they have shown that the occurrence of cancers, other cancers also, it's not only this liver cancer, but it is lung cancer as well, the other cancers like stomach cancer also. And they have shown that a vegetarian diet does help in preventing carcinoma and also of liver.
Excellent talk. And just wanted to proceed further. Ashish's question that de novo development of diabetes is high in HCC patients. So does it modify the course of the disease and how they should be handled?
Yes, actually, these patients of diabetes, they will have adverse effects on heart, they will have adverse effects on kidneys. So whenever actually managing these patients, kidney is very important, heart is very important. So other comorbid conditions do occur with diabetes. So I think it has, these patients have a little worse prognosis than patients who do not have diabetes. So little more care is required if we are treating HCC in a patient who is diabetic.
Last question. Sir, average year of conversion between HBV, HCV, and NAFLD to HCC, what is the average year? Does it take? Is it all relatable or different of all the 3?
Is all etiology should be different, and among the 3, you see, there are no prospective studies which have shown, but according to me, the fastest should be B, C, and NAFLD. Right?
Any comments from the chairpersons?
Was wondering, as an oncologist, that is there any study which kind of definitively tells us that treating the etiology along with the HCC definitively improves the outcomes? Just wondering, while it is empirical to do so, it's quite empirical to do it anyway.
You see, once there is development of HCC, that means that tumor has already developed. Now, after the development of HCC, what you require is to give them treatment for HCC. But there are patients of HCC where you can't give treatment because of bad liver function, and their prognosis becomes poor post-treatment also. So by giving treatment for etiology, what you are doing is you are improving the liver function and not the cancer, basically. So you are downstaging the stage of the cancer by improving the liver functions. So once you improve the liver functions, they are more amenable to treatment, which they were not before. So that's how etiology comes into play.
At the end, I thank Professor Nijavan for giving a very eloquent lecture. And I also thank all the chairpersons for making the discussion very lively.
Thank you, sir. Thank you.
We will now have a 15-minute tea break and we'll resume the sessions at 12 o'clock.
कर्नल साहब को
हेलो हेलो। हाँ हाँ मीना जी, आपको आवाज आ रही है मेरी? मीना जी।
Welcome back. Let us begin with the next session. For the next session, I have invited Dr. Jayanti Venkatraman. Ma'am is going to be moderating the session with Dr. Manav Vadhavan. Dr. Manav Vadhavan, can I request you to please come on the stage? Can I also request Dr.
Mic test 1 2. Is there audio?
Dr. Sareen will be joining online. So I think the coordination is happening. Dr. Anira Vaidya, Dr. Ankur Jindal, Dr. Vikrant Singh, and Dr. Piyush Mishra to please chair this session.
So I guess Dr. Sareen is joining us online. This audience does not need any introduction for Sir. Sir is currently the Chancellor of ILBS and the Director of ILBS. He's also Head of NAMS. And we all know the King of Hepatology, Dr. Sareen. Can I welcome Dr. Sareen for the talk, please?
Good afternoon, sir. We look forward to your talk on Bevino 7, sir.
Thank you. I am very grateful to Dr. Anil and the whole organizing team for inviting me. I wish I could have come personally to meet all of you. I will try and share some updates on Bevino 7. I have nothing to disclose. This is the classical picture on the first Bevino when it was raining heavily and there were few people who were trying to cross the road. Bevino 7 is every 5th year activity, and this year the title was Personalized Care in Portal Hypertension. First of the 7 topics which I will discuss is about non-invasive tools for diagnosis of compensated advanced chronic liver disease and CSPH. This diagram from Thomas Reiberg tells you what we do currently. We do biopsy or we do HVPG to diagnose CSPH. What one can do is plasma biomarkers, 1 Willebrand factor antigen of more than 315, APRI, and other plasma markers. We also can use a transient elastography or a spleen stiffness measurement. The biopsy tells you thin septa, large nodules, low pressure, less disease. Thick septa, small nodule, big disease, big pressures. Conventional methods include putting a line into the hepatic vein, wedge it, confirm it. So have a wedge pressure, let's say 32. Then you deflate the balloon by bringing it up. This is a free hepatic venous pressure. The difference is 21 millimeter, and you repeat it 3 times or so. So one is pressure measurement like this, or endoscopy shows you that there are varices in this. Clinically significant is when it is more than 10 millimeter. But these are not compartmentalized patients. You have patients who need continuous measurement. The term came in 6th Bevino, compensated advanced chronic liver disease, which reflects continuum of severe fibrosis and cirrhosis in an ongoing chronic liver disease. So here, first I will discuss about some biomarkers. Biomarkers have an advantage because they have low failure rate. They're just blood test, yes or no. They're reproducible, cost, if you are not doing proprietary, maybe less, otherwise more. And they are validated for fibrosis. They are, however, non-specific, not for any individual fibrotic tissue or collagen. They are poor discriminators of intermediate F2, F3. Proprietary like Siemens and others are expensive. APRI is the most standard all of us have used. AST, platelet, and a ratio and a cutoff of above 1 is suggestive of F4 fibrosis. ELF, the European Enhanced Liver Fibrosis, this is now available with Siemens, has hyaluronate, P3P, NP, and TIMP1. P3P, NP is one single molecule of P3P, NP is released when 1 collagen 1 is deposited. So this is pro-collagen 3 peptide at the N-terminal end, and 1 molecule is equal to 1 collagen 1 deposited. Anything above 10.5 is worrisome. And if it is above 11, it certainly suggests an advanced fibrosis compensated advanced chronic liver disease. And these correlate very well with TE. 1 Willebrand factor is a marker of endothelial dysfunction and intrahepatic vascular resistance. In this slide, I show you a meta-analysis of 5 studies, which all show that 1 Willebrand factor correlates very well with HVPG. And here you can see 1 Willebrand factor. If the level is above 315, It generally suggests CSPH. Let's now move on to the next group of using liver stiffness. Liver stiffness or transient elastography, all of us have been using. Clearly, if it is above 25, think it is HVPG is above 10. It is clinically significant. So this is a simple thing. The gray zone comes between 15 and 25. If fibro is less than 15, then you look into platelets, but still not an endoscopy. This is compensated advanced chronic liver disease 15, but platelets are low. But when will you do endoscopy? If it is 20 and platelets are low. So anything about 20 and low platelets goes into this group. Now between 15 and 20 is the group. Now you assume compensated advanced chronic liver disease. You can do a biopsy, you can do an endoscopy. This depends upon you. So clarity is about 25. Clarity is about 20 with low platelet. Clarity is also on this side that less than 5, nothing to worry. Less than 10, by and large, it's not a advanced chronic liver disease. So I would say between 15 and 20, there is a gray zone, which we as individuals have to assess. There are new tests. One is called a Vitro test. Vitro is 1 millibrand to platelet ratio. If it is above 3.3, a 1 millibrand to platelet ratio above 3.3 is as good as doing a fibroscan and above 25. So if you don't have that expensive machine, you just get Vitro test done and you are accurate in a fairly large number of patients. What are the limitations of transient elastography? If person has high BMI or skin to liver is more than 2.5 centimeter, there is ascites, heart failure, or inflammation like AST, ALT are high, or there is ethanol, cholestasis, high bilirubin, SOLs on the right side, high liver tissue, iron content, and a fasting is not there. So with this, I would say TE is good in about 7 out of 10. In 3, it is not good. What Bavino says? It says if the LSM is above 10, it should be repeated in a fasting state. Or calculate FIB4, which should be above 2.67. Or an ELF, which is above 9.8. I would put ELF above 10.5. How do you assess portal hypertension? Well, we have seen on the right side, that is on the liver side, HVPG and others. But let's go to the left side to the spleen. SSM or spleen stiffness measurement directly reflects portal hypertension. This stiffness is due to congestion and other changes related to portal hypertension. Bavino recommends that if there is a spleen stiffness above 50, then it is clinically significant, and less than 21, not. Around 32, you will start suspecting that there is a portal hypertension, but you do an endoscopy, then above 50 or so. Can splenic stiffness help you to define response to beta blockers? Very indirect. A decrease in liver stiffness of more than 20%, or coming down of LSM to less than 20, or any decrease to less than 10, but the evidence is C2, you can think there is a response. We need much more work to be done in this direction. We did some work. Our colleague Ankur had shown in this recent study steps beyond Bavino 6. Now, please pay attention to this group. HVPG is less than 10. It's not clinically significant, but LSM stiffness is above 22. Now, this group has decompensation in 3 years, almost same as clinically significant with a pressure above 10. So the bottom line is, don't think that less than 10 millimeter HVPG is not significant. We believe this has relevance. So how will you manage your patient and give beta blockers? Anybody who has a LSM above 20 or 22, you may do an endoscopy and may consider doing beta blocker therapy in them. Not everybody, but you can consider this as a potential group. Splenic stiffness and response to carvedilol was studied. And just to briefly tell you that the hemodynamic responders to beta blockers versus non-responders could be clearly differentiated to the tune of 0.84 AUC. So spleen stiffness in this very small study was able to determine response to beta blockers. I also showed you earlier, there is a 20% reduction in the liver stiffness, or it comes to below 20. But here spleen stiffness has also been shown to respond, but data needs validation. So the first part of my presentation of Webino 7 non-invasive tests, they are promising, they are reliable in predicting CSPH, advanced compensated chronic liver disease, and high portal pressure. They can exclude patients not needing endoscopy. There is a gray zone. They are not reliable in predicting success of beta blocker or rebleed or etiology specific cutoffs. We have to have combinations, so non-invasive plus maybe blood biomarkers. Radiomics and point of care are evolving. I have a lot of data, but no time. The next Bevino important part was management of the acute variceal bleed. As you can see, there is a spurter. Spurter means portal pressure is above 16 or so. Here is post-EVL ulcer bleed. Bevino 7 indicates you manage all these patients in ICU in immediate care settings and preferably intubate in active bleed if the patient has altered consciousness. But this is important. Extubate as quickly as possible after endoscopy, maybe on the table. With terlipressin, if you are giving, which all of us give, monitor sodium. Lactulose and enema be added, IV ceftriaxone. Stop PPI immediately after endo, oral nutrition. Don't worry, just 2 hours later, feed the patient so the bowels move and the blood goes out. Very important, all trainees must be supervised when AVB is managed. Fresh plasma, not needed. Platelet fibrinogen, not correlating with failure. Discontinue anticoagulants until hemorrhage is controlled. So patient was on Clexane or any of the DOACs, you just discontinue till hemorrhage is under control. You can start in 2 hours after that. Patients with GOBT, IgV1 and ectopic BRTO may be considered and tips can be combined. Refractory bleed, SAMS is a good option. Balloon is a good option, which was not there in Bevino 6. They had thrown it out, but it is back. Preemptive tips within 72 hours, ideally within 24 hours is indicated. A child C of less than 14 and B7 and above can be taken in. And especially if the HVPG is above 20. It is futile. I agree with that. If it is above 14 or equal to, a MELD is above 30 and lactate is high. What is important and I think worth a debate by all of us, ACLF, HE and hyperbilirubinemia are not contraindications if present at admission. Take the patient individual basis. Check the splenic vein thrombus, portal vein thrombus and HCC. I'll now come to some new concepts of prevention of further decompensation. We all know that 0 to 5 is normal. 5 to 10, I don't think it is subclinical. Some of them are clinical. And above 10, of course, is CSPH. This paper by Dr. Jindal, very important. It divides patients who have HVPG 20 or above. They have more decompensation at 1 year or so. And those who have a pressure which is less than 6 and less than 12, they have only 11% at 2 years. Now see the beauty of this paper. This divides patients between 6 and 8 millimeter and 9 and 10 millimeter. Those who have an HVPG of 9 and 10 have 20% at 2 years decompensation, while those who have pressure between 6 and 8 have about 4 or 5% decompensation per year. So I would say clinically significant portal hypertension is anything above 9. 9 and 10 are CSPH. Now, decompensation in a compensated patient is defined as ascites or pleural effusion, HE, or variceal bleed. Imagine they have removed jaundice from decompensation because they couldn't define what is a bilirubin to define jaundice. So huge debate, and I think it's a mistake. Further decompensation, what they had earlier defined as ACLF is now to some extent further decompensation. What is further decompensation? Development of a second portal hypertension driven decompensating event. Ascites, variceal hemorrhage or HE is further decompensation with or without jaundice. Recurrence of events, and in bleeders earlier, development of ascites, HE or jaundice. So this is the natural course of any cirrhotic patient with decompensation, earlier clubbed as ACLA, but now Bavino, after a lot of debate, just says further decompensation. Now, what is recompensation? This is interesting, and I would like each one of you to check your patients. Fulfillment of all of the following: removal, suppression, cure of primary etiology, resolution of ascites, HE, and bleed for at least 12 months, and stably improving LFT. If your patients can achieve, he can be off the list from LT because he is recompensated. My last part, in the interest of time, is splanchnic vein thrombosis and vascular disorder. HVOTO term is now in dustbin. Budd-Chiari is the preferred designation for any primary hepatic venous outflow tract obstruction. How do you manage? Stepwise. Anticogs, all patients. Treat ascites, varices according. Angioplasty is the first. Do a stent if there is a short stenosis. Thrombectomy, thrombolysis in experts' hands. Tips in Budd-Chiari can be done. I'll come. And LT can be done. Long-term anticogs to all patients with primary Budd-Chiari. The aim is to provide a endovascular treatment to relieve hepatic congestion, restore perfusion, relieve pressure, and halt deterioration of liver functions. This is what we feel. And a patient who has Budd-Chiari with no liver failure, recanalizable vessels, recanalize them, repermeate by angioplasty or a stent. If there is a need, then you will certainly repeat recanalization. If not possible, put a TIPS or a DIPS. If the patient has liver failure, now here there is new development. You can do angioplasty, you can do anticoagulants. Every patient doesn't need to go for liver transplant in them. So here are the types. If there is only an IVC block, recanalize IVC. If there is an ostial block, recanalize the ostial. And if there is a, sorry, my apologies. If there is a complete occlusion of the hepatic veins as seen in this, then you can do TIPS or DIPS. And this is what you will see from portal vein. This is the TIPS and this is the DIPS. Bavino says, before you subject the patient for TIPS or DIPS, do the BCS TIPS prognostic index. Age 0.08 plus bilirubin, 0.16 plus INR. This everyone should know and put it into your unit. And if this score is above 7, you should generally think of LT from the beginning. Outcome of TIPS helps decrease in ascites, bilirubin, creatinine, and INR. These are some of the examples. IVC is a web. You can open it up. Here you can see in this particular patient, and this is a congested, differentially perfused liver. And here you can put in a balloon and dilate it and subsequently put a stent. You can also use a combined jugular and percutaneous approach here in this patient, this and this approach, and you can put the stents in this. You can do direct IVC to portal vein shunt, as you have seen in this particular patient. Post-intervention, maintain INR, regular imaging, and prevent early suspicion of restenosis and dilate or restent. Portal vein thrombosis or EHPVO is defined as obstruction of the extrahepatic portal vein with or without involvement of intrahepatic segments not associated with the spleen or SMV. This was a proposal that we had placed and widely accepted. Is a patient with PVT can have anatomical, very simple, main trunk has gone, type 1, one of the branches right or left is type 2, or both branches to be, or type 3, main as well as the branches. The important part is functional. Recent is less than 6 months, chronic is more than 6 months. Chronic symptomatic, treat for portal hypertension. Chronic asymptomatic, like you see every day, but no cavernoma, you start anticoagulant. But if cavernoma, it is old, no need. So remember chronic. Acute or what now is recent, if it is asymptomatic, you will still probably give anticoagulant because symptoms come in about 30%. If it is symptomatic like pain or diarrhea or blood or whatever, you start anticog and then plan repermeation. Bevino says that recent PVT, less than 6 months, rarely resolves. So add anticogs, start low molecular weight or vitamin K antagonist, and continue this. If the D dimer is less than 500, you can discontinue after 6 months. DOACs can be considered. Now I've added this slide for 2 reasons. DOACs have bleeding rates lower than vitamin K antagonists. It favors DOACs. Of all bleeds, DOACs have less bleeds. ILBS experience, a trial has been completed with dabigatran. Dr. Reddy has done it. Just to show you some of the cases with PVT, which gets recanalized, and over a period of time, the flow has been restored, and the portal vein at 12 months is now showing patency. We have both non-cirrhotic patients and 8, and out of 8, occlusive thrombus or others. So what we have done in this, patients who have got non-cirrhotic thrombolysis has been done or a stent has been placed. In a cirrhotic group of patients, generally we would like to have a non-occlusive thrombus and like to do anticoagulant therapy in them. A term called portosinusoidal vascular disorder, PSVD, has been proposed. It's a broad term. I want to read with you. It's a broad clinico-pathological entity encompassing non-cirrhotic portal fibrosis, IPH, NCIPH, NRH, obliterative portovenopathy, hepatoportal. All those terms are all put into one big umbrella basket. So a liver biopsy is needed, but absence of portal hypertension does not exclude. Presence of viral hepatitis, alcohol, metabolic syndrome does not exclude. Both can exist. Presence of PVT is not ruling out. So what it means is all liver diseases other than cirrhosis now are clubbed under PSVD. I think it's like the ACLF of West. What you require is a biopsy to say it is obliterative portovenopathy, and you also require a clinical criteria of ascites, low platelet, or spleen being large. I think it has become more confusing than before, and we continue to stick to our NCPF or EHPVO diagnosis. The judgment on Bevino 7 will come in next 5 years. It's a pilgrimage. So after 5 years, we will know what we say is correct. I think Bevino 7 has chewed more than it could digest in many things, including of diagnosis of decompensation and maybe PSVD. Thank you for your kind attention.
Thank you, sir, for the highlighting the important components of the Bevino 7. Any questions from the audience we can take up? So one question is, in patients with portal hypertension, different types, sir, EHPVO versus NCIPH versus cirrhosis, is there a difference in the splenic stiffness based on the portosystemic collaterals?
Very good questions. So this was the first paper, and I guess Praveen may be in audience who is now in Ganga Ram. The first paper on spleen stiffness was published in Radiology 2012, which showed that patients who have EHPBO have very high splenic stiffness. Bleeders had close to 64 or so, and non-bleeders close to 37 or so. So one can differentiate without history, higher spleen stiffness in patients who bleed. So in other words, those in whom the splenic stiffness is high are likely to bleed.
But there won't be much of a difference in the different types of portal hypertension.
This was, in my memory, non-cirrhotic. In cirrhotics, the bleeders would have a splenic stiffness generally, in my experience, above 65 or so. But splenic stiffness has many caveats. If the patient has got a large linear-renal shunt or has IGB1 or GOB2, splenic stiffness may be fallacious. Also, it may be exceptionally high if patient has PVT. So if other things are normal, I think it's one of the finest ways of measuring portal pressure.
A small question. In recompensation, what are the histological reversions that take place?
It's a clinical diagnosis.
Only a clinical diagnosis.
And in this, all the three major HE, bleed, and ascites have gone away, and jaundice is not there. So let's say patient had SBP, and we all say an SBP goes for a transplant. It may not be necessary. Or we say patient has decompensation with ascites for last 6 months or 1 year. If he has removed ascites, maybe he doesn't need a transplant. So I think nearly 30% of those who were earlier decompensated, if they decompensate, can be off. I think it's a major, major achievement.
One question from the audience.
Yeah, this is Dr. Ashish. So has the management of acute variceal bleed remains the same as in previous webinar, or for example, the duration of terlipressin and timing of endoscopy and all that? Acute variceal bleed within first 5 days.
Thank you, Ashish. A very important question. 3 or 4 things. One, the Bevino 7 accepts 2 days of this vasoactive drugs. Second, it in a way mandates that patient, if he is in grade 1 or so 2, must be intubated. Third is management-wise, it says that don't use PPI. And I thought it was not a very wise thought, but I thought PPI is held for at least 48 hours, but they were all so critical that we have to stop PPI. The preemptive tips is a new entry in this. The preemptive tips management is part of acute variceal bleed. So rescue tips is different. Preemptive tips is different. So a rescue tips, all of us will do. But preemptive tips of the 3 categories, that is NaCLF for a patient with HE or with a jaundice. But if the pressure is above 12 and he is between B7 to C14, he can be taken for a preemptive tips. I think these are data which need to be collectively done by us. But yes, it opens a window of preemptive tips done within 24 hours to 72 hours.
Last question, Dr. Arora.
Dr. Sareen, I'm Anil.
Yes.
My question is the reason why we look for a stiffness of either the liver or the spleen is because we want to preempt the complications. So liver being a direct effect of the portal hypertension, how is it that spleen, which is at the fag end, at the receiving end of the portal hypertension, it is hardly ever it occurs that you will have a single collateral. So by the time the patient bleeds, you will have plenty of collateral which will decompress the system. So how will a splenic stiffness, which may have a dissipated pressure vis-a-vis the liver pressure, be more reflective of portal hypertension than either the spleen, liver stiffness or HVP?
So let me add to the question which Dr. Arora is asking, sir. So to put it more grossly, do you think splenic stiffness is only for publication or does it help at all?
Putting it together, I feel splenic stiffness is more important in portal hypertension than liver stiffness. It's a very, very helpful modality. Serial portal splenic stiffness measurements will tell you, and it correlates with reduction in the chance of bleeding. Coming back to why splenic stiffness and not liver stiffness, there was earlier a backflow theory where spleen congestion was the fundamental part, and still there is a huge role of that. And being away from liver, the liver stiffness has major problems because you have intrahepatic collaterals, veno-venal collaterals, opening up of several channels which we can't see. But a spleen stiffness is not for publication. It is for real. It works, in my experience.
So let me just add on to this. So you have veno-venal collaterals inside the liver. You have multiple collaterals. You have lienorenal shunts. You have gastric varices. You have esophageal varices. So the probability of splenic stiffness being influenced by the collaterals, I would think, would be more than liver stiffness. How would you counter that?
Very good, Manav, and very nice. I could see Anil also, and apologies I couldn't be with you for coffee. Is the basic spleen stiffness is measured. This is despite the collaterals being present, you are not able to decompress the spleen. That is the spleen the patient has come to you. Now this patient has bled. And after bleeding, you have a baseline spleen stiffness, which is a reflection of the portal pressure. And if you reduce portal pressure, what do? You measure HVPG. And if you see the recent data on the problems with HVPG in NAFLD, you will realize. So, but spleen stiffness with the available collaterals still is the purest reflection of portal pressure. So you have a gastric varix, I agree, but he has a splenic stiffness of only 32. You have a, or whatever it is. So still the best.
So what I understand is one-time value of splenic stiffness is useless, but a serially followed splenic stiffness may help. Perfect.
Yes.
Any questions from the chairs?
Dr. Manav? Yeah.
Last, sir, we have to stop this now.
Just a small little thing. So, we talk about collaterals, we talk about the recanalization and other things. So do we have any guidelines regarding the rectal varices and collaterals, which we keep on seeing in patients who are cirrhotics?
Yeah. You may refer to my paper in 1995 in hepatology on rectal varices. The classification was grade 1, grade 2, grade 3. Grade 3 is more than 6 millimeter. If it is grade 1, grade 2, no need to worry. But if it is grade 3 rectal varices, a prophylactic measure must be taken in. However, if the patient has already bled, that means we need secondary prophylaxis for that in rectal varices. I would recommend a EUS guided or sometimes a very carefully done glue therapy in these patients. However, you have to see that IMV is patent. Most of these varices are a connection of inferior mesenteric vein. So if the block is beyond IMV, the rectal varices are more. So for guidance, a simple ultrasound Doppler that the block is not, if IMV is patent, rectal varices are okay. They won't trouble you much. But if the beyond IMV, there is a block, the rectal varices will continue to bleed, and then you may have to do something else.
So I'll request Dr. Arora to maybe give you the rectal varices topic next time, sir. This is contentious, and I don't think we can do justice in such a small time. Thank you for such a beautiful lecture, sir.
Vikram, I think you should, cajole Vikram to speak on this. He'll be better than me.
Thank you. Thank you, sir.
Thank you. Thank you, Anil.
Thank you, sir. Can I request you for a picture? Can I also invite the speaker to please be a part of the picture? Dr. Sareen ko online. I know, can we just have it online? If sir is still available. Okay.
Thank you.
Sir's here. Thank you, sir.
Thank you.
For the next session, can I please invite Dr. Raju Chinna and Dr. N. Suraj Kumar to please moderate the session? I would also like to invite Dr. Subhash Bhattarai, Dr. Sanjeet Karki, Dr. V.M. Dayal, and Dr. J.P. Bhatt to please chair this session.
Good morning to the audience. We are having a very nice academic feast since yesterday. I would take this opportunity to invite Dr. B.D. Goswami for non-invasive markers for NFLD, which one and for whom. This is a very contentious issue and requires a lot of debate and discussion. And I hope Dr. Goswami is able to do justice on this topic. Dr. Goswami, please.
Respected moderators, respected chairpersons, and all the delegates. For next few minutes, we are going to discuss about the non-invasive markers for non-alcoholic fatty liver disease, which one and for whom. The assessment of the liver disease staging is important for the diagnosis, treatment, and also for the follow-up of these patients during the treatment as well as after the treatment. Is it important to determine if your patient has got just NASH or just steatosis on NFLD? Yes, the studies clearly shows that the end product of the mortality of NFLD from steatosis or NASH is completely different one. This is the natural history of NFLD in 8 to 13 years, from steatosis, then NASH, F1, F2 fibrosis, advanced fibrosis, then cirrhosis, and finally hepatocellular carcinoma or death of the patient. At different percentage, it goes further and different stage and to cirrhosis. Then why to assess the liver fibrosis? That is a big question, and this is the answer. Assessment of the liver disease progression, the planning for the therapy, for the regression of the lesions of the treatment, and also for the screening of the fibrosis, CLD in the general population. And also the studies have already established that the fibrosis is the most important predictor for the mortality in case of NASH. Here, the studies clearly shows whether it is the all-cause mortality or liver-related mortality. In NASH, ultimately, it is the fibrosis that determines everything.
Sorry for the interruption. May I request the audience, please? A lot of muttering and a lot of noise coming. So please hear the speaker and do justice to other people in the audience. Thank you.
Here is the halting of the fibrosis is very important one, and that is our aim of the treatment in NASH. We try to halt the fibrosis or reverse the fibrosis, or if the patient has got already cirrhosis, try to ultimately stop the progression of the problem. So evaluation of the liver fibrosis, it is either the liver biopsy or the non-invasive methods what we have got. The liver biopsy, what it gives to us is a type of the disease, the dynamics of the fibrosis and the treatment option, and also severity and the prognosis of the problem. So liver biopsy, what the problem we have got, it is an invasive procedure, it is the potential complications it has attached to it, it is costly, there's lack of the expertise, all the stations or sessions. Then sampling and the inter-observer variability is also there. And it is only a snapshot, no insight in the dynamic process of the whole liver. And also initially it was developed to get the diagnosis of the differences in the CLD, but not for the fibrosis assessment. But we have got the non-invasive test to assess the liver fibrosis. And basically what should be the ideal one for this purpose should be a simple, widely available, inexpensive, reproducible, accurate prediction of the full spectrum of the disease severity, and also it should be sensitive to the treatment and track the disease progression of the liver over the time. So non-invasive assessment of the liver, we have got the two ways, the biological approach and also with the physical approach. Simple using the clinical parameters, also we can predict the outcome. For example, is ALT/AST level, platelet level, BMI, albumin level, and also the glucose level. For this method, FIB-4 score with age, ALT/AST, and platelet count, and all these parameters with NFLD fibrosis score can give us some assessment about it. We have the non-invasive biomarkers for liver fibrosis assessment. There are direct NIBMs, which are linked to the matrix deposition, like pro-collagen type 1, type 3. We have got type 4 collagen, hyaluronic acid, laminin. There are also direct NIBs linked with matrix degradation with MPP1, MPP2, MPP9, and also tissue inhibitors of the matrix metalloproteinases. There are also, we have got the cytokines and the chemokine that is linked to the liver fibrosis. Also, we have got the indirect biochemical markers like this all list I have given, not going in details about the time for. Also, there is combined direct and the indirect markers, and also there are so many non-invasive markers which are less commonly studied and validated so far. Then this is the list of these biomarkers, where indirect biomarkers and also direct biomarkers of different type. In short, I am giving in this slide. But the problem with the biomarkers, it is indirect biomarkers. There were so many loopholes about it, as well as we have got the physical approaches about the stiffness assessment, which I am going to discuss later on. But again, there are some complications because it needs the technical expertise and other requirement as well. The combinations of the markers, nowadays so many authors have opined that yes, if we combine these biomarkers, and probably it can give some more accuracies in the diagnosis of this one. For example, the fibro test after the FP test gives more accuracy in the diagnosis of fibrosis. This slide shows the studies with different scores, but fibro test, NFLD fibrosis score, and also ELF with the different variables that are used. This is recently NIS4. This biomarker was used by channel and the group. And here they are showing that probably it will be a better option for non-invasive biomarkers for liver fibrosis assessment. It gives some advantage over the others. Recently again, the study published from GUT in 2022, also they showed that these two tests with clean 2 as well as the Rev14 levels also gives a better accuracies with high sensitivity and high specificity level. This slide also shows the different biomarkers with AUROC and also positive and negative negative values, and also it shows the better options what we have got. This is another study showing 761 biopsy provided FLD patients with NFS and fifth score with the accuracies they showed for the assessment of the liver in NFLD. So this ultimately showing which are the best one biomarkers for the liver in NFLD is APRI, the ALT/AST ratio, fifth score, NFLD fibrosis score, BART score, the ELF test, type 1, type 2 collagen, and hyaluronic acid. This is a better option for the NFLD. We have got the stiffness measurement by the physical method of imaging with transient elastography, with RF, with two-dimensional shear wave elastography, as well as with MRI or MRE test. Fibroscans, everywhere it is used in India nowadays. Of course, we have got some limitations, but this what they show in the picture with cap value as well as the stiffness value. Of course, we have to consider confounding the factors while doing the fibroscan, and this is what the F1, F2, F3, and F4 fibrosis. After the scanning, we can assess it. This study showed with based on the 9 studies, and also there is the sensitivities and the specificity is quite high. This is another study again showing high specificity level of transient elastography. We have got the RP, and here it is very good for the diagnosis in stage 3 and stage 4 fibrosis with almost 95% confidence interval. But it is not very good in the early stage of the fibrosis. Then we have got this RP again showing the diagnostic accuracies of 84 to 98% in advanced fibrosis. Of course, we have got the accuracy rate, high sensitivity and specificity from this study of 723 NFLD patients. We have got the MRE, where again it is very effective one, but of course it depends upon the operator. It is independent of the body habitus. Entire hepatic field is assessed, and also the conventional MRI at the same time can be done. The MRE with meta-analysis of the 5 clinical trials, they showed the high sensitivity and specificity in differentiating the different stages of the fibrosis. For the future of the imaging in patients with NFLD, this is what we have got. It's a better options with MRE, MRI-PDFF, and multimetric MR. With the technology advances with time, definitely it will give more and better results with these technologies. This study shows the diagnostic accuracy of the MRI-PDFF with very negative and positive predictive value and high sensitivity and the specificity. This is multimetric MR, again shows the high accuracies of this usefulness of this one. Then which modality is more accurate one, MRE versus the elastography or the RFE, or MRI, PDFF or the CAP? Yes, these studies clearly shows that the better is the MRE, then the transient elastography and the RFE. Also, MR, PDFF is better than the CAP values with the studies clearly showing. How can we improve the assessment of the liver with the non-invasive procedures. We can improve the available non-invasive scores. We can improve the stiffness pattern, and also we can improve by combining non-invasive score and the stiffness. This study also shows the clear options for the prediction of the NFLD in non-invasive scores by elastography as well as the other scoring system. In conclusion, the suspected NFLD patients with the risk factors, non-invasive tests can be used in a clinical practice for risk stratification. By assessing the degree of the fibrosis is important in prognosticating the treating patients with a chronic liver disease. The serum biomarkers or the elastography, each modality is most reliable in excluding the presence of the advanced fibrosis. The choice of the non-invasive tools can be used that should be guided by the local availability and the context to use. Transient elastography is the non-invasive standard for liver stiffness measurement, and combinations of the non-invasive tools are better than the individual markers and assessing the fibrosis. With this, I thank all of you for your kind attention. Thank you. Thank you.
Markers for assessment of liver fibrosis. So, because one of time, I'm restricted to questions. First, so in your practice, like, how do you use these markers to actually start a pharmacotherapy in patients with NAFLD?
Yeah, this is an important question. In practice, it is for biomarkers, we can use the PIP score. APRI score is a better option for NFLD. And of course, nowadays, everywhere it is available, and the FibroScan, and FibroScan can be used. And it is a combination of these two will be the better option to assess it before the treatment or after the treatment.
So, because everybody is using FibroScan, at what level are you comfortable starting a pharmacotherapy based on a FibroScan?
Yeah, it is advanced fibrosis is the predictor already I have shown here. So if it is phase 3 fibrosis or 4 fibrosis, it is always better you plan for the proper treatment. But anyway, if the patient has got the NFLD, always we should see as a whole the patient, because mostly NFLD is attached with a metabolic syndrome, the comorbid condition. So we have to consider everything together and you start the treatment. It is not that we should wait for the advanced fibrosis to start the treatment. Yes.
Suppose we have elastography available, which is now available to most centers, then should we add another marker like this biochemical marker to improve sensitivity or specificity? Is there a certain marker we could add to it, in particular in clinical practice, to the elastography?
Yeah, I have already mentioned and in the studies.
Best, sort of in percentage wise.
Yes, yes. Point is, we should try with APRI, then FIP4. It is widely available everywhere in India nowadays. And of course, we have got the FibroScan machine. The elastography plus these biomarkers together, we can plan. It's an added advantage over it.
How much that is increased, our sensitivity and specificity? Do you have data sort of something? Yeah.
Exact figure,
But
don't
it is
have.
clinically relevant.
Yeah,
And
it's
suppose
clinically relevant.
Suppose we don't have elastography.
Yeah.
And we have biochemical markers we can do, simple one.
Yeah.
So again, adding two, would that improve sensitivity, or should we stick to one like FIP4 or APRI?
Yeah, these combinations are always a better one than only one score.
But we are not sure which combination sort of in the clinical setting.
FIP4 score and your APRI is definitely a better option. So I think anybody else have got any more information?
See, what I would say is that whatever is available to us in clinical practice gets precedence over what is experimentally available. Most of these biomarkers, indirect biomarkers, are not available at all the centers. I do not think they would, we have Vijay here, but I do not think they would increase your sensitivity and specificity to such an extent that they become mandated to be added in elastography. So MR and a fibroscan should be good enough at the present stage, unless you are doing some experimental study. We can have the audience, if anybody has any different views on this.
Excellent talk, sir. I have a different question. We talk about non-invasive marker for fibrosis. What about non-invasive marker for inflammation? Are AST, ALT, do they reflect accurately the inflammatory milieu of the liver? Do we need inflammatory biomarkers? Maybe you or Dr. Ajay can also come.
I think, yeah.
Again, I think nice talk. You know, we are now coming up with the nasal guidelines, which should be published, you know, maybe next few months. So what we are suggesting there is, you know, at a two-tier kind of a step approach, where at a secondary level or at a primary level, you use a blood-based biomarker, and the easiest and the most widely available and most tested would be FIF4. Just do a FIF4, AST, ALT, platelets, age, that's it. And based on that, if it is more than 2.67 and you think the patient has a advanced fibrosis, you can refer him to a hepatologist. There they can confirm it by a fibroscan. And if both are concordant, you can even take a decision for pharmacotherapy. But if there is a discordance, then the hepatologist can decide whether a biopsy is required. And if at a primary and secondary level, if your FIF4 is low, I think you can manage it at a primary or a secondary level. No need even to refer. But yes, if you're still in doubt, patient has a lot of metabolic risk factors, FIF4 is in a gray zone, you can use another, you know, blood-based, maybe NFS or EPRI. This is what we are suggesting, you know, the algorithm.
Thank you.
But the question was, would these markers add up to anything if done along with the fibroscan?
They do, you know, I think, obviously, I think if you use more than one marker, those kinds of approaches are also available. The combination is obviously better than a single marker. There's no doubt on that.
Would it be statistically significant?
Any comments, questions from chairpersons?
Yeah, so basically what we have is biomarkers or these fibroscan or other tests. They help you distinguish normal liver versus F3, F4 liver. But F1, F2 liver, they're not so good. So what would be your recommendation to exclude? Say you have a fatty liver patient, you want to know whether the early fibrosis is occurring, then you have to follow him closely. If early fibrosis is not occurring, then you can have a longer follow. So any recommendation regarding how to deal with such patients?
Actually, that's a very, so like I will just take up, it's a very difficult question because even by definition, if you have to define NASH, like there should be like presence of liver injury in the form of balloon degeneration that can be documented only on a liver biopsy. So even if a patient has got F0, F1 or F2, these patients may still have NASH. So like to pick out liver biopsy is the only way. So whatever we are doing with the indirect markers or non-based markers are like, you know, we are trying to measure the surrogates of the inflammation, which is the end result of inflammation leading to fibrosis. We are trying to measure that. So to exactly stays like NFLD or NASH or like cirrhosis, we need liver biopsy. Since liver biopsy is invasive and because of the unintended complications that might land up, the whole idea is to, we might have something that may do away without a liver biopsy. Otherwise, we'll never be able to know. So we'll close the session.
I will request you for a picture. I'll request you for a picture. We'll begin with the next session as well. So a picture in the center. For the next session, may I please invite Dr. Sunil Taneja and Dr. Amit Tawarani for moderating this session. I'll also invite Dr. Adyashri Karti, Dr. Akhilesh K. Kashyap, Dr. Geeta Rani Ray for chairing this session, please.
Hello. A very good afternoon to all. So we move on to the next very important talk on in NAFLD, what do we want to treat? Fat, inflammation, or fibrosis? And for this, I invite Dr. Ruvina Bhavani to deliver the talk.
A very good afternoon to all the audience. I would like to thank the organizing committee for inviting me to give this very interesting talk. In NAFLD, what do we need to treat? Fat, inflammation, or fibrosis? Okay. The natural history of NAFLD is one that begins with bland steatosis, and then a proportion of these patients move on to develop steatohepatitis, where there's persistent necroinflammatory process going on. And this then results in fibrosis. The trajectory of this disease progression is non-linear, as there is fluctuating degree of inflammation, and this may then lead to accelerated progression of fibrosis or even regression in the fibrosis. Hence, the aim of the treatment or intervention here would be to retard the progression of the disease, as well as, if possible, to achieve resolution of NAFLD. This is hoping that this would then reduce both liver-related and non-liver-related morbidity of NAFLD. In order to treat NAFLD, I think we should have some basic understanding of the pathogenesis of this disease, mainly the alteration in lipid metabolism, the necroinflammatory process that leads to NASH, as well as the fibrosis pathway. With this knowledge then, hopefully we will be able to identify potential target areas for therapeutic intervention. So in the past, NASH was thought to be a consequence of two-hit hypothesis, but we now know that this explanation is oversimplified. A better explanation would be multiple parallel hits hypothesis, where there is gut-liver axis involvement, implicating gut microbiota, dysbiosis, chronic inflammation of the intestinal lining. There is involvement of adipocyte tissue and liver axis, where there's pro-inflammatory cytokines released, as well as there's reduction in leptin and adiponectin, which increases insulin resistance. There's genetic predisposition, PNPLA3 gene and BOT7 have been implicated, which all has an interplay and then leads to alteration in lipid metabolism. So in a NAFLD environment, we realize that there is increase in the free fatty acid that is circulating within the plasma. This is mainly contributed by the increase in the dietary intake, as well as increase in the lipolysis process that occurs in the adipose tissue. This is enhanced in the insulin resistant state. It can contribute up to 60 to 70% of the lipid pool in the liver. Along with that, there is increase in de novo lipogenesis, which produces triglyceride, which is again increased in NASH and insulin resistant state, especially if there's increase in carbohydrate intake, especially fructose. So these excess fatty acids are then eliminated via two pathways. The first would be the fatty acid metabolization, as well as fatty acids are transferred into VLDL, which is incorporated into your triglyceride and secreted out into the plasma. Even though these two mechanisms work harder to eliminate the free fatty acids, but the net effect of the increase of free fatty acids in the liver, as well as the increase in triglyceride synthesis, does not match this, and there is a net effect of excess steatosis. So the very definition of NAFLD is hepatic steatosis, which is more than 5% in the liver, which is mainly composed of triglycerides, the inert lipid species in the liver. So what is the role or what is the effect of triglyceride then? In the previous slide, I've shown that it has a protective role, mainly by modulating the fatty acid toxicity by two ways. First, byproduct of fatty acid oxidation is used for triglyceride synthesis. And second, it reduces the free fatty acid by converting to VLDL and being incorporated into the triglycerides, which is then secreted out. So do all lipids behave in the same way? I don't think so, because there are some lipids who exert good effects, such as triglycerides, and there are some bad lipids which are pro-inflammatory as well. So looking at the good lipids, triglycerides has been mentioned. The next in the category would be mono or polyunsaturated fatty acids, especially the PUFAs, for example, oleic acid, DHAs, and EPA, which helps to alleviate inflammation and fibrosis to a certain extent. And you have the bad lipids, which are saturated fatty acids, free cholesterol, the LPCs, which stand for lysophosphatidylcholine, ceramides, sphingolipins, which cause cellular injury and lead to lipotoxicity. So lipotoxicity leads to inflammation. And how does it do so? The toxic element of the lipids causes dysfunction of the organelles within the liver cells, causes abnormal activation of intracellular signaling pathway, which then leads to chronic inflammation and cell death, which is the hallmark of NASH. So in lipotoxicity, there are several events that occurs leading to cellular death. For example, there is endocrine reticular stress and mitochondrial dysfunction, which further activates the Jun-N kinase pathway, which accelerates the apoptosis. Lipotoxicity also causes liposomal dysfunction or permeabilization. It also causes production of extracellular vesicles, which also then activates and aggravates the hepatic stellate cells, Kupffer cells, and macrophage. And this creates a pro-fibrotic pathway. Lipotoxicity also increases hypoxia, which accelerates cell death. So the bad cholesterols that have been implicated are the saturated fatty acids, the LPCs, and the ceramides, which acts on these events and further accelerates cell death. Ceramide on its own is also known to act on hepatic stellate cells, as well as macrophage and adipocytes, triggering the pro-inflammatory and pro-fibrosis pathway. So now we look at the good lipids. So PUFA, which is omega-3 and omega-6, especially omega-3, the EPAs and the DHA. The main role of these polyunsaturated fatty acid is to maintain cellular membrane integrity, as well as to directly modulate the activity of the genes involved in lipid metabolism, oxidation, inflammation, fibrogenesis in NASH, by interacting with nuclear receptors and transcription factors. So in this table, you can see that the effect of EPA and DHA on hepatocytes, they are able to actually reduce the de novo lipogenesis, as well as reduce the cholesterol synthesis. And DHA on its own has shown extra benefits such as reduced necroinflammatory activity in the liver. This same effect is seen on macrophage Kupffer cells and hepatic stellate cells by DHA, where it exerts an anti-inflammatory as well as anti-fibrotic effect. So the EPAs and DHA are further processed to form these molecules that are called specialized pro-resolving mediators. These are in the greens. Examples of specialized pro-resolving mediators would be lipoxins, resolvins, protectins, and marasins, which help to stop the injury in the liver. It also helps to switch the balance from the pro-inflammatory to restorative state in the liver, as well as in the macrophage. It is also shown to cause deactivation of the myofibroblasts, and also helps with the degradation of extracellular matrix, which is composed of collagens and non-collagenous tissue, which is the hallmark of fibrosis in the liver. Next, this is the pathway for fibrosis in NAFLD in general. So the stressed or the dying hepatocytes go on to produce an array of mediators, which then triggers the hepatic stellate cells. Peculiar to NASH fibrosis pathway would be the TAS and the Notch pathway, which triggers the formation of Indian hedgehog and osteopontin, which is part of the mediators of fibrosis. The hepatocytes that shows ballooning also goes on to trigger the production of sonic hedgehog, which is only seen in NASH. Extracellular vesicles, which is produced in the inflammatory process, triggers the microRNAs. These mediators not only activate the hepatic stellate cells, they also activate the macrophages to become profibrotic. Along with these mediators, the bad lipids such as ceramide and free cholesterol also triggers the macrophage to produce further mediators of fibrosis, such as transforming growth factor beta, your chemokine markers, platelet-derived growth factors, galactin-3. When hepatic stellate cell is activated, it is further proliferated and it's continuously producing the extracellular matrix, which is deposited, and hence there is fibrosis in the liver. So now that we know to a certain extent the basic pathogenesis of liver inflammation and fibrosis, we can now consider pathways to be tackled in order to reduce inflammation and fibrosis. So the first group would be insulin sensitizers, the GLP-1 and analogs, where it works on the insulin resistance. Next, the group which works on inhibition of de novo lipogenesis, such as your ACC enzyme inhibitors, your DGAT enzyme inhibitors, and SCAD enzyme inhibitors. Another way to approach this would be to modulate nuclear transcription factors by such as FXR agonists, FGS19 analogs, PPAR agonists, as well as thyroid hormone receptor beta agonists. Last but not least, you can also target the fibrosis pathway by inhibiting the chemokines, the galactin-3, and the transforming growth factor beta. So this is my last slide. I would like to conclude by saying that development of NASH and subsequent liver fibrosis involves multiple pathways that are interlinking and complex. More evidence of systemic involvement has been shown. There's genetic predisposition, there's gut inflammation, dysbiosis, insulin resistant, pro-inflammatory environment in the adipocyte tissue. This then just adds to the complexity of the disease. Multiple pathway means there are more opportunities for therapeutic intervention. However, this also means that it could increase the heterogeneity in the clinical outcome of these therapeutic interventions. So coming back to the question that was posed, in NAFLD, which should we treat, fat, inflammation, or fibrosis? I would be very happy to hear from the moderators and the panelists and the audience as well. But my conclusion would be all three elements should be treated both by pharmacological and non-pharmacological means. With that, I thank you for your attention.
For this wonderful talk. So let me just ask you this question, that we know that the outcome of patients with fatty liver disease depends on the degree of fibrosis they have. And we also know that, the inciting agent or the starting factor is obviously the fat in the liver. So where do you start? You target fibrosis or you start with the fat? And I mean, what kind of treatment would you like to offer to such patients?
I think that fat plays a role in every step of the disease progression. It plays a role, the bad fats plays a role in lipotoxicity and even fibrogenesis. So I think it's very, very important to target the fat from the very beginning. But we also understand the inflammatory pathway and the fibrotic pathway is very complex. It does not only involve the lipids, it is to a certain extent common for most chronic liver disease. So in order to target the fibrosis and the inflammatory pathway, you will need additional therapies, not only by targeting the lipids. So I think a good way to start would be the lipids. And as you can see that, I feel I made a statement saying that non-pharmacological approach is very important. So what I meant by that is dietary intake is very, very important. Increasing your PUFAs, DHA and EPA into your diet is very important. Controlling insulin resistance is also very important because that seems to be the trigger at the very beginning as well.
Dr.
Thank you. Excellent presentation. So you have shown a big chart of so many drugs. It's like, water everywhere, not a single drop to drink. Still, FDA has not approved even a single drug amongst a pandemonium of drugs. And we have Dr. Ajay Duseja, he says, wait till Fib is more than 2.47, do nothing till then. Why the dichotomy?
I think I shall ask Dr. Ajay to answer that question since it's most likely
I
going to
think
be his
first coming
topic.
to your talk, I think a nice presentation. I think probably we need to tackle all three. This is my personal take because all three are interconnected. Fat leads on to inflammation, inflammation leads on to fibrosis. So it depends on what stage the patient comes to you. If the patient is coming to you with F2, F3 fibrosis, obviously you will choose the drug or the lifestyle interventions and would look at the anti-fibrotic activity. If the patient comes to you with only NASH, no fibrosis or F1 fibrosis, you will try to tackle the inflammation. Now there's a patient who has come to you with only fat. So obviously, I think you will give him only maybe lifestyle interventions. So all are important, all are interconnected. And to add on to that, there's a very good paper by Rohit Lumba's group, where they have shown that once you treat them and on MRPDFF, if you show 30% reduction, that actually correlates very well on biopsy with the improvement in NAS score and improvement in NASH histology, which actually means you're taking care of fat and looking at non-invasively by only reduction in fat by MRPDFF. But when you're looking at the histology, it's not only the fat which is improving, the inflammation is also improving. There's little data on the correlation of MRPDFF reduction with fibrosis, but there's a good data to suggest that I think it is connected with inflammation. Yeah.
Sir, how to approach a patient with lean NASH? They don't have so many fat storage. They do show necroinflammation on.
NAFLD would largely remain the same. You have to stratify the severity of the disease. Lean patients can also have F3, F4 fibrosis. They can have F2 fibrosis. So ultimately, it boils down to the severity of the liver disease, and then take a decision whether in addition to lifestyle interventions, you require any pharmacotherapy or not. So if they have severe disease, you tackle them. The only point which is valid in lean is that you may not like to lose them, say 10% of body weight because they're already lean. But still, there's a very good data which is coming up now that even if lean people, if they lose only 3 to 5% of body weight, right, there's improvement in histology. So I think the approach largely remains the same.
Just one quick question. You showed that PUFAs and MUFAs are better. So are the capsules which are available of omega-3, why don't they become a part of treatment?
All right. Theoretically, PUFA works, but we have not seen adequate enough of clinical papers. Probably there's not much of pharma interest in that. But I think theoretically it works. So Mediterranean diet works, and Mediterranean diet is mainly based on polyunsaturated fat. So my personal take would be, I wouldn't stop my patients from taking it, but I wouldn't openly encourage them from taking it. But we do know that a lot of patients take DHA and EPA supplements, and it seems to work.
So let me just summarize that you need to treat all three components: fat, inflammation, and fibrosis. And I think the easiest would be lifestyle modification and control of fat in the liver. And once you have advanced stages, then you have to be more aggressive in treatment.
I'd like to ask one question. Congratulations for a wonderful presentation. I would like to ask you, what is the role of gut microbiota in the pathogenesis of NFLD, and is it important to treat that?
Okay, thank you for the question. I did not touch on gut microbiota because it's such a huge topic, but there seems to be emerging evidence that certain gut microbiotas seem to be increased in NASH population, but I do not have enough to say with regards to should you directly treat it when there is so many other modalities that should be addressed first.
I would like to ask one question.
Yeah, last question, please.
I would like to know that patient asked which oil to take. In North, they are not using coconut oil. So what oil you suggest? Because not all oil are refined. Now it is saying that we should not use refined oil. So what is your say? What to advise patient? To tell them use this oil is very difficult.
Okay, that's a very tough question. I also usually get that sort of questions from patients when they ask specific dietary recommendations, and it's very difficult to give it specific dietary recommendations when there's not enough clinical data. But I would say
because it is very difficult to answer them what to eat.
so yeah, so the usual, what do I tell my patients? I try to follow Mediterranean diet, which is sort of tailor-made to your local dishes, and exercise is very important. And maybe Dr. Ajay can give some insights about oil.
Thank you.
I would advise them to avoid saturated fat, check the labels of the oil, and they should be high content on PUFA and MUFAs. And instead of using refined oil, use cold pressed oil. That is much better.
Actually, I wanted to know a specific patient. They are illiterate. They don't see that much of labeling on the item. What is there? What is the percentage? 3/3, 1/3, 2/3.
Olive oil is much better because they contain much of PUFAs and MUFAs. But it is expensive. Then apart from that, there's a combination of soy, this sunflower oil, that is also a good, sunflower, and rice bran oil.
Thank you, sir.
So if there are no more questions, we close this session. I thank the speaker and the co-chairpersons. Thank you very much.
Thank you for the session. Now we'll go ahead with the next session. For the same, can I please invite Dr. S.P. Singh and Dr. Manoj Sharma to please moderate this session. Dr. Ashish Prasad, Dr. Bisweswar Panda, Dr. Varun Gupta, and Dr. Amit Man Joshi to please chair this session.
Good afternoon. Without wasting time, we're going to start the lecture. The speaker is none other than Dr. Ajay Duseja. So I thought when all the questions were being asked to him, they could be saved for this session. He, I think, eats, drinks, and does everything NASH, NAFLD, and nothing else. He's a pioneer in the field of NASH. I don't think there's a better person than him to speak on NAFLD management. Ajay, please.
Thank you, sir, and good afternoon, everyone. At the outset, my sincere thanks to Professor Arora, Professor Ashish, Dr. Praveen, and the other members of the organizing team for giving me this opportunity. The problem is, I think Dr. Arora is a good friend of mine, but he has asked me to answer two very, difficult questions. Will it ever bear fruit, the pharmacotherapy? And the second, he's asking, where are we heading? I know, I think he's a tough examiner. I can't leave these questions blank. I will have to answer those, but I'll answer maybe the easier question first, which is, where are we heading? And maybe I'll briefly say about whether we will really bear the fruit. So I think you have heard two very nice talks before me, and we do understand that it's a lifestyle disease, fatty liver disease, and lifestyle interventions is the key. There's no denying the fact. So all patients, irrespective of the severity of the disease, I think need to be given the lifestyle interventions. And the most common metabolic disorder we know, which is associated with disease, is overweight or obesity. So weight reduction of say 3 to 5%, 5 to 7, or 7 to 10%, as per the severity of the liver disease, control of diabetes, hypertension, dyslipidemia. I think there's no denying the fact. But now I think we were discussing before this, I think the concept which is coming up now is that you need to look at and define so-called the high-risk patients. High risk means those who have multiple metabolic risk factors. Age is a very important, which puts you at a high risk. You kind of screen these patients if they have, say, risk for fatty liver disease, and try to stratify, which you heard Dr. Goswami saying, based on the non-invasive assessment. And now we try to, on non-invasive assessment, we try to put them whether they have like a fibrotic NASH, or they have a non-fibrotic NASH, or just have, fat in their liver. Then based on that, then you decide whether you want to put this patient only on lifestyle interventions, or you want to give them pharmacotherapy. So patients with only NAFL, just fat in the liver without inflammation or fibrosis, are the candidates only for lifestyle interventions. The pharmacotherapy is, to be given only in patients, those who have significant or advanced fibrosis. When we say significant, this means F2 or more. And when we say advanced fibrosis, this is F3 and more. So this you make, assessment based on the non-invasive assessment. As I said, we are coming out with the nasal guidelines, and we are suggesting that the biopsy may not really be required if you are confident enough in making a diagnosis of F2 or F3, and can take a decision to put them on pharmacotherapy if you think that they can be F2 or F3 fibrosis. And depending upon, as I said, which drug to choose is another, area. So depending upon whether you want to tackle only fat, inflammation, or fibrosis, we have some drugs which are recommended, and then you can choose amongst them. And I'll be talking about that, what is ahead of us, some of the future treatments which are available. You also look at, the adverse event profile of a particular drug. That also helps you in choosing a drug. And finally, when you're looking at the response to the treatment, again, people, as I said, traditionally this has been always histology, but now people are focusing more on NITs or non-invasive assessment, non-invasive markers to assess the response. And people are now, kind of classifying this response into adequate response, partial response, or lack of response, something. So on this basis, you just saw this diagram and you heard this, it is such a complex disease, and people are, kind of tackling, as I said, all the three components: the metabolic components, the inflammatory component with anti-inflammatory drugs, and the fibrotic component with the anti-fibrotic drugs. So now, where are we heading? That's the question I was asked. All these, kind of stuff which is happening, and people are working on the pharmacotherapy of NASH, has to go through different phases of clinical trials. Start with phase 1 to 2, 3A, 3B, and all that stuff. So it really takes very, very long. So, and it's, as I said, this is a lifelong disease, could be we know it's a lifestyle disease. So what, FDA and most of the, regulatory agencies have done it, that they said that a drug will get approval, and they are calling it as a conditional approval, if you show that there is a resolution of NASH without worsening of fibrosis, or there is improvement in fibrosis of 1 stage or more without worsening of NASH. This is what they are saying, that your drug will get approval only, and this will be a conditional approval. Then final approval will come only if you show that it actually improves the clinical outcome, which means the cirrhosis goes up, your clinical outcomes improve. So, this is a huge and a long drawn process. And that actually answers the question which, was asked by Dr. Arora, that why till date no drug has been approved by FDA because this is a long drawn process. Conditional approval, you're looking for a histological assessment, clinical outcome obviously will take, so many years. And people have started working on pharmacotherapy for this particular, entity, maybe for last 10, 15 years. So I think but the future looks, bright, I would say. Again, I think if you ask me to read all these drugs which are, in various phases of clinical trials in NASH, I think my all 15 minutes will go into that. I think this is not even readable because this is one disease where probably you have the maximum clinical trials, going on, right? So I'll not, waste time here on this. But what I'm trying to tell you is now people have come, especially, this Dr. Nam Alkhuri from Arizona has done some wonderful work in NASH. And he has come with this, what they call it as a NASH drug score card, which means that when you are looking at the efficacy of a particular drug, obviously, the hepatic efficacy endpoints are very, very important, where you look at the NASH resolution, you look at the fibrosis improvement, but then they're also saying that you can even non-invasive assessment based on the MRPDFF, ALT reduction can help you in taking a decision. But then, as mentioned by the previous speakers, NASH is not only liver disease. It's a systemic disease, multi-system disease. People can have cardiovascular disease, osteoporosis, CKD, and malignancies and all that. So when you're looking at the efficacy of drugs, you also have to look at that what is the effect of these drugs on the metabolic risk factors. What do they do to the weight of the patient, dyslipidemia, hypertension, insulin resistance? And that's very, very important. And finally, you also have to take into account the adverse events which are related to that drug. So, it's a comprehensive kind of thing. And this, they're calling it as a drug score card, which I think is very, very important when you're choosing a drug for patients with fatty liver disease, which is, as I said, is a multi-system disease. Now, I think, again, coming back to the same question as to where are we heading, again, we people, as I said, have been working on this for so many years. There are, certain drugs which are, I will just focus on the drugs where probably we have some of the histological data. And as I said, maybe working for that conditional approval, which have shown that, yes, these drugs look very, very promising. And I'll maybe show you one recent study on lanifibranor. Then you have, some phase 3 data, where people phase 2 studies were very, very promising. They showed that there is an improvement in histology, say with elafibranor, which is a PPAR alpha and a delta agonist, selonsertib, which is an apoptosis signal kinase inhibitor, and sinicreviroc, which is a chemokine inhibitor. But when these drugs went on to phase 3 studies, they failed. So that's why, these drugs have been stopped. But then you still have some ongoing clinical phase 3 studies based on the efficacy in phase 2. And the 3 important drugs are the resmetirom, which is a thyroid hormone receptor beta agonist, Ramcol, which is an SCD1 inhibitor, and semaglutide, we know, is a GLP-1 agonist. And we also have the interim analysis of the ongoing phase 3 study of obeticholic acid, which is the regenerate trial, and which actually was promising. And people are now working on the combination of different drugs, and I'll maybe show you some data on that. So this lanifibranor is a recent study, published last year in NEJM, and this is a PPAR, pan-PPAR. When we talk about PPARs, they can be alpha, beta, and gamma, but then they have a dual PPAR alpha gamma, like saroglitazar, which is available in India, is a dual PPAR alpha and a gamma agonist, right? Clofibrates are PPAR alpha agonist. Pioglitazone is a PPAR gamma agonist. Now they have come up with this pan-PPAR agonist, lanifibranor. And if you look at this, when they looked at the primary endpoint and the secondary endpoint of improvement in the resolution of NASH, I think this was much better than the placebo. This drug is now going into phase 3. I think this will decide its phase. Now, the 3 drugs which I said, which are in phase 3, so now how they went into phase 3 was based on their results in phase 2 data. And there is a concept of so-called hepatic hypothyroidism in fatty liver disease, where, and we know that if you give them, the systemic thyroxine, they are going to have, the systemic side effects. So people have come up with this molecule called resmetirom, which has a very specific hepatic, effects on this THR beta receptor. So this is a thyroid hormone receptor beta agonist, which acts only at the level of liver. So you don't get any extra hepatic or systemic side effects. So this particular study, phase 2, in comparison to placebo, did show that there was improvement in fat. And as I was saying, when on MRPDFF, when you look at the reduction in fat, histologically, there was improvement in NASH. So this fat reduction, which was assessed on MRPDFF, was actually correlating with the resolution of NASH. So based on this, this company called Madrigal is now conducting these 2 very large trials. The results of this were, announced maybe last year, where they were looking at, the cardiovascular outcomes and the liver-related outcomes. This was known as the MAESTRO-NAFLD-1 study. And then you have a MAESTRO-NASH study, the results of which are, still awaited. The second drug, which is still in, phase 3, is the Aramcol. And Aramcol, you heard, there's certain, when you look at the fatty acid synthesis, this enzyme acetyl-CoA, plays a major role. And then you have a melancholy-CoA, which gets converted into palmitate. So here there's an enzyme, which is involved, which is known as the SCD1. So Aramcol is, the SCD1, inhibitor. So again, phase 2 data was promising. And based on this, this company called Galmed is, studying this particular molecule in this phase 3, so-called the Armor study. And again, the results are awaited. And the last drug is the GLP-1 agonist, which is the semaglutide. Initially, you are aware, there was a trial called LEAN trial, which was with the liraglutide, which was a subcutaneous daily injection. Then they come out with this new molecule called semaglutide, and the phase 2 data, if you look at this, 59%, improvement in NASH activity in comparison to 17% in placebo, looks promising. So based on this, now companies, conducting the phase 3 study, which is known as, the Ascens trial. And again, it's a global study which is going on. And some of us are, part of this study. And again, the results will decide on this. So the molecule where we have the interim analysis is called the obeticholic acid. And this was again, based on initially the phase 2 study, which was called the Flint study. And then came, this regenerate trial, which, when they did the interim analysis, they showed that the 25 milligram OCA was better than placebo when they did the interim analysis at 18 months in, both per protocol analysis and the intention to treat analysis in improving the hepatic fibrosis, though they didn't find it to be effective in improving the liver histology. The drug also had, secondary endpoints, and they showed that there was improvement in AST, ALT, gamma GT, alk-phos, but it is not free of side effects. And the 2 major issues are the pruritus and the dyslipidemia. And as I said, now people are working on, the combination of drugs. And this was one trial which was called the Atlas, which used the combination of selonsertib with cilofexor, which is, a FXR agonist, and the fursocostat, which is an ACC inhibitor. And this is a recent trial which used the combination of semaglutide and compared it with the semaglutide in combination with cilofexor and fursocostat, and they found that the combination was better. So now, having told you about all these clinical trials, I'm coming back again to that drug scorecard, which is very, very important, as I said. So when you look at these drugs here, lanifibranor, resmetirom, semaglutide, and pioglitazone, and these, FGF1 and FGF19 and FGF21 analogs, I think what you're looking at this drug scorecard, you're looking at the NASH resolution. Almost all these drugs have been shown to, kind of resolve NASH. Fibrosis improvement is kind of plus minus with these drugs. Some of the drugs are improving. They have anti-fibrotic effect. Others do not have. Similarly, you have MRPDF data with, some of these molecules where they have shown that, yes, the hepatic fat improves. ALT, again, some data. Effect on metabolic risk factors is very, very important. The problem with lanifibranor and pioglitazone is that it causes weight gain, whereas you want weight reduction here. Again, some of the drugs, like, as I said, the obeticholic acid and this aldafermin, they increases LDL cholesterol. So again, as I said, when you're choosing a drug, you also need to look at that. What is their effect on the metabolic risk factors, effect on insulin resistance, and the adverse events, the weight gain with lanifibranor and pioglitazone and, some of other things. So when you're choosing a drug, I think it's very, very important to look at this drug scorecard and then see which you fit into. So I think, so finally, as I said, I think we do have a lot of things which are there in pipeline, and I think they look promising. But coming to the second question, which was asked to me, that the NASH pharmacotherapy, will it bear the fruit? I think if you ask me as a good resident or a good student, I think my answer would be that I don't know whether this actually will bear the fruit. But then looking at whatever data which is available with us, I can say that yes, probably it will bear the fruit. Why I'm saying this is because based on the progress which has been done in, say, last 5-10 years, we at least have 2 molecules which have been, recommended by most of the societies, say EASL, ASLD, and including in ASL. And we tend to use vitamin E and saroglitazar in our clinical practice. So this is based on the data that's there. And then again, as I said, a lot of progress is being made on the future pharmacological treatment, and phase 2 data of resmetirom, aramcol, semaglutide, and obeticholic acid looks promising. So based on that, I think if you have to answer this question where this will bear the fruit, as I said, my answer would be yes. So thank you very much for your kind attention, and my greetings to all of you from PGI Chandigarh. So I'll be happy to take any questions.
Thank you, sir. Now the floor is open for questions and comments.
Excellent, actually, lecture on the drug therapy and other things also. I think you put 2 currently drugs like one, the saroglitazar and vitamin E. Why don't you put pioglitazone, which is very cheap, which has been shown to improve the fibrosis, NASH, except the weight gain. Those patients, let's say patients of NASH and fibrosis, whose weight is not very huge, let's say 60, 70 kg, why can't they be put on this drug? And if it has been shown to be very good.
No, I think if you look at again the guidelines from the EASL, ASLD, and INASL, we all do recommend pioglitazone also in the same basket. Maybe for my personal reason, I didn't try the pioglitazone because our experience with pioglitazone is very, very limited, and we tend not to use this drug again because of the 2-3 reasons. One is the pedal edema, weight gain, and the cardiovascular issues which are linked with pioglitazone. Otherwise, as you rightly said, it's a cheaper drug. Rather, even metformin is a very good drug, we find. The problem is we do not have a good histological data with metformin, but these are cheap drugs. But yes, I think if you're comfortable using with pioglitazone, I think it can be used. Rather, pioglitazone has an advantage over vitamin E that it has been shown to have some anti-fibrotic activity also, which is lagged by vitamin E. Right. So I think there the pioglitazone will have some added advantage.
Excellent talk, Dr. Sir. So finally, where do you place vitamin E and saroglitazar in today's clinical practice? That and the combination of these two, whether that is.
Yeah, sure. So, I was actually asked to answer the way ahead. So that's why I didn't touch the current treatment. But then in our clinical practice, as I said, we choose either of the 2, vitamin E or saroglitazar. So what we do is we look at this drug scorecard, which I said, right? And then we look at the gender of the patient, we look at the age of the patient, look at the cardiovascular profile and everything. And then we also look at the disease severity, liver disease severity, and then you choose a particular drug, right? So what we do in clinical practice is that anybody who qualifies first for pharmacotherapy, which I said in the beginning, you have to have F2 or more fibrosis based on your non-invasive assessment or on histology. Once that is qualified, then you look at all these risk factors. And if somebody has, say, for example, associated diabetic dyslipidemia, so my choice goes more towards, saroglitazar, because that's a standard drug for, this thing. That's one. If I am looking for somebody who's an elderly gentleman and there is a theoretical risk of, CA prostate, which is associated with vitamin E. So my choice will be again saroglitazar. But then if the cost factor comes in, saro is costlier than vitamin E, right? And vitamin E has a lot of other benefits also. So if somebody doesn't have diabetic dyslipidemia, no issue with prostate, there's a lady who's there, I can even choose vitamin E. And the other area where we don't tend to choose vitamin E are the
cackled or the compensated advanced chronic liver disease or even compensated cirrhosis, because there's a good retrospective data that vitamin E actually has been shown to reduce your decompensation rate and your requirement for liver transplantation. There also we choose vitamin E. So this is how in clinical practice, we tend to choose here. I think Dr. Satpathy has.
Don't you think we theorize too much? As hepatologists, we theorize too much on NAFL management. How many in the audience do a FIB-4 routinely for the NAFL patients? I request you to raise your hands. How many of you do FIB-4 routinely? We have had so much discussion on FIB-4 for the last so many years. But see, we theorize too much, and when it comes to management, now F2 qualifies for pharmacotherapy. But does that mean that every F2 patient you are going to go for pharmacotherapy without a lifestyle intervention?
No.
Intervention? So that method should be clear. F2
Absolutely.
doesn't mean pharmacotherapy. F3 doesn't mean pharmacotherapy.
No. Absolutely not. I said lifestyle interventions for everyone, irrespective of what kind of severity they have. The pharmacotherapy needs to be combined with lifestyle interventions if they have F2 or F3 fibrosis. Otherwise, if you have F1 or only fat in the liver, I think lifestyle interventions alone are good enough. Whereas F2 and beyond, it is the combination of the two.
So if you're if you're saying F1 and liver 100 and 120, so you're waiting that he should, and he's not qualified for a good lifestyle, and you are waiting him to go into F2 and then start pharmacotherapy. That is the message.
I'm not able to hear you well. The question
Sir,
is?
the enzymes are ALT, AST is around 120, 140, and
Right.
you have a F1 fibrosis, and he's in your OPD chamber. And then what is the take-home message? That wait
So
for the
again,
pharmacotherapy.
I think this message should be very clear to the audience that ALT does not have a very good correlation with the liver histology in patients with fatty liver disease. Your enzymes may be elevated, and if you tend to do a liver biopsy in that particular patient, it may or may not show you NASH. It may just show you some lobular inflammation, and all the features which you are required to call him as NASH may not be seen. On the other hand, there could be a patient with normal ALT or very minimal ALT elevation, and the biopsy may show you NASH. So don't decide on the treatment or diagnosis of NASH just based on the raised ALT. We don't do that. So that's what I'm saying. So decision is not based on only ALT. It's the combination of all the factors.
Yes, Sanjay.
Yeah, thank you. This is an excellent talk, Ajay. My question is, why so many drug trials have failed? Do you think these NAFLD, we know that it's a heterogeneous disease. Now, metabolic syndrome, it's a hepatic manifestation of metabolic syndrome. So as you add the components of metabolic syndrome, also the fibrosis increases. These risk factors increases that progression of disease. So will be the regression. Like, for example, a diabetic patient can progress in 5 to 6 years to advanced fibrosis. And a non-diabetic may be less progressive. So when we're ignoring this phenotype, when you are designing a clinical trial, when ignoring the phenotype, only relying on the histology, is this the reason for the failure? What your opinion about this?
Yeah, I think probably this is now the time, as you rightly pointing out, to stratify our patients with fatty liver disease, as you rightly saying. So there is a patient with fatty liver disease who has histological NASH, qualifies to be, for pharmacotherapy trial or whatever. You need to further stratify them in reference to whether he's diabetic or non-diabetic, overweight, obese, or what, and the end result or the outcome of the drugs may be different. I'm not very sure that most of the clinical trials have not done that. So that's the time I think probably we need to look at this. All these metabolic risk factors are very, very important. And these metabolic risk factors can go either way while the clinical trial is on or while the treatment is on. If your metabolic risk factors are improving, you can very well, your liver disease can improve. And if they are worsening, they can worsen. I agree with you. This kind of stratification is required, yes.
Yeah, Jyoti, last question. After this, we wind up.
Nice talk. Thank you, Dr. Doshi. Two questions. One is how long you have to give vitamin E and what type of vitamin E? Because we have got tocotrienols, natural vitamin E, and other form of vitamin E. So which form of vitamin E and how long you recommend them?
I can see Dr. Kaushal Madan sitting in the audience. So he was given this talk on vitamin E once, I remember. So coming to your first question, the duration of the talk. If you ask me the duration as per the clinical trials, then vitamin E in the PIVENS trial was given only for 96 weeks, which is 2 years, right? Saroglitazar in the clinical trial was given only for 1 year. So 1 year, right? But then in clinical practice, you probably have to individualize. So like, for example, if you ask me, we don't give vitamin E usually beyond 1 year. We have an ongoing clinical study on compensated cirrhosis. We are giving it for 2 years. But then Dr. Mukhewar once was asking me in the last INAZL meeting that why not continue it for long? If they're safer drugs, you can, even if you want to continue it for long, but then you have to draw a line somewhere, right? And these drugs are only to reduce the inflammation and fibrosis, can't continue throughout your life. Ultimately, the lifestyle interventions have to take over, and you can probably give it only for a year or two and then classify them. As I said, now people are classifying whether it's an adequate response, partial response, or no response, as you do in other, say, Hep B, Hep C and all. And if somebody is not responding, there's no point, continuing it. So look at the response and then individualize whether you really want to continue or not. As far as your second question is concerned, there's no comparative data, but I think most of these studies would use, tocopherol as the vitamin E, but I'm not aware if there's any comparative data, I'm saying, between the two, but both can be used, but there's no comparative data. But most of the data is on tocopherol rather than on tocotrienol.
Thank you, Professor.
Thank you very much.
And in the interest of time, we close this session. I thank all the chairperson and moderators.
There a picture for this. Thank you for this session. Now we'll move ahead with the next session. For the same, can I please invite Dr. Shalimar and Dr. Virendra Singh to moderate this session. I would also like to invite Dr. Arun Gyawali, Dr. Pukar Thapa, Dr. Amit Soni, and Dr. Ashwini K. Khanna to please chair this session.
Thank you very much. I'm thankful to the organizers of this conference, Dr. Anil and his team. And we'll have the management of refractory ascites by Dr. Kaushal Madan. Dr. Kaushal, please.
Thank you, sir. Thanks to Dr. Arora and Praveen and Ashish for inviting me for this talk. So management of refractory ascites in the current era. Refractory ascites is defined as that which cannot be mobilized or early recurrence of which cannot be prevented by medical therapy. And in clinical practice, it is divided into two types: that which occurs due to lack of response to low sodium and diuretic therapy, when it is called diuretic resistant therapy, resistant ascites, or diuretic intractable ascites. Once these patients start developing side effects of optimal doses of diuretics like hyponatremia or hyperkalemia or hypokalemia or encephalopathy, then we call it diuretic intractable ascites. That means we are unable to increase the dose of diuretics to its optimal doses. So this is why it happens, because of this particular pathophysiology, which is a spectrum in the course of the natural history of cirrhosis. It starts with splanchnic vasodilatation, more of it as the liver disease advances, which leads to portosystemic shunting of vasodilators, systemic arterial vasodilatation. This leads to a reduced effective arterial blood volume and blood flow to the kidney. And there is further activation of sympathetic nervous system, renin-angiotensin-aldosterone system, and ADH release, leading to reduced blood flow to the kidneys, reduced GFR and sodium retention, which leads to formation of ascites and ultimately, as the disease progresses, to hepatorenal syndrome. And this is why it is important. Once the patients develop ascites, 5 to 10% ultimately these cirrhotics will develop refractory ascites, and they will have about 50% mortality in 6 months if they develop refractory ascites. And as they progress, they will develop type 2 HRS and then finally type 1 HRS with a very high mortality rate. So what are the options for managing these patients? We all know the first thing we have to do is ensure compliance to low salt diet. And we all know that once the patient develops this, the ultimate treatment is liver transplant. But what are the other options? What we can do short of liver transplant to manage these patients? The medical management includes repeated large volume paracentesis along with albumin, which is given at a dose of 8 grams per liter of ascitic fluid removed, especially when you are removing more than 5 liters of ascitic fluid. This is the first line treatment for refractory ascites. However, the issue of albumin being expensive, so can it be replaced with other plasma expanders? This was a meta-analysis which compared albumin with other plasma expanders. As you can see, the post-paracentesis circulatory dysfunction favored the use of albumin, as well as the mortality rate was lower when albumin was used as compared to other plasma expanders. But can we use lower doses of albumin, again because of the expense? This was the study which compared half the dose of albumin, that is 4 gram of albumin per liter of ascitic fluid removed versus 8 gram. And as you can see in this particular study, although 35 patients were included, the PPCD as well as development of hyponatremia were similar in the two groups. So yes, you can get away by using lower doses also. But this recent study suggested that this was in 57 patients of refractory ascites undergoing LVP. If you removed less than 8 liters of ascitic fluid and gave just above more than 8 gram albumin per liter of ascitic fluid removed, despite 23% patients developing PPCD, there were no significant adverse clinical outcomes. So no mortality, no adverse outcomes related to LVP, but you have to remove less than 8 liters. The second important issue is we all, especially when we deal with non-hepatologists, non-gastroenterologists working in the hospital, especially the patient is in ICU, they would not do an LVP if the patient has coagulopathy, but that is not true. LVP is safe. This was a study of 171 patients, 515 paracentesis, only 1% increased risk of minor cutaneous bleed, despite an INR more than 1.5 and a platelet count less than 50,000. So when you deal with your intensivists, they will tell you, please arrange platelet-rich plasma or FFP before embarking on LVPs. Even your interventional radiologist colleague will also tell you to do that, but you have to hold your ground and tell them that you don't require unnecessary FFPs or platelets. Coming to midodrine, Dr. Virender Singh has a lot of work on this. This is an alpha-adrenergic agonist. This was the initial study in refractory ascites, which told you that midodrine could reverse the basic pathophysiology. 25 cirrhotics, midodrine single dose of 15 milligram, and hemodynamics were recorded 6 hours later. And as you can see, with time, there was an increase in mean arterial pressure and an improvement in systemic vascular resistance. But these effects were less marked in the group who had also had HRS. So more severe the pathophysiology, more difficult to treat with midodrine. Obviously, renal parameters also improved with this. This was a clinical study, 66 cirrhotics with 10 ascites randomized to midodrine, 2.5 milligram thrice a day for 2 weeks versus placebo. There was a significant improvement after 2 weeks in the midodrine group in terms of the body weight, and the abdominal girth also improved. But I agree, these are not very robust markers of improvement with midodrine. This was a study by Dr. Virender Singh's group, 40 patients with refractory ascites, 7.5 milligram thrice a day, plus standard medical therapy versus SMT alone for 3 months. So they gave midodrine for 3 months. And they also showed that the group which received midodrine had a significantly better survival as compared to the group which was given placebo. So coming back to the pathophysiology, another thing which adds to worsening of this pathophysiological mechanism is gut-derived endotoxemia and the subsequent inflammation because of the endotoxins. So in order to reverse that, this study was designed 600 patients with refractory ascites given midodrine plus rifaximin versus standard medical therapy alone, again for 3 months. The group which received midodrine and rifaximin, 78% had complete response versus 15%, and the number of ascitic tappings reduced to 4.5% versus 37.5%. And not only that, they also showed that there was a significant improvement in survival in the midodrine rifaximin group. But unfortunately, these results have not been replicated so far, and there were some methodological flaws in this particular study. So these are the recommendations. ASLD in 2012 suggested that oral midodrine should be considered in a setting of refractory ascites, but I don't know why they have removed this recommendations from the 2021 recommendations. But there are other societies, like this is the British Society of Gastroenterology and British Association for Study of Liver, which still suggests that it may be appropriate to consider midodrine on case-to-case basis in these patients. Coming to TIPS, the second option for refractory ascites, transjugular intrahepatic portosystemic shunts. So does TIPS improve survival? So these are the studies which have compared TIPS versus TAPS, or TAPS being large volume paracentesis. These were the control trials. Till 2004, almost all suggested that there was a significant improvement or control of ascites. But the data on mortality was controversial. And why is that? So I'll come back to that. The meta-analysis of these trials published in 2007 did show that TIPS was associated with a better survival as compared to large volume paracentesis. And these were the patients who did best, those who were less than 50 years of age, bilirubin was less than 1, and sodium was more than 40. Something which is very difficult seen in real clinical practice. Once the patient do develop refractory ascites, you hardly get a patient in this particular group. You will get patients in these two groups. And one of the reasons why they did not show improvement in survival was most of these studies used uncovered stent, and their stent blockage rate was to the tune of 37 to 100%. So do covered stents improve survival? This was an RCT of 62 patients from France, TIPS 29 patients, LVP plus albumin 33 patients. And yes, TIPS was associated with significant better survival as compared to LVP. This time they used PTFE covered TIPS stents. The number of LVPs required was significantly lower in the TIPS group as compared to the LVP. So how much survival does one get after TIPS? In refractory ascites, this was a study which compared refractory ascites with variceal bleed in which TIPS were done. So refractory ascites, the survival was significantly lower as compared to variceal bleed, 29 months versus 60 months. But this was with bare stents. Now with the use of covered stents, this survival is almost, I think, almost double which we can achieve with a covered PTFE stent. So what are the other benefits of TIPS in these patients? In addition to doing large volume paracentesis, the bleeding episode in the group which underwent TIPS were 0. The umbilical hernia rate developing in future were 0 as compared to those who underwent LVP. Effect on renal function, 276 patients with refractory ascites, retrospective MASH controls. Look at the eGFR in the TIPS group. Here the TIPS was done. Post TIPS, there was a progressive improvement in the eGFR or the improvement in renal function. Whereas in the LVP group, with time, the either it declined or remained the same. So renal function also improves after TIPS. So I personally feel that even in patients who are in the group of type 2 HRS, TIPS also benefits these patients. And finally, nutrition. There are other studies also which show that there is improvement in quality of life and other nutritional parameters. But I want to highlight this particular study of 173 TIPS patients for portal hypertension, both bleeders as well as refractory ascites. And they measured the total psoas muscle area and the psoas muscle index. And they found that after TIPS, there was a significant progressive improvement in the muscle mass or improvement in sarcopenia. And this persisted only in those in which the stents remained patent, not in those in which the stents got blocked. So something happened which, I mean, by way of improvement on portal hypertension, by way of creating a shunt, there was an improvement in the muscle mass. Why that happens, no one knows. And there are other studies also which have confirmed this. The issue with TIPS is post-TIPS hepatic encephalopathy. So is this really a myth, or does this really happen? So this was that particular meta-analysis which shows that the probability of developing at least one episode of hepatic encephalopathy was not different in the group which received TIPS or the group which underwent repeated LVPs. However, the HE episodes per patient were higher in the TIPS group. But remember, these were bare stents. And the post-TIPS HE was associated with advanced age, lower MAP, higher MELD score, and lower post-TIPS pressure gradient. When the covered stent was used, this was the RCT, which showed that the incidence of more than equal to grade 2 encephalopathy was similar in the two groups. So early encephalopathy may develop in 80% patients post-TIPS, but if you really are concerned about significant hepatic encephalopathy, that was not different in the two groups. The probability of remaining free of HE was 65% in both the groups. So don't be scared of hepatic encephalopathy unless there are high risk factors for that. So how to select which patients will do well? This was a study of 105 patients, and they showed that those who had a platelet of more than 75 or bilirubin less than 3 had a better survival as compared to the other group. I've already talked about this particular study. And interestingly, people always thought that those who have very low sodium, high bilirubin, high NR, that means poor liver function, will do poorly. So this study on multivariate analysis showed that these parameters did not matter. All that mattered was the type of therapy. Those who were given TIPS survived more. And that brings us to this question: can TIPS benefit patients with advanced liver failure? We've been avoiding TIPS in these patients. So 104 cirrhotics with MELD more than 15 who underwent TIPS. The median MELD was 20. The mean CTP score was 10. And the controls were 104 patients, 44 patients without TIPS. Yes, in the first 2 months, there was higher mortality or need for transplant. But after 2 months, those who survived the initial 2 months, there was a 56% lower risk of dying or requiring liver transplant in the TIPS group. Hepatic hydrothorax, again a manifestation of refractory ascites, 19 patients with refractory hydrothorax. The hydrothorax could be taken care of well by doing a TIPS, and the 1 year mortality was 42%. So 60% patients could be benefited. This finally brings us to long-term albumin drain. This, you tunnel a catheter. It is also called a Plurex catheter, which you also place in a pleural effusion. Tunnel it subcutaneously and place it in the ascitic fluid, the peritoneal space, and connect it to a bag controlled with a valve in which you can intermittently remove the ascitic fluid. So this was a feasibility RCT of 12 weeks use of this long-term ascitic fluid drain versus repeated LVPs. And it was found to be feasible with no worsening of albumin in the two groups at week 12, no worsening of creatinine in the two groups at week 12. So it is feasible and can be done. Yes, there was a minor increase, but minor but controllable increase in risk of subcutaneous infections with the LTAD group. So to summarize, dear colleagues, even though repeated LVPs with albumin is the first line recommended therapy for refractory ascites, addition of midodrine improves control of ascites as it hits the pathophysiology. Combining midodrine with rifaximin can help dry up these patients and improve survival, but we still need more data on this. TIPS, both the bare as well as covered metal stents definitely provide survival advantage in patients who have developed refractory ascites. It also improves the quality of life, the nutritional status, and the risk of bleeding in these patients. The risk of significant hepatic encephalopathy with TIPS is not inferior to the control group. However, we still have to carefully select these patients to have a better result. Age less than 60, bilirubin should be less than 3, platelet should be more than 75,000, low MELD, and high MAP at baseline. Thank you so much for a patient hearing.
Thank you, Dr. Kaushal. The major problem of refractory ascites especially is related to the patient not restricting the sodium intake, or maybe SBP, or maybe they are continuing the high dose of beta blockers, and maybe they are having hyponatremia. These are all factors which are to be considered. And as he has highlighted, the role of the LVP and then the tapes and the midodrine, of course, there are not many studies regarding the use of midodrine. So that's why it has been removed from the latest guidelines. But we need more data to say or the use or this is not useful in patients with the refractory ascites. Yes, Dr. Satpathy.
My question is, in a patient with end-stage renal disease with refractory ascites, is there a role of tips? That's the first question. And my second question is, a patient with a MEL score, you mentioned multiple times that high MEL score, the outcomes are not good. So if a patient's MEL score is driven by acute kidney injury, a MEL score 20 plus, let's say, how do you approach? Would you go for a tips or not in those patients? These two questions.
So I think two different scenarios. One is a patient who's already CKD on possibly on maintenance hemodialysis. Yes, that is a patient where tips might benefit, but a patient who's a cirrhotic with AKI, there I said type 2 HRS is fine, but type 1 HRS with a rapidly developing AKI or AKI HRS, I would avoid tips there.
So in a refractory ascites with ESRD, what would be the mechanism of improvement with the tips in those patients? We're not improving their urine output, their end-stage renal disease.
So I think reducing portal pressure would be the major mechanism there, because you are connecting the portal vein directly to the systemic circulation. So something like a shunt. So intrahepatic shunt would be the one which would be playing the part, not improving the urine output.
Dr. Kaushal, as usual, very clear and concise talk. Before your talk, we almost relegated the tips to the dustbin, because it was very few people who got the tips. But you have repeatedly shown in the trials benefit in mortality vis-a-vis LVP. So, and the conundrum, of course, is that if the patient has very advanced cirrhosis, then we can't go for tips. So, should we decide at the beginning of the refractory ascites that we should go for LVP and we should counsel the patient for tips? And how many patients or a percentage of patients of refractory ascites would actually undergo tips?
Yeah, so I think there are a number of factors which decide whether a patient would choose tips over LVP. One of them is cost also. But if given a choice, if it was not an expensive treatment, then yes, it would be better to counsel the patient early that a tips would be better than continuing with large volume paracentesis repeatedly.
And what is sort of your percentage in clinical practice where sort of refractory ascites would go for tips and get the benefit of mortality?
Less than 20%, less than 20%, less than 20%, maybe even less.
Where are you practicing? If you are practicing in a tertiary care hospital, you may send these patients for the tips. Or, for example, in our place, we use a lot of midodrine, and then very few patients undergo tips.
Sir, my question is regarding midodrine also. What is the maximum possible dose of midodrine we can go up to for refractory ascites? Because in studies, the dose used was quite low.
So up to 10 milligram thrice a day has been described. In the study by Dr. Singh, it was 7.5 milligram thrice a day. So would you want to add to that?
Yeah, we usually start with the 5 mg, and then the maximum 12.5 or even 15 we can give 3 times a day.
Kaushal, what is the status of so-called alpha pump in this?
So alpha pump is very expensive, and I think we have no experience in its use. I even inquired from other interventional radiologists in our country also. They have not had much experience of the use of alpha pump.
Is not so useful. There are only 2 studies and a lot of complications with the alpha pump, and it is very, very costly.
So
yeah, Dr.
So just a conceptual question. Do we need to redefine the definition of refractory ascites in the context of Indian population or the Asian population? How often do you use that maximum dose of diuretics which has been recommended?
I think that's a very important point which he has raised. In real clinical practice, we are not able to go up to 160 milligram of furosemide and 400 milligram of aldactone. I think I have hardly used a dose beyond 300 milligram, and that too in a rare patient I can count on fingers. And furosemide I've never used beyond 80 milligram. And I agree, most of them will develop side effects.
So
yeah, these are very important questions regarding the.
So this side, sir. Yeah,
Okay.
at the back.
Go ahead.
Dr. Kaushal, as we are practicing, most of us, in the periphery, with patients with refractory ascites at the same time having a CKD coming up, does albumin plays any role if you give intermittently in such patients? In order to increase the urine output at the same time, having some amount of.
So if they have early CKD, yes, definitely it will help. And it will be very important to differentiate between a real CKD versus a renal dysfunction, which has happened because of diuretic use or dehydration in these patients. And albumin will definitely improve the second
So we
group of
can give
patients.
intermittent albumin to these patients?
Yes. And I think I'm glad that you pointed this out, the role of intermittent long-term albumin. Whatever studies I'm talking about, the ANSWER trial, that was done in patients who had early ascites. Most physicians tend to extrapolate that for patients who have refractory ascites, but that particular study was done in patients who had early ascites.
Thank you.
See, these are very
That's why I
difficult
did not
patients.
discuss
Those
that.
who have the refractory ascites and the CKD, why unnecessarily drain the funds of the patients? Keep giving the albumin, very minimal benefit of giving albumin in these patients. And regarding the various issues, regarding the definition of refractory ascites, then the diuretics, long-term albumin, we already have a meeting, and the final consensus on the APASL guidelines on the management of ascites is going to be maybe in a few months. It will appear in the Hepatology International. We have already prepared. We were preparing for last 1 year, and now it is almost final. So with that, I think we move on to the next session. Thank you very much.
Thank you.
Thank you for this session. We now have the lunch break. We'll begin again at 2:45. Thank you.
Future beats on the track. Ultra beats on the track. Beats on the track. Ultra beats on the track. on the track. Ultra beats on the track. track. Beats on the track. Ultra beats on the track. natural beats on the track.
Welcome back. Let's begin with the next session. Apart from the academic feast, I'm sure it's a culinary feast as well. Dr. Mamoon will be joining us online at 3 p.m. sharp. For the same, can I please invite Dr. Vivek Raj and Dr. Y.K. Joshi to please moderate this session. How are you? Good to see you too. I would also like to request Dr. Sitaram Chaudhary, Dr. Ankush Bansal, Dr. Rathi Patil, Dr. Srijan Man Pradhan to please chair this session. Actually, he's joining online. Join.
Welcome, Dr. Mahatab. Can you hear us?
Yes, I can hear you.
So now we have post-lunch, very interesting session, but it will be on video, and Dr. Mahatab will be speaking from Bangladesh. So please don't fall asleep. But there is no speaker here. Dr. Mahatab will speak on nasal vaccine for HBV. Dr. Mahatab is working at the Bangbandhu University of Medical Sciences in Bangladesh, and he himself is involved in these multicentric trials. So I think we are going to have something new in this subject. Dr. Mahatab, please.
Can you see my slide, please?
Yes, yes.
So you can see my slides and I'm audible.
Yes, you're audible, sir. And you can see your slides also.
So thank you very much for this opportunity to be here with you today. I'm very sorry. I actually planned to join physically, but I had to postpone my trip yesterday because of the sudden illness of my mother. So hopefully we'll join you next time in some other meeting and next year, CPLD. So anyway, today I have been asked to talk about a nasal vaccine for hepatitis B virus. As we all know that right now we have very good oral antivirals for hepatitis B, but these are not without limitations. For example, these drugs have to be used for long durations, for years together, and sometimes lifelong when the liver is not so good, when we have liver cirrhosis. These drugs are not free from side effects. Resistance is an issue with the ones except tenofovir and tenofovir alafenamide. And if one is non-compliant, which is a common problem in our part of the world, then the headache is more. So given these considerations, not to speak of the funding issue as well, there is extensive clinical research going on all over the world, trying to see whether we can find out a drug that will be of finite duration, which I don't have to use lifelong, and the drug that will give me a healthy liver when I am off treatment, when I am not undergoing treatment, when I am off treatment, that my liver will be okay. So one of the focus is on immune therapy, and here you see a drug called NASVAC, and we are actually involved with the development of this drug, and over the next 15-20 minutes, I will try to share my experience or our experience of NASVAC with you. So So basically, NASVAC is a combination of hepatitis B surface and core antigen. And this is the electronic microscopic view of NASVAC. The drug was synthesized by a Cuban biotechnology company called CIGB, Center for Genetic Engineering and Biotechnology. And we have been involved with the development of the drug ever since. So what is the basis of NASVAC? This is a famous paper by Pierre van de Papelier, where the first time showed that if you use HBsAg based vaccine that we commonly use for Hep B prevention in combination with lamivudine, that can subvert the immune tolerance seen in patients with chronic hepatitis B. And on treatment, patients did show a response with HBV DNA levels. Some became HBV negative as well, but the response was not sustained. This was not the treatment of choice, but this is one of the earliest papers that actually showed that we could try to manipulate the host immune system for controlling hepatitis B virus. We all know that that has been a challenge because the virus itself is a non-hepatotropic virus. It does not cause any harm to the liver. The problem happens when the immune system targets the virus and the liver gets damaged in the process because the viral DNA is integrated with the host DNA. So we have always, the challenge has been that if you trigger the immune system or stimulate the immune system gets activated and attacks the virus, then the liver might get damaged as well. So this is a major concern with developing any immune therapy for hepatitis B. So this was the first paper which showed that yes, we could do something with some sort of immune therapy. And this is a much old paper from the 1990s by M.I.C.E and his colleagues from Germany, which actually shows that people who have a low hepatitis B core antigen in their liver actually have low ALT, low DNA, and better liver histology. This is the only paper of its kind in humans, and it actually gives evidence that if we can target the hepatitis B core antigen, then we may have the desired response. So these two papers are the basis of synthesis of NASVAC, which now has both surface and core antigen. NASVAC is actually the abbreviation of nasal vaccine. It is a therapeutic nasal vaccine. Why we call it nasal vaccine? Because it is one of the first therapeutic vaccines that targeted the nose, nasal mucosa. We all know that the nasal mucosa is the most exposed part of the body and has a high number of immune cells. So it has been shown in transgenic mice that if we apply NASVAC in the nasal mucosa of the transgenic mice, then you can get anti-HBs in the lung and vaginal washes of the mice as well. So lung washes is understandable. When you stimulate the nasal mucosa with the NASVAC and get anti-HBs in the vaginal washes, that is actually encouraging. So based on these evidences, a human animal study in the hepatitis B transgenic mice was actually carried out in Japan, which was subsequently published. We were a part of that research. Subsequently, the Cubans, they did a phase 1 clinical trial in healthy human adults with NASVAC. After these two papers were published, we were considering a phase 1/2 clinical trial in humans with NASVAC, and we conducted that study in Bangladesh, which was subsequently published in Hepatology International. There were 18 treatment-naive chronic hepatitis B patients who were treated with NASVAC. The schedule was that they received 5 doses of only nasal at weekly intervals, and then after 4 weeks interval, they were given another 5 doses, that is the second cycle of both nasal and subcutaneous vaccines. And then they were followed up off treatment at 24 and 48 weeks. The results were very encouraging. With NASVAC, we got increased anti-cytokine production with NASVAC stimulation, which shows that this is an immune modulating agent. And also we got both in EAG positive and EAG negative treatment naive patients, DNA levels did come down at 48 weeks of treatment. Actually, in 50% of the patients, DNA became undetectable. So having these results, especially having seen that NASVAC is safe and has some evidence showing that it may work in hepatitis B, we decided that we will go for a phase 3 clinical trial, which was then conducted also in Bangladesh with me as a principal investigator. We subsequently published the data of this trial in PLOS ONE. There were 160 patients divided into 2 groups, randomized into 2 groups, one receiving NASVAC and the other receiving pegylated interferon, because the only other immune therapy that we know of that works in hepatitis B virus infection is pegylated is interferon. Although it's a non-specific immune stimulant, not that unlike NASVAC, it stimulates B-specific immunity. Anyway, this trial was done. The schedule of interferon was as usual, weekly doses of 48 weeks. NASVAC, it was given like before in the phase 1 clinical trial, 5 nasal followed by 5 nasal plus subcutaneous doses. And like the phase 1 clinical trial, patients were followed up to 24 and 48 weeks of treatment. So the drug was found to be very safe, both nasal and nasal plus subcutaneous injections in humans. No safety issues were there. None of the patients had any major issues, and none had to be discontinued for this drug side effect. And this was very interesting. After the nasal administrations, there was a rise in ALT, and during the 1 month gap, 4 weeks gap, the ALT came down brilliantly without any interference in the NASVAC treated groups. This is a indicator of immune response in these patients. With the interferon treated group, we also saw a rise in ALT, but you see that rise was desired, not as much as the NASVAC group, and some did not come down. So we found that the immune modulation effect was of NASVAC was there, as was evidence in phase 1 through clinical trials as well. And as clinicians, we are more interested in the levels of ALT and HbAg and DNA. These are all these boxes that show the responses, where you can see that NASVAC was better compared to pegylated interferon in all terms. But for the sake of time, I will draw your attention to the last box. Here you see that in interferon group of treatment, 9.2% patients develop advanced fibrosis, which can be defined as cirrhosis. But in the NASVAC group, none of the patients of treatment at 48 weeks developed any liver cirrhosis. So this was very encouraging. So here we thought that we have some evidence of a drug that can be given for a finite definite duration, or that is 10 doses, 6 months, and that off treatment helps the liver, and none of the patients, although a small group, did not have progression to liver disease. I know you'd like to know the response in of HbA1c. So this was the response with treatment with interferon. While on treatment, the HbA1c came down, but off treatment, it bounced back. In case of NASVAC, HbA1c remained steady during on treatment, but off treatment, we found a decline in HbA1c. So this was also an evidence of late immune response by NASVAC, which is also perhaps evidence clinically, as I showed in my previous slide. Very recently, we have published the 2-year off-treatment follow-up data of NASVAC in a journal called Pathogens. And there we saw that the patients who received NASVAC, 66 out of 78 patients were on our follow-up at 2 years of treatment. None of them developed liver cirrhosis, and other responses were also more or less well sustained. Then we have recently published our 3-year follow-up data in a journal called Vaccines. Here also, 59 out of 78 patients who were included in the phase 3 clinical trial for NASVAC. They received, none of them developed liver cirrhosis. Right now, our 5-year clinical off-treatment data is under submission, under revision in a major journal. And I can tell you that there also, we have not seen any patient who has developed liver cirrhosis. We are now analyzing the 10-year off-treatment follow-up data of the NASVAC group. So I can tell you that 10 years have passed since the phase 3 clinical trial was conducted in NASVAC. All patients are surviving, and none of them actually has advanced liver disease, so to say. But the 5-year and 10-year off-treatment data are yet to be published. This is a non-published data that I'm sharing with you. The Japanese are now conducting a major clinical trial of NASVAC. 8 different Japanese public universities, where we are also collaborating, have studied human trial. And there you see some initial data from the Japanese patients, where you see that there's a decline in HbA1c with NASVAC, both in chronic hepatitis B, on nucleic acid analogs and asymptomatic carriers. Not only that, interestingly, they have also noticed a rise in anti-HbS in these treatment experienced patients, Japanese patients who are now being treated with NASVAC. So this is very interesting, encouraging data that is coming from NASVAC. So after the data of NASVAC was published, the phase 3 paper was published. This is a status from the Prime Minister's Office Library of Bangladesh, encouraging the NASVAC research. This is Dr. Fazl Akbar, many of whom you may know. He's familiar to the Indian hepatology community. He is the senior research partner of in this research. And this is a Facebook status, a website status of the Viral Hepatitis Foundation of USA in 2021, who have defined NASVAC as the most efficient prospective immune therapy for chronic hepatitis B of the coming days. So these are two more recognitions of NASVAC, and for the discovery of NASVAC, the team that worked for NASVAC, including me, we received the Premium National, the highest scientific award of the Cuban Science Academy of Science in 2019. And in 2021, I was awarded the Bangladesh Academy of Sciences Gold Medal for the NASVAC research. What is the current status of NASVAC? NASVAC, based on our clinical trial, is now registered in Cuba. This is the registration certificate of NASDAQ in Cuba. This is a product as it looks in the Cuban market. And here's the product insert. It is registered in 4 more countries. Bangladesh, what is the status of Bangladesh? Our drug administration approved the recipe of NASDAQ before COVID. And COVID since stopped everything, but we are expecting NASDAQ to be commercialized in Bangladesh market by the end of this year or early next year. Right now, we are working on another clinical trial of NASVAC at the Bangabandhu Sheikh Mujib Medical University, where I work in Dhaka. We have selected a group of treatment experienced patients with chronic hepatitis B, where some are getting NASVAC in addition to nucleoside and nucleotide analog. In the other group, we have stopped nucleoside and or nucleotide analog and added NASVAC. So this is a very unique trial because for the first time in the world, a group of patients who have been on nuke has been stopped and replaced by immune therapy. We don't have the data to present as of now. We have just finished this part, the only nasal treatment, and the first dose of nasal plus subcutaneous had been administered last week. As of now, I can tell you that none of the patients have any adverse event, no B virus flu, nothing. They're doing very well. And we hope to present the data of this paper as well as our 5 and 10 year off treatment data to you in the next meeting that will be hosted by Sir Ganga Ram Hospital and Dr. Anil in 2023, hopefully. So that was all that I had to say, share with you today. Thank you very much.
Thank you, Dr. Mehtab. That was a very quick and excellent review of all the new things that are happening in the field of therapeutic vaccines. So one question, we'll open it up to the audience also. Any possibility of this being used as a primary prophylaxis also, or that is something that is not quite likely?
Pardon, can you please repeat the question? I couldn't follow, sorry.
No, the question is, will there be any role for nasal vaccines in primary prophylaxis, if possible?
A very good question to ask because when the phase 1 healthy volunteer trial in humans was conducted in Cuba, they did see that it also induces protective immunity. And right now we are planning a trial in Bangladesh where we will be giving a group of healthy individuals, non-vaccinated individuals. We'll expose them to 3 doses of nasal vaccine to see whether it produces preventive protective immunity. And we think that is going to happen. If does happen, this will be another game changer. Because now when we look at 2020, 2030 and look for eradication, if we have a nasal vaccine, we apply for 3 days at the, in 1.5 months time, it gives you immunity. That will be something very exciting.
Dr. Mamun, this is Dr. Ashish here. Excellent presentation. My question is, how do you see use of this vaccine post liver transplant when immunosuppression is going on? So will it be effective? Will it work that time? Post liver transplant.
If you ask me, Ashish, whether we have the data or not, then I will say that we only have the data of chronic hepatitis B as of now. But what I think is, from our experience, a very safe drug. For example, the patients were taking tenofovir alafenamide, they have been stopped, and they have added NASVAC. None has any flare, nothing. So I think eventually this will prove to be a safe drug in any scenario, in cirrhosis, post-transplant, in all situations.
Mamun, for the first time, we are missing you physically over here. I hope all is well.
You are not missing me as much as I'm missing you and your meeting.
Okay. My question is, what does it target? Does it target the CCC DNA or even a integrated DNA? Does it ever cure the disease, the NASVAC?
That is something we don't know actually, Dr. Arora. What we know is that it induces a immune response, but whether it's targeted the cccDNA, the exact mechanism, that is something we haven't looked at. And to be very frank with you, with our limited resources, it is very difficult for us to look at or explore such issues also.
So do you have any data of the 5-year follow-up which you have? What has happened to the anti-HBS antibody following NASVAC therapy? And secondly, do you have any data to look at the cccDNA in the hepatocytes of those who have been treated?
We have stored samples, so we are looking at the HBsAg levels now. We don't have the data in hand, but cccDNA we can't look at because we don't have the liver biopsy specimen. That is not doable. But I have showed you the Japanese data. There they have seen HBsAg coming down in at least 50% patients, and 44% plus patients are actually developing anti-HBs. So that is also very encouraging.
Dr. Mehtab, this is Dr. Sitaram from Nepal, Kathmandu, Nepal. Looks very nice, but is it in trial phase in Bangladesh, or you are likely to have it in the government policy of immunization in Bangladesh? When? And
Actually,
one more thing, how much is the side effects? Is it one time or you repeat this nasal vaccine? Is there any dangerous side effects also?
Dr. Sitaram, we are open to clinical trials. The issue is that there are two limitations. One is so far the product was a Cuban product. So we were not on control of the product fully. But as it will soon become a Bangladeshi product, will be manufactured in Bangladesh, and we'll have the liberty more. But right now, as I was telling you, there's a Japanese trial going on involving Japanese human patients in 9 different Japanese universities. So that is very encouraging. So we are open to such options once this drug comes to Bangladesh. Then it will be we will have more mobility. If you consider the side effects, I have highlighted that none of the patients even have any adverse event after stopping nuke, who are taking nukes. In the phase 1-2 clinical trial, phase 3 clinical that we have conducted, none of the patients had to be discontinued for any adverse event. It's very mild, sneezing, and very, as such, the very safe drug.
Thank you. Thank you.
Any other question?
Dr. Mahatab, I have one question. Since we have to give multiple doses within 2-3 weeks times, how is the compliance of the patient? Is it difficult to trace all these people and put drops 10-15 times in 2-3 weeks? Number one. And number two, what will be the cost of these things? Suppose it comes as a commercial preparation.
So compliance is difficult to comment as of now, because right now in Japan or in Bangladesh, patients have got that drug as part of clinical trials, so the compliance was ensured. In the markets that is now available, for example, Cuba, then Honduras, then Nicaragua, Angola, all these markets are actually regulated markets where the drug is given free from the government or through some government project. So there the system ensures compliance. So, but injection is always something that at least our part of the globe does not want to accept. So our aim is to make it an entirely nasal one. And in the next phase, we are planning on that whether we can only apply the nasal drug. Whether it has to be repeated is a $1 million question that I cannot answer. But I think these trials are needed, whether we should increase the dose, or whether we should have repeated doses. Why only 10 doses? Why not 15? Why not 5? These are the questions that have to be answered over the next few years. But sitting in Bangladesh only with limited, efforts, it is always not possible for us, to answer all these questions. But I think if we have the drug in Bangladesh market, we'll have more liberty to collaborate with more people to look into those issues.
Well, I think we'll close the session. Thank you so much, Dr. Mehtab. This was an excellent presentation, and we look forward to more research. And as the drug becomes available, more data coming out from your center. And hopefully next time we'll be able to meet you in person also. Thank you. And then we'll collaborate with you also.
Thank you,
All right,
sir.
take care.
Sir, we'll request you for a picture. Center me. Haan ji, sir. Haan ji, ji. I'll invite the next We'll begin with the Pancreato-Biliary session now. For this, I will invite Dr. Ajay Kumar and Dr. G.S. Lamba to please moderate the session. I would also request Dr. G.K. Pathak, Dr. Ajay Gupta, Dr. Meherajuddin Khan, Dr. Achyut B. Hamal to please chair this session.
Hello. So we begin this Pancreatico-Biliary session with a very important lecture, and it is basically on based on a complication which we all of us fear a lot, which causes a lot of stress to any endoscopist, and which is probably the cause for maximum litigation post-ERCP, and that is post-ERCP pancreatitis. So we now have Dr. Manu Tandon with us today, who will tell us how best we can prevent this complication. Is it really inevitable? If it has to happen, it will happen, or there are ways to prevent it, and how to manage this. So I'll invite Dr. Manu Tandon, and I think this all knows Dr. Manu Tandon very well. He's a senior consultant at Asian Institute of Gastroenterology, Hyderabad, and he'll talk about prevention of post-ERCP pancreatitis.
Thank you, Lamba. And I'd like to begin by thanking Anil and the team. Ashish is here for the privilege of today's talk. Well, as Lamba said, it's a complication that we all know, we all fear. What I'm going to do in the next 20 minutes is go through a review of what all is available today, our knowledge today on how to look after post-ERCP and how best to prevent it. So we'll begin with this historical slide. Kawai and Klassen, 73 pioneers of endoscopic sphincterotomy to relieve biliary obstruction. They performed a surgical procedure. And like any other surgical procedure, this will also have its own complications. So this is how it all started. We have moved on, the complications remain. Well, what is the aim? Why are we talking about all this? This is the consensus that has come out that by and large, 90% to 95% units should have success in achieving what they have started to achieve at ERCP, and we should have a complication rate of less than 10%. 3 to 7 is what most agree. It may be a little higher for community endoscopists and lower, the success rate and complications both, and lower for the specialists. Their success rate should be higher, complications lower. All of us knew about post-ERCP complications, but this landmark article, Martin Freeman's in New England Journal, I think really awoke us to what all we should be aware of. And it has been quoted innumerable times and remains the paper for the complications of ERCP. The list is given here. It could be sedation related or procedure related. And I've highlighted pancreatitis because that's the only thing we are going to talk today in this talk. And this is how we are going to discuss it. So let's begin by incidence and mortality. Pancreatitis, Lamba just told you, feared, is the commonest of the complications. And incidence ranging now for practical purpose below 10%, but 3 to 7 may be more practical. Mortality of all the complications, the highest. I'm not talking about elderly and the sedation and anesthesia associated complications. We'll leave that away because I'm talking purely of the procedure related complications. So this is how it is. About 20 years back, Martin Freeman, after that initial review, in fact, he was with us at this time when he said that this is the figures that he again looked up all across US. And overall, there was a 10% incidence of pancreatitis. I feel with improving techniques, it has probably come down a little lower than that. The importance, the improvement in techniques I just mentioned, the importance of expertise cannot be overstressed. Here you see, as the centers which have lower and lower numbers perform ERCPs, their complication rate is higher. So, question, experience, expertise do matter. Unfortunately, none of us can define what is a low volume center. Is it 100, 200, 500 a year or more? So that remains a debate, but expertise matters. All of us know the Atlanta classification, mild, moderate, severe. I'd get you back to Dr. Peter Cotton's classification, the original classification of post-ERCP pancreatitis. He divided it into mild, moderate, and severe. Mild, where the patient was less than 3 days, needed no intervention and recovered. Between 4 and 10 days, if he needed hospitalization, it was moderate. And beyond that, either complication or intervention or death, then it is severe. So this was the range of the pancreatitis that you can get post ERCP. Of course, I'm not going to read through the Atlanta classification. All of us use it day in and day out. So coming to the gist of the talk, how best we minimize this. It's going to happen. It's going to happen to anyone who's doing ERCP. It's happened to me. It's happened to all the champions sitting in the audience. I'm sure Lamba and my co-chair people also would have experienced it. And this is how we'll take it. Careful case selection. There's nothing to beat that. Identification or risk stratification. A sound ERCP technique. And then once you determine the risk status either pre or during the procedure, pharmacotherapy, maintenance of patency of MPD, and hydration. This is what is going to help. I am not going to talk about fully established pancreatitis because Pramod is speaking next and he's going to talk about it, but that is as any other pancreatitis. So this is all peri-procedural. So to paraphrase Nike, just because you know ERCP doesn't mean you have to do it. So just don't do it. And if you have a different alternative, an MR or an US for diagnosis, please use it. So unless strongly indicated, please do not do the procedure. And then look at the risk factors. Now the risk factors have been divided into operator related, patient related, and procedure related. And we'll go over this. Operator related mostly are experience. I told you the value of experience and expertise cannot be substituted as far as an ERCP procedure is there. We'll come to the patient-related factors and the procedure-related factor during the course of the talk. Many studies, many of them, multivariate analysis, various risk factors, they may vary, but by and large, young person, when you inject repeatedly into the pancreatic duct, if there's a past history of SOD or a past history of PEP, as we call it, all of them and certain procedures, minor papilla sphincterotomy, a pre-cut ampulectomy, all of them predispose to the development of PEP. And Martin Freeman himself, you see the last line in that yellow part, if you are a female with a normal bilirubin and have a SOD, sphincter of Oddi dysfunction with the difficult cannulation, your cumulative incidence is 42%, means 1 out of 2 is going to develop PEP. So this is the extent where you should take care. I'm not going to go into the pathogenesis, but a number of factors, sphincter spasm, infection, contrast toxicity, thermal, all irritate, activate the proteolytic enzymes, leading to the development of pancreatitis. But a good marker for us, a little amount of pain is there in almost all patients. If your amylase values after the procedure within 4 hours are less than 1.5 times normal, it's a good negative predictive value. Your chances of getting PEP are minimal. Vice versa, if your values are very high at 4 to 6 hours, chances rise. So that was selection and not showing your expertise. Does the patient need? Identify the risk factors. And now, what do you do during the procedure? Difficult biliary cannulation, all of us has faced. Lamba, all of us have faced that. How do you define that? If you touch the papilla 5 or more times. Now this is tough. Some people say just a touch. Some people say if you needle it a little. More than 5 times, or if 5 minutes of cannulation, or if there's an unintended cannulation of the PD, then it is considered a difficult biliary cannulation. And why is it important? Because you have made 1 to 5 attempts, your chances of pancreatitis are 3. More than 15 attempts, 13%. And in that case, please, there is a saying that if you have to do a pre-cut and the experience will tell you you're not going to cannulate, do the pre-cut early in such cases. Now, pre-cut itself is an independent risk factors. I think as important as your expertise is the help of your assistant. He is vital, not only in manipulating, let us say, a hydrophilic guide wire through a tight situation, stricture or a tight stone, but when injecting contrast also. Because the crucial thing is that do not ascenerize the pancreas, do not over-inject contrast when you are doing a procedure. People today prefer guide wire, I'm coming to that, but sometimes you do need contrast, especially if you are looking at leaks, etc. in the system. So be very careful. And why am I saying that? Because see this set of 4 figures, the one on the extreme left, minimal contrast, pancreatitis less than 1%. See on the right, full contrast and little has gone in the acini also, close to 9% pancreatitis. So the degree at which you or your assistant push the contrast in the PD is partly responsible for increasing the incidence. And you would see in many workshops, the champions, they inject their own contrast. They, irrespective of how good your assistant, they have confidence in their own fingers. And then we had this study, and since then guide wire cannulation has become very important. If you use a guide wire, your incidence of PEP drastically reduces. So what do you do? Or ask your assistant, do a guide wire assistant. And if you are doing a sphincterotomy, go for it early. And opacification, if needed, of the PD should be minimal. Okay, you have done all this, and yet you feel that somewhere there is that sixth sense saying that this patient is going to land up into trouble. So what are your peri-procedural modalities to help reduce this incidence? The first is pharmacotherapy, and then you have stenting, and then hydration in the accepted knowledge. ESG divided drugs in 3 groups, which are definitely effective, partly effective, and which have not been effective. And the list is given here. I'll go back to it again. We will take up only drugs with proven efficiency and a few of the doubtful ones. The only one with absolute proof is the non-steroidal anti-inflammatory drug, and Joe Elmanzer's, whom we in 2012 in New England Journal with this original article just about established that rectal indomethacin is probably the best pharma prophylaxis that we can give to prevent PEP. And his landmark study, all PEP reduced, severity reduced, GI bleed and renal failure were minimal, not higher than placebo, indicating that it is the drug of choice. And when you give NSAIDs, the questions answered are, whom do we give? Do we give it to everyone or only to high-risk patient? Now, this remains debatable yet. The jury is still out on this question. There are studies which say that in high-risk patient, there is no use of giving indomethacin rectally. Other people say that you should give it in everyone, and you have studies supporting each one of them. So I think the choice is yours. I'll tell you, at my institute, it has become that we use a rectal indomethacin suppository for every patient who's undergoing ERCP. That's at my institute, but this is a topic of debate. The second question is timing. When do we give it? Big studies, I'll mention this later. The bottom line is ideally suited 30 minutes before you do the procedure. And third, which is the best route? Why not give it intravenous, intramuscular? Why take the trouble, take a separate consent that you're passing it rectally, etc., etc.? Well, these are the studies. Meta-analysis going on to show that rectally induced introduced indomethacin is most effective. The lower study is the same one where they gave half an hour before ERCP and post ERCP and found in high-risk patients 560, fairly large numbers. PEP was reduced in half if you gave it before the procedure. Now, obviously, indomethacin is not very easily available then. Diclofenac was, so there were comparisons, and this study showed that they are similar. But we, at least at our unit, continue to use rectal indomethacin. And then once you have some efficacy, combinations will come. Somatostatin was earlier touted as a drug which reduced secretion. Will a combination help? This study says it did help, but they said the numbers are very small. Higher studies are needed. The second way we can reduce is to keep the PD patent. And this is one of the earliest studies where a clear-cut improvement in reduction of PEP after prophylactic stenting. This is one of the earliest studies. And this is how it works. You see the first figure, normal. Second figure, edematous papilla, block the PD and the CVD because we have touched 5 times or more, a difficult cannulation. And the third figure, you maintain the luminal patency by introducing in a stent. So this is the purpose of putting in a PD stent. And this is from one of our archives. I have not taken a video. Classical, we are going for a pre-cut. Papilla is not very big. Ideally, a case for prophylactic PD stenting, which I have shown you here. And ESG gives clear-cut recommendations. The only thing that it adds is the removal of retained prophylactic PD stents may itself cause a little pancreatitis. So that's a limitation of prophylactic PD stenting. And then a number of studies showing both benefit. All of them favor prophylactic PD stenting. There's just one which showed a little odds ratio. So the guidelines are very clear. Small stent, lower diameter, 80% will drop off in 14 days. The others you remove after that time. What do we do at our institute, which is a high volume center? We prefer a 5 French 5 centimeter plastic stent. Ask the deuterium not to put in a flap so that it can drop by itself, but only 70, 75 drop out. The rest we still have to go in once. So that is one of the drawbacks of PD stenting, and I've listed just some of them. That prophylactic PD stenting which we want to do, we may not be successful. Second, you increase the cost of a stent, you increase procedure time. That itself may induce pancreatitis. And finally, you may require a second procedure to get rid of the prophylactic stent. So this also has got its limitations. And then comparisons come cost-wise, and however they worked out the economics, they felt rectal indomethacin was cheaper than, equally efficacious and cheaper than a pancreatic stent. The third way of knowing is IV hydration. ESG is given definite guidelines, a little complicated during the procedure, post-procedural and otherwise. The practical approach is 3 liters during the peri-procedural period, 2 to 200 ml per hour for the next 8 hours for all high-risk patients. Again, backed by numerous studies. This is just one of them showing the reduction in incidence. Again, they combined lactated ringer with indomethacin. See the chart to the extreme. That's right for you all. Indomethacin and lactated ringer combination, the best in reducing PEP. Our own study, Roop is studying here. Roop is sitting with me. We use peri-procedural fluid in close to 1,000 patients with excellent results in reducing the amount of fluid. Again, combination studies, and I can see this chart, meta-analysis. Everything favors must go in for prophylaxis, single or in combination. That issue is not decided. It is left to individuals and their units to decide on the same. Few slides on what are the other agents that have been used. Well, someone doesn't tolerate rectal indomethacin, nitrates are the best option. We will take each of these one by one. Nitrates, when people cannot tolerate, either aggressive hydration or NSAIDs help in reducing PEP. This is another study, John Hopkins. Roop is again here. All of us contributed in this study. It was done in 3 centers in India. The basis what they felt that if you diluted epinephrine, adrenaline, if you spray on the ampulla, the edema reduces and that will maintain the patency. Unfortunately, out of close to 1,000 patients, we did not find a difference when only an NSAID was used or an NSAID was used along with epinephrine. But there are supporters who continue to say that topical spray of 20 ml of diluted adrenaline can help reduce PEP. Then we had the protease inhibitors, something which prevent enzyme activation. Gabaxate used, also rejected. Ulinastatin, I have no experience, neither does my institute. Dr. VGM from Coimbatore has done some work, found it to be beneficial. A few meta-analysis say so, but I think the question is still unanswered. If someone in the audience has got better experience with that, fine. This was a new potent inhibitor of trypsin, 20 milligrams used 6 hours before administration, but not found to be useful in high-risk cases, expensive, and most important, not available with us. So the final 2 slides, what do we do? This is the protocol we follow at my institute. We give IV hydration to everyone. Yeah, give me 2 minutes, I finish. Routine rectal endomethacin, sir. If you find that you have touched the PD or gone involuntarily, then put in a PD stent and continue post-procedure hydration. This is the standard protocol for highest risk at our institute. So the 3 Ps are patient selection, proper procedural techniques, and prophylaxis. This is how we are going to minimize it. None of us are going to get rid of it. As Lamba said, we'll face it, we'll worry about it, but with these things that I have listed out, we'll do our best to minimize. And I end with the last slide. Again, Cotton, who's been, of course, a pioneer in therapeutic pancreatic and biliary endoscopy. ERCP is most dangerous for people who least require it. So that is where your judgment matters. Thank you. Thank you for your patient listening.
Thank you, Dr. Manu. And that was really excellent and a very comprehensive coverage of the subject. So I think we can have few questions because you have finished very well in time.
Is it? Okay, I thought there was a bell which went on, Yes, Chaubal. Chaubal himself is a master. I don't know why he's asking me this.
What is the mechanism? Why it's the rectal endomethacin or rectally administered NSAIDs act?
We asked the same question to the people. Yes. In fact, I had the fortune, since I do a little amount of work here and there on pancreas, with Almanzar. In fact, direct question to him and he said, don't ask me. This is his answer. This was directly asked to Almanzar, who had, I think it was 216 or something in Charleston. He's with Peter Cotton's unit. He said, don't ask me.
So I should also not ask the same.
No, not this question.
Okay.
The answer will be the same.
You see, when you are doing ERCPs, especially in a tertiary center like ours or yours, patient comes with a limited amount of money.
Agreed.
Okay, and by the time you have pancreatitis, that cost becomes astronomical.
Not only for him, your sleep for 30 days is gone, Anil. Absolutely. The enjoyment I have of doing 30 days, 1 PEP and it's lost.
I agree. Then when you have all the different modalities which are trying to undo the injury caused by ERCP, like IV fluids, endomethacin, and pancreatic stent, why not use all 3 in which you anticipate?
You saw the last slide?
So that is exactly what we do. Rather than looking at individual
I also
parts.
have put, I think, we have now 2 units, as you know, AIG runs in 2 units. At least the place where it's a written rule that
all 3.
All 3.
Yes, I agree.
Because the cost of this is less than 1,000. 1 day of admission and, blown.
You'll go for all 3 even if you have not cannulated PD?
Yes. No, not cannulated PD, then I don't
Then you
generally
don't need.
yeah, PD. But
So I think
IV rectal endomycin is a must.
Endomycin and fluids, everybody I think
yes,
now is
yes,
using because it's a
yes.
totally harmless thing,
And
except for any
the
special
third one
contraindications.
comes as you do the procedure, you know you are done something which needs, then PD. Otherwise, two are a must.
One question, sir, there's some controversy about what is the length of the stent to be used for prophylaxis. Is the 3 centimeter
yeah.
better than 5?
Todd was with us for a month. Todd gave the theory that use a 3 centimeter stent because he felt that the distal on the stent, if it hits the genu, you will get a de novo stricture even in 2 weeks. That was his theory, and he kept insisting that 3 centimeters, 3 French is the best. The distal end, which is in a undamaged PD, will produce. But we didn't publish it. When he was there, we put alternately 3 and 5, and we are happy with 5 French.
One more question in this respect, that when do we remove the stent? Because usually patient goes for a cholecystectomy and then we remove it at 4 weeks. And suppose the PD stent doesn't fall off.
We do it.
Do
then
we call
only.
him
No,
at 2 weeks?
4 weeks. We call him
Because
at
then
one time.
it adds to another procedure.
One more extra procedure again, sedation.
Keeping it for 4 weeks would be
Nothing
safe?
will happen. Yes.
Nothing.
See, that was the study we did because Todd Barron was there for 2 months with us. And we saw that none of them had a de novo pancreas stricture. None of them. Unfortunately, not published. The resident didn't fill up the data. So,
the chairperson.
Sometimes the surgeons insist that lap cholecystectomy and ERCP in the same sitting. So they are giving the guide wire from the
in fact,
and then it is eliminating the risk of pancreatitis because we're sure that you can undo the guide wire, and I did it just 2-3 times.
Yes, in fact, not only that, I have seen new people, relatively fresh laparoscopy wanting us to put a stent. It will prevent them from damaging the cystic duct and the main duct. They insist you push in a stent. You clear whether you have, even if you have cleared, they insist you push in a stent. That's for their convenience. We do it on request, not with the established people.
Dr. Shaukat.
Zargar,
Dr. Manu, excellent actually discourse on the subject. How difficult it is technically to put 3 French versus 5 French? Because I feel 3 French is
terrible.
difficult to push.
3 French, your wire, we stopped doing 3 French. We wanted to oppose Todd Barron's thesis and we stuck to 5. Very tough. I don't know if how many of you do it, bends, pops out.
Because
bends, pops out.
3
Yes.
French is very difficult to put technically. I think that's why 5 is.
So for us, it's out. But it is there in the ESG guidelines is still 5, but there are papers on 3 French, 8 centimeters.
You know, if you remember, I presented in the preliminary session before this publication came in NEGM. Probably you missed it on 960 patients.
Oh, yeah, we did it.
Yeah, and we showed that time that if you use indomethacin, which was available with us, it reduced pancreatitis, but unfortunately could not publish it because the concerned resident, he went to other country along with the data.
This 960 Roop is here. We both were there in San Diego is where we started. Took 2 years, but we got the data, but it didn't make it. This was with with spray of Adrenaline, it didn't make a difference.
I think we've got the signal from the organizers. We have to wind up here, sir.
Yes.
Thank you. Thank you for the excellent talk and very good question answers. Thank you. Thank you, Chairperson.
Thank you for the session. For the next session, can I please invite Dr. Harsh Kapoor and Dr. Vikram Bhatia to please moderate this session. I would also like to request Dr. Arun Kumar Singh, Dr. Abhinav Arora, Dr. Sajan Agarwal, and Dr. Rajneesh Gulati to please chair this session.
Hello. Hello. I think we are ready for the next session. It is regarding cystic lesion of pancreas, how to manage. And we'll request Dr. S.S. Rana come and deliver the lecture. Thank you.
Thank you, Chairpersons. Good evening, ladies and gentlemen. At the outset, I would like to thank Professor Anil Arora and Dr. Ashish and team Ganga Ram for inviting me and giving me an opportunity to be here. I have been asked to speak on cystic lesions of pancreas, how to manage. So we all know that of late, we are seeing a lot of patients with pancreatic cystic lesions. They are discovered incidentally because of increased use of abdominal imaging, as well as increased aging population. So we know that there is a broad differential diagnosis when we see pancreatic cystic lesions. It can be either cystic neoplasms, non-neoplastic lesions, or solid tumors with cystic degeneration. But the clinical dilemma we face is that majority of these patients are asymptomatic. Majority of these are benign, and the risk of malignancy in pancreatic cysts is very, very low to the tune of 0.01%. So despite increasing literature on this topic over last decade, the workup and management of these patients remains both confusing and problematic for both the clinician as well as the patient. There are multiple guidelines with varying recommendations, and none of these guidelines are perfect. And the most ideal balance of surveillance and intervention for specific lesions remains highly debated. So if you look at proper management of pancreatic cystic lesion, it involves detailed understanding of various types of pancreatic cystic neoplasms, associated malignancy risk. Then once we have looked at the malignancy risk, the guidelines for surveillance and intervention, and the cost analysis of each of these guidelines and their recommendations. We all know that broadly there are 4 major types of pancreatic cystic neoplasm, the most common being IPMN, followed by mucinous cystic neoplasm, then serous cystic neoplasm, and the rarest are SPEN. But then out of these 4, these 2 are the ones which gives us most difficulty in differential diagnosis. The serous cystic neoplasms and SPEN are most of them diagnosed comfortably on imaging and FNA. Serous cystic neoplasms don't need any surveillance as the malignancy risk is practically 0, and surgery is recommended only if the patient is symptomatic. Whereas in patients who have SPEN and cystic neuroendocrine tumors, which are more than 2 centimeters in size, surgical resection is recommended. So it's fairly clear in these 2 type of cystic neoplasms. Now, for the other neoplasms, what we have to look is what are the factors which are associated with increased risk of malignancies. So this is a meta-analysis which has looked at the various factors which predict the risk of malignancy. If the cyst size is more than 3 centimeters, the odds ratio for malignant cyst is 3. If it's solid component, then the odds ratio is much higher, it's 7.7. And if the duct is dilated, the odds ratio is 2.4. So if all 3 factors are present, the risk of malignancy is very higher. If you have to look at one single component, it is the solid component with the cyst, which has got the highest predictive value for risk of malignancy. One of the important things which we need to remember is that there is no association between the risk of malignancy and cyst enlargement over time, because many of us start believing that if cyst is increasing in size, it's malignant. So that's untrue. Studies have looked at the risk of malignancy and the cyst size enlargement, and there is no correlation. So when we see cystic neoplasm, there are 2 key questions which we need to answer. The first step is whether it's a mucinous or a non-mucinous cyst. And second is, if it's a mucinous cyst, whether it's an NCN, main duct IPMN, or a mixed duct IPMN, or it's a branch duct IPMN, because the risk of malignancy depends upon the type of mucinous neoplasm. So if we look at literature, there are a number of guidelines. None of these guidelines are perfect, as I had highlighted earlier. And either these guidelines are less sensitive. If they become more sensitive, then they are less specific. So the appropriate approach to evaluation of pancreatic cyst, which I'm going to talk about in the next 10 minutes, will be based on the current knowledge and our experience at PGI. First is look at the symptoms. If the patient is symptomatic and there is a straightforward symptom like jaundice because of obstruction, there is nothing much you have to offer. The patient has to be offered surgery because the cyst itself is cause of obstruction, irrespective of whether it's benign or malignant, it requires removal. However, majority of these patients will have non-specific abdominal symptoms like abdominal pain, which are usually not attributed to cyst. So then you need to further work up the case. And if the patient is having pancreatitis and there is a cyst, then one needs to have a little bit caution because some of these patients may have malignancy causing pancreatitis. So to sum up, symptomatic cysts are more likely to be malignant and surgery should be offered. But as I have already told you, none of these symptoms are specific, so we need to look at the blood markers. But again, unfortunately, there is no DNA, RNA, or a protein biomarker in blood which can be used in clinical practice to differentiate between either the various cyst types or identify the high-risk cysts. CA19-9, which is quite commonly used in pancreatic cancer, is again of no use in pancreatic cystic lesions. But then in patients who have a diagnosed IPMN, it can be used as a serial marker for looking at malignant transformation. So we have to rely on cross-sectional imaging, and MRCP is usually the first step in these patients with pancreatic cystic lesions. So as I've already highlighted, the features which can identify the risk of malignancy are the size, solid component, and the duct diameter. However, there are certain factors in MR, features in MR, which can help in identifying serous cystic neoplasms and SPEN. Serous cystic neoplasm, the classical ones, usually have a microcystic appearance with a central scar or sunburst calcification. And on contrast MR, they take up the contrast. So if these features are present, these are quite specific for serous cystic neoplasm. And similarly, mucinous cystic neoplasms, majority of them will not have any classical symptoms. But if it has got a eccentric calcification, then it probably suggests a possibility of a mucinous cystic neoplasm. If you have a dilated main pancreatic duct with nodules, which is seen in about 20% patients with an IPMN on MR, and that nodule is enhancing on contrast, that suggests a possibility of IPMN. And SPEN usually have a well-demarcated mixed solid cystic lesion, which is quite characteristic on contrast MR. So MR can help you in differentiating serous cystic neoplasm and SPEN from the other causes of cystic neoplasms. But then only 30% of patients will have a classical features on MR. So you have to further investigate the patient, and the next investigation done commonly is endoscopic ultrasound and followed by a fine needle aspiration of the cystic fluid. It is important to understand predicting malignancy in mucinous cystic neoplasm in an IPMN based only on EUS imaging features is almost impossible unless and until you have advanced disease like lymphadenopathy, which is malignant, or you have hepatic metastasis. Microcystic appearance like MR is classical on EUS for serous cystic neoplasm, and SPEN usually again have a classical appearance on EUS of well-demarcated, eco-poor, solid appearing masses or a mixed solid cystic lesion. So these two can be fairly confidently diagnosed on imaging itself, and in the equivocal cases, one can rely on FN. But then imaging itself has very limited information. So if one is doing an EUS, it should be followed by FNA, because the greatest utility is from the cyst fluid, which is obtained and then analyzed cytologically. We do CA level. Now we have glucose level, which can also be done at bedside. Then there are various molecular markers which are being studied, like KRAS, GNAS, VHL, CA10, NB1, and prognostic molecular markers, which include TP53, PIK3CA, and P10. So this is all a composite package of markers which are for diagnosis and prognosis, and I'll just illustrate these in my subsequent slides, what is their clinical utility. Coming to cytology, usually it's a paucicellular specimen. Very limited cells are present in the fluid, so the cytological diagnosis is very difficult. If you have a glycogen-rich cells, which will probably suggest a serous cystic neoplasm, or a mucinin-containing cells, then you can diagnose NCN and an IPMN, but the sensitivity is very, very low. Only 10 to 15% of patients with cystic neoplasm will have these features on cytology. There are some studies which have looked at cytology brushings. Through the needle, one can insert the brush and take the scrapings from the wall of the cyst. It may improve the yield of EUS FNA, but again, experience is limited. The risk of complications, including pancreatitis and bleeding, increases. So in nutshell, cytology has very poor sensitivity for diagnosis of potentially malignant or malignant cysts. But if you find malignant cells, the specificity is almost 100%. So sensitivity is very low, but specificity is almost 100%. So since cytology is not effective, what do? We rely on tumor markers. CEA is the one which is most commonly done. There are a number of studies and number of meta-analysis, so which showed that the pooled sensitivity was 63% and specificity was 93% for diagnosing mucinous cystic neoplasm, that is IPMN and NCN, at a cutoff of 192 nanogram per ml. But if you scan the literature over last 15 years, the studies have used a variable cutoff. One study which we did at PGI, we found a cutoff of 45 nanogram per ml, having a sensitivity of 88.5% and specificity of 96.8%. So if you have a higher CA level, it's higher likelihood that cyst is mucinous. But then again, that's where it stops. It cannot help you in differentiating between potentially malignant and benign mucinous cyst. So you can only find out that the cyst is mucinous. So what about other markers? So because of this inherent limitations of CA, various other markers like molecular markers, cyst fluid DNA, cyst fluid glucose levels, and proteomic mucin profiling have been studied. Their KRAS mutation has a sensitivity of 45 to 65% and a specificity of 96 to 100% again for detecting mucinous pancreatic cystic neoplasms. But if you compare KRAS with CEA, there is no added advantage of doing a KRAS over CA. That's what studies have shown. There's studies which have looked even at that amount of DNA. So they found that if you have a higher amount of DNA with high amplitude allelic loss of tumor suppressor genes, it's more likely to be associated with malignancy. Then there are studies which have looked at somatic mutations in GNAS. It has been found to be highly specific for IPMN. So this is one marker which can help in differentiating IPMN from other mucinous cystic neoplasms. But then again, it is not very specific for dysplasia grade or presence of carcinoma. So then there are other mutations which have been studied over the last few years, which include TP53, PIK3CA, and PTEN. These are associated with IPMN with high-grade dysplasia or invasive carcinoma. So in nutshell, these are prognostic molecular markers which can help in differentiating between benign, potentially malignant, and malignant IPMN. Then there are mutations in VHL, which are quite specific for serous cystic neoplasm. But as I've already told you, the imaging is quite specific. So usually you don't need to do these mutations. And similarly, mutation in CTNNB1 is associated with SPEN. So if a composite markers are being done, you can help in differentiating between mucinous and non-mucinous neoplasm. Of great interest are the studies done recently, which have found that the low pancreatic cyst fluid glucose, if it is less than 50 milligram per deciliter, it has got a high sensitivity and specificity. And when compared with CE alone, it fares better. So I think glucose is one which can be done at bedside, and it can be highly sensitive and specific for diagnosing mucinous cystic neoplasm. But then again, it cannot help us in differentiating between benign, potentially malignant, and malignant cysts. Then there is EUS guided through the needle biopsy. What you do is through the EUS, use a 19 gauge needle, take the biopsy from the wall of the cyst. Usually this requires cysts which are more than 2 centimeters in size. So these are already high risk cysts. And its studies have shown that the diagnostic yield is higher as compared with FNA cytology and CA analysis. However, it is limited to larger indeterminate cysts with high risk stigmata or failed cases of diagnostic USFNA. So we don't do it in all cases of cystic neoplasms. What about other investigations? Pancreatoscopy and intraductal ultrasound are very useful in diagnosing, determining the extent of IPMN, and also because you can obtain a tissue, it can help in diagnosing malignancy. Confocal laser endomicroscopy is coming up. It's a 19 gauge needle through which you do a real-time imaging of the cyst wall. The studies which have compared it with CE and cytology have diagnosed mucinous cysts with higher sensitivity. However, the problem is cost, availability, and reusability. So I think it will take a long time before confocal comes into routine clinical practice. So to sum up, when we have a pancreatic cystic lesion, what we have to look for symptoms. If jaundice is secondary to cyst, this patient needs surgery. If you have acute pancreatitis secondary to cyst, then cyst requires a detailed evaluation, as I've talked about. Similarly, if in a patient with IPMN, if you have an elevated CA99, it's a quite specific marker for malignant degeneration. You look at mural nodule, which is enhancing, it again suggests a high-risk cyst. If the duct diameter is more than 5 millimeter in a patient with ductal lesions, again suggests a high risk. If there is a change in the main pancreatic duct caliber with an upstream atrophy of pancreatic parenchyma, it again suggests a high risk of malignancy. Then size more than 3 centimeter is again suggestive of a high-risk cyst. If the cyst increases in size by more than 3 millimeter per year, then these cysts may be resected because they may have an underlying dysplasia. But as I've already talked about, the risk of malignancy by increased size is not possible to predict. And if on cytology you have high-grade dysplasia or malignant cells, these are high-risk cysts. So to sum up to the flow chart, you do an MR. If the MR is suggestive of main duct IPMN, SPEN, or mucinous cystic neoplasm, the surgery is offered. If it is not, then you carefully look whether it's a serous cystic neoplasm. If it is, then no additional evaluation or surveillance is required if patient is asymptomatic. On the other hand, if doesn't fall into these criteria, then you further evaluate the patient. Then you look size. If it is more than 1.5 centimeter, a mural nodule is present. If main duct is more than 5 millimeter, or if there is a family history of pancreatic cancer, then you need to further evaluate. If these risk factors are not present, then you do a repeat imaging at 1 year to document stability of the cyst. And if the cyst is stable, no further surveillance is required. On the other hand, if these factors are present, you do an EUS FNA. If the mutations are present for serous cystic neoplasm, then again, no further evaluation is required. If these are not present, then you need to do further evaluation, which in this case, if you look, if the cytology is suspicious or positive for malignancy, if the mucinous cyst is more than 3 centimeter with dilated duct or enhancing mural nodule, and if KRAS and or GNAS mutation is present, along with these prognostic mutations, that is TP53 and PIK3CA or P10. So these all mean that it's a high risk. So these patients will require surgery. If it is not, then you look cyst less than 3 centimeter with dilated duct, mural nodule. And if only one mutation is present apart from KRAS, GNAS, then you again need to do an EUS after 6 months and see if the molecular markers are stable. If the molecular markers are stable, then you can put them on surveillance with MR. And if no, then these patients will require surgery, as I've already talked about. Finally, after listening to all this, how correct we are. Now, this is a study which was published in Pancreatology. It looked at the they've resected cysts, and they found that 1 out of 3 resected pancreatic cyst pathology did not conform to the preoperative clinical diagnosis. So whatever best we may do, we still are wrong in almost 1/3 of patients, and considerable number of benign cystic lesions are being resected, and not even combination of 2 or more imaging techniques seems to correlate with better preoperative characterization. So inappropriate resections of benign cystic lesions is significantly higher in patients who have a presumed diagnosis of MCN preoperatively. So just some pictorial representations to again highlight the limitations of what we have talked about. This is a clear-cut large cystic lesion with a mural nodule. So it's a large mural nodule. It looks like it's a malignant mucinous cystic neoplasm. This patient was resected. It was indeed a mucinous cystic neoplasm, but there was no dysplasia or no malignancy. This is a classical appearance of a serous cystic neoplasm, a central scar. This is a microcystic appearance on EUS also you find. So this again patient was resected because of symptoms, and it was a serous cystic neoplasm. Here again, on an MR, you see a small cystic lesion. The duct is little prominent, not very clear on MR. You do an EUS, again you find these microcystic spaces. This is again suggestive of a serous cystic neoplasm. Patient is currently on surveillance, almost 5 years with no increase in cyst size. Here again on CT scan, you see an ill-defined cystic lesion, not very clear on CT, but when you do an EUS, you find a lesion of a variable appearance of hypo and hyperechogenic area. So this is suggestive of SPEN confirmed on FNA. Again, here is a cystic lesion, which is on CT not very clear, but on MR you see a bilobed cystic lesion measuring about 2 centimeter. You do an EUS, there are no mural nodules, but you see a thick septa. You give a contrast, you find that the septa is enhancing. Still not very clear whether it's a benign or a malignant cyst. So we proceeded ahead with an EUS FNA. The cyst fluid was aspirated. The bedside, the string sign, which is for a mucinous cystic neoplasm, was negative. CA was low, 28 nanogram per ml. Glucose was 41 milligram per deciliter, again suggesting a mucinous cystic neoplasm. Cytology, there were no malignant cells. Mucin was present, and the patient had KRAS mutation. So all this fits into a profile of a branch duct IPM, and then this patient was not resected on follow-up. The cyst size is stable. So to sum up, MRCP with CMR and all, USFN in select patients, and cystoscopy, microbiopsy, forceps, and confocal in very few. Last few slides, we do see patients with dilated MPD in our setting. We are in a dilemma whether it's a CP or an IPMN. They have an indistinguishable clinical presentation. Cyst can be seen in both diseases. Rarely they can coexist. So how to differentiate? One is epidemiology, look at age. If the patient is young, more likely to be chronic pancreatitis. Carefully look at EUS and CMRE, and if pancreatoscopy in doubtful cases. I'll just show you two cases. This looks like a chronic pancreatitis, calcification, dilated duct, a young patient, 43-year-old. You do an EUS, you find a lesion in the pancreatic duct. You do an FNA, it's a IPMN with a high-grade dysplasia, and patient was operated. On the other hand, another patient, dilated duct. On MR, you see looks like some strictures, some lesion here in the main pancreatic duct. On EUS, you find looks like a mass lesion. Elastography is stiff. FNA, no malignancy. You go ahead with an ERCP. There is a stricture here at the head end. We dilate and take a pancreaticoscope through. When you do a pancreatoscopy, you find dilated side branches and you see these calculi. So to conclude, PCL, in particular IPMN, are a common management problem. Majority of incidental pancreatic cystic lesions are branch duct IPMN. EUS is an important diagnostic modality for evaluation of pancreatic cystic lesions. However, without FNA, it only gives a limited information. So FNA should be part and parcel if you are doing an EUS. Molecular markers hold considerable promise, but right now are not in clinical practice because of limited utility. So more work is required. And despite recent innovations, accurate preoperative diagnosis of pancreatic cystic lesions still remains a challenge. Thank you so much for your patient hearing.
Thank you, Dr. Rana, for a very comprehensive talk. I'm sure there must be some questions. We'll be happy to take up any discussion. Dr. Garg, sir.
Surinder, enjoyed your talk. Very, very nice.
Thank you.
Just one point. With regard to the molecular markers, do you think we have reached a stage where they can be used from a clinical point of view and help in decision making?
Sir, as I highlighted, the molecular markers, they have limitation that the sensitivity and specificity is still not up to the mark, and it considerably adds on to the cost.
Right.
So I think personally, I will not be in a favor of doing molecular markers in
Right.
patients with pancreatic cystic lesion. I think, if you have a difficult case, cyst is large, I think doing through the needle biopsy forceps would be a better option rather than relying on molecular markers.
That's what, because in one of your flow charts, you had mentioned that this should be done. Thanks.
Excellent talk, Dr. Rana. Asymptomatic cyst incidentally detected because of the routine ultrasound or a CT scan. If MRCP does not show any connection with the MPD, do we need to proceed? Anything less than 3 centimeters.
Do we need to what, sir?
Do we need to proceed with further EUS or FNAC? Anything asymptomatic less than 3 centimeters? No communication with the MPD. Should we leave it alone?
Personally, I would like to do an EUS because EUS would be able to better pick up the mural nodules, which will not be seen on MR. If I don't see any mural nodules on EUS, then I won't put a needle there. So that
EUS will be needed in all.
Sorry, sir?
You will do
Yeah,
EUS in all.
Yeah, EUS.
All pancreatic cystic lesions.
Cysts which are, say, more than 2 centimeters. If it is less than 2 centimeters, because 2 to 3 centimeters is a little gray area, because you still may have some malignancies, and you may have subcystic neoplasms, solid neoplasms, which may have a cystic degeneration. So less than 2 centimeter, MR done, no mural nodule, I think nothing would be required.
All more than 2 centimeters, you'll always do EUS.
Yeah, I will always do an EUS.
Hello. Dr. Anand, your institution, how many patients get operated in a year's time for these cystic neoplasms?
How many patients you want to know?
Yeah. What is the bulk of the surgery in these patients?
It would be, I would say, sir, about 2 to 3 a month.
2 to 3 a month?
Yeah.
They turn out to be malignant on specimens?
Some of them would be symptomatic. Like if you look, if I look at data of last 3 years, which we just published, majority of patients who have undergone surgery for cystic neoplasms are serous cystic neoplasms, which have symptomatic large cysts. So followed by mucinous cystic neoplasms in young females, which are more than 3 centimeters. IPMN is very rarely operated.
So if I can ask Dr. Rana, in extension to Dr. Arora, if I feel this is a mucinous, say, MCN or a branch duct IPMN, in what circumstances would I want to maybe sample it with FNA, or am I just happy with the morphology of it alone?
I think it's a question for which there is not a clear-cut answer, but then you have to look at the size of the cyst. As I've said, if the cyst is less than 2 centimeters, there is no need of putting a needle. In a cyst which is less than 2 centimeters, I'll put a needle only if I find that there is a mural nodule and I give contrast and I find it is enhancing. Otherwise, I'll not put a needle because I think I'll be doing more harm than good by putting a needle in a small cyst.
Quickly, last one. If a patient comes to me and he's 2 centimeter, 2 millimeter, what is his chances of increasing? When a patient's going to ask me, what are my chances of getting it to 3, 4, 5? What should we say?
So we look again at the morphology of the cyst. If the cyst is simple cyst, there is no mural nodule, no communication with the duct, I think we can confidently tell him that his cyst is going to remain stable.
And if it is serous?
If it is a serous cystic neoplasm, the increase chances are quite less. I would say that about 15 to 20% of the serous cystic neoplasms would increase in size, necessitating an intervention in the form of surgery. Otherwise, most of them grow very, very slowly to the tune of 0.5 to 1 mm per year. So the cyst size is stable in serous cystic neoplasms.
Thank you very much. I think we'll close the session now. Thank you.
Sir, can we request you for a picture? Sir, please stay on the stage. A great session. For the next session, can I please invite Dr. M.S. Paul and Dr. Vivek Ahuja to please moderate this session. I would also like to request Dr. Naveed Mehraj, Dr. Nitik Batla, Dr. Reshma Kaushik, and Dr. Arvind Joshi to please chair this session. Can I request Dr. Pramod Garg to please come and take his talk?
Good afternoon, ladies and gentlemen. I would like to thank Dr. Arora and the organizing team for giving me this opportunity to talk about early management of acute pancreatitis, what is new. So let me first define what is early. Early, I would say first 2 weeks would constitute early, but what is new, upfront I can say nothing much and close the talk. But that's not what I'm going to do. I'll just, emphasize certain points for the postgraduates here. So one of the things in most talks related to acute pancreatitis, people will see this. There's a large fluid collection, call it pseudocyst or a Waldorf necrosis. There is a beautiful stent here. You go in, drain this, put a metal stent under EUS guidance. If there is a live demonstration, there will be claps and patient is supposedly cured of the disease. And then you do necrosectomy like surgeons do, and sure enough, you think you have cured acute pancreatitis. The reality, of course, is much different. So I'll come back to this, why I have mentioned right in the beginning that this is not, I'm going to discuss, this is not the whole thing about pancreatitis. Very small percentage would constitute that. And obviously nothing at all in the beginning of the illness. So this is a clinical scenario of a lady comes with abdominal pain, classical presentation, amylase is high, heart rate is more than 100, and oxygen saturation is about 92 on 2 liters of oxygen. This is day 1. So you have a patient on day 1 who presents with acute pancreatitis, and if you find there is tachycardia or there is tachypnea, and or there is some problem with saturation, patient is likely to be in trouble, and so would be the physician. Ultrasound here shows features of acute pancreatitis with gallstones, bilirubin is 1.8, and SGPT is raised. you diagnose acute pancreatitis. And the reason I mentioned LFT here is I want to emphasize here that if your liver function tests are abnormal within the first 48 hours, it is biliary unless proved otherwise, even if there is no gallstone on ultrasound. And even if you find ultrasound stones and LFT is absolutely normal, this is not biliary pancreatitis. In more than 90% of cases, that is the case. And CT is not done, not required. So day one, first week, what are the points we need to discuss? Does this patient needs hospitalization? When to refer a patient if you're working in a primary care or a secondary care hospital? What analgesics do we give? That's the major problem. Which fluid, how much of fluid, when do I do a CT? Should we start antibiotics? And what and when nutritional supplementation? These are the things we often discuss, but I think worth emphasizing again and again. So when do you refer a patient the first week of illness, day 1, 2, or 3? 2 very simple criteria. If there is presence of SIRS or persistent of SIRS, this patient is likely to have moderate or severe pancreatitis. And if you see the patient on day 2 or day 3, and there is organ dysfunction, surely this patient is likely to have a severe disease course. You don't need any markers. No fancy markers, no CT scan, nothing, just clinical medicine. Coming to the analgesia, what is the right choice? We have 2 major choices, opioids and NSAIDs. The concern with both of them is safety. NSAIDs may cause renal failure and GI bleeding, and opioids might lead to ileus or exacerbate ileus and may increase respiratory depression. So we don't know which one is better. Unfortunately, not much data are available. We conducted randomized trials of diclofenac versus pentazocine, which is an opioid. And consecutive patients with acute pancreatitis were randomized to receive either diclofenac 75 milligram or pentazocine 30 milligram, given intravenously over 8 hours. Very importantly, we used injection fentanyl as a rescue analgesia through a patient-controlled analgesia pump, PCA pump. And I would like to emphasize this PCA pump because what we learned from this study, that this is very important. So we randomized patients to pentazocine or diclofenac, and we found that pentazocine was better than diclofenac, both in terms of the total dose of fentanyl required as rescue analgesia and pain-free period. So we feel, and there is some evidence in literature as well, that opioids are better than NSAIDs. Fentanyl as a rescue analgesia is very good, and it should be provided as a PCA pump. People who are managing acute pancreatitis, either in ICU or in specialized wards, should have this pump. This is not a very costly thing, very easily available, widely available, but we as gastroenterologists often don't use it. Surgeons use it, anesthetists use it, ICU people use it. I think we should also use it. There's no problem, and it provides excellent analgesia. Patient is very happy. And if required, you can supplement with NSAIDs, but most often, more often than not, you won't require it. Coming to IV fluids, here I will spend a couple of more minutes. So the questions are, what is the usual fluid deficit in these patients? What should be the rate and type of fluid replacement? And how do you guide fluid therapy? So way back in 74, Ranson et al. In a very famous study showed the fluid losses in the early part of the illness may be as high as 5.6 liters in those with severe pancreatitis. But more recently, a study from Spain showed that the median fluid loss is around 3 liters. And the predictors of fluid losses were younger age, alcohol use, high glucose, and presence of SIRS. So how aggressive and how much fluid do we give? So again, we don't have much data, but very disparate studies. So one study which was systematic review of 9 trials reported that the rate of fluid infusion, there was a wide variation in the definition of what constitutes aggressive. So we don't know what is exactly aggressive. So somebody might say if you give 4.5 liters in first 24 hours, that is aggressive. Non-aggressive, in a summary, was 3.5 liters in 24 hours. And when you it comes to how much you give. So it was suggested if you give 15 to 20 ml per kg bolus, followed by 1.5 to 3 ml per kg per hour for 24 hours. Now, if you see this 3 ml per kg per hour and you have a 60 or 70-year-old patient, it is 200 ml per hour. We are talking about 4.8 liters in 24 hours, besides what you have given as a bolus. So you're talking about upwards of 6 liters. And I don't think that is the correct strategy. So 2 recent studies have shown that aggressive fluids are better in those with mild acute pancreatitis, not moderate or severe. But recent studies, including RCTs, have shown that aggressive fluid resuscitation may lead to increase in organ dysfunction, intra-abdominal hypertension, need for ICU care, and higher mortality. In fact, the first study published was from China, which was a randomized trial, and everybody was very skeptical of that study. There were some problems, though, with that. They had a very rapid fall in hematocrit with aggressive fluid, but it showed that it worsens the disease course. And recently, a waterfall trial, I don't have full access to that data, but I'm told this study is going to come in I think, next 2-3 months in NEJM, that aggressive fluids were found to be detrimental in those with predicted severe acute pancreatitis. So this is where I want to draw your attention, and I want you to spend just a couple of minutes on this. So what happens in those who have mild acute pancreatitis? Here, there is no systemic inflammation, and there is minimal fluid deficit, no capillary leak. Very importantly, they have a preserved neurohumoral mechanisms and intact capillary circulation, those who have mild disease. So if you give aggressive fluid, there is no problem. You give more fluids, there is no harm, patient will have diuresis, and patient will be okay. No issues here. You give 4 liters, 5 liters, I don't mind. But generally, they don't require that much. The problem comes in those who have predicted severe acute pancreatitis. So what happens in these patients, because of the marked inflammation and necrosis, there is release of these inflammatory cytokines and chemokines and DAMs, and this will lead to problems in the vasculature, the capillary circulation. So there is capillary leak syndrome. And what happens that they lose blood in the interstitium. So there is intravascular volume contraction, tissue hyperperfusion, and this adds to organ dysfunction, not the primary cause, adds to organ dysfunction. Now, problem is if you give aggressive fluid here, you are going to exacerbate this problem because they don't have that intact neurohormonal mechanism to take care of the extra fluid that we are giving them. So there is more leakage, there is more pulmonary edema, there is more organ dysfunction. So that's a problem in these patients. So which fluid to give? I mean, there is almost general consensus that ringal lactate is better than normal saline because of that it may lead to hyperchloremic acidosis, and lactate may downregulate inflammation. But again, there is some controversy, but let's not get into that. But ringal lactate overall seems to be better. How do we monitor? That's a clinical question that every resident should know. Our standard goals in any patient, regardless of the underlying disease, is that we need a minimum mean arterial pressure about 70, hematocrit around 40, and a urine output of 0.5 to 1 ml per minute. How do you monitor that when you give fluids? CVP is not a good guide, especially those who are on ventilator. Invasive pressure is obviously very good, but most of the time we don't have invasive pressure facilities unless the patient is in a very good ICU. But non-invasive monitoring is very important, can be easily done by all the residents. I think currently most gastroenterology wards have a portable ultrasound, and it is very easy for residents to learn this, to look at the IVC diameter and also lung ultrasound. Lung ultrasound, now most intensive care departments actually conduct courses on lung ultrasound. So it is very easy. If you just send your residents for 3 days, 5 days, they will learn lung ultrasound, and you can measure the IVC diameter like this. And also you can do this lung ultrasound to look for B lines. Our residents do now in ICU every day on such patients. It actually helps you determine how much fluid you need to give. So current recommendation is that it's reasonable to give about 3 to 4 liters of fluid in the first 24 hours, preferably ringer lactate. And you need to keep on assessing the need for fluid requirement further. So every 8 hours, there should be a check whether I need to give more or less, whether I should give more or less, rather than giving an order for 24 hours. So that is very important. Every 8 hours, you have to reassess. And beyond the first 3 days, the intake should depend on the output. That's not a much of a problem there. The take-home message I want to give here is that we cannot convert a severe acute pancreatitis into mild by fluids. That if I think I can give 6 liters of fluid and prevent development of severe, I'm mistaken. We cannot do that. But we may worsen severe pancreatitis by giving aggressive fluids. So that's the take-home message I would like to give. Coming back to the patient had fever on day 3 and 4, TLC was 14,000, creatinine was 2.4, bilirubin settled 2.9, SGPT came down to 78, blood and urine culture was sterile, ultrasound showed mild fluid collection. So this lab reports tell me that the stone which was there on day 1, which caused acute pancreatitis, has now passed out. You find the SGPT is decreased, bilirubin is slightly less, and there is no need to do ERCP in such a patient. And very interestingly, 1974, Acosta showed a very beautiful study, elegant study. He sieved the stools of patients with acute biliary pancreatitis and showed very small stones in the stool samples, suggesting that it was small stones which caused pancreatitis, and these stones passed out over the next 2, 3, 4 days. So that is why the studies, randomized trials which were done, whether early ERCP is beneficial or not, were negative simply because the stone had passed out by the time ERCP was done. Unless, of course, there is persistent of obstruction and there is cholangitis. So here you find there is hypoxia and the creatinine is up on day 3. Now, this tells us that organ failure is the key determinant of survival in patients with acute pancreatitis. And I'll just give you these data. 3 studies published in 2018. One is from our center, Rajesh Pradhan published that. Then this is the Dutch pancreatitis group, and this is a study from Spain. And if you look at the numbers of patients with acute pancreatitis, fairly large number, 800, 600, and 1600. Look at the mortality in patients with persistent organ failure, 42% in RK series, 38% in Dutch study, and 52% from Spain. Those who had early onset persistent organ failure, mortality was about the same, 46, 42, and 52%. So this means that those patients who are developing very early organ failure within the first week, there is a very high chance of them dying, regardless of what we do, because unfortunately, we do not have any effective therapy during this period for organ dysfunction. Antibiotics, I think we all know that prophylactic antibiotics have no role. Meta-analysis of 8 RCTs done after 2000 showed no benefit. And I think there is ample evidence now that we should not. And even if someone is on antibiotics on day 3, 4 and comes to you, you can safely stop antibiotics. So there is no study to say whether you stop antibiotics on day 4 or 5. But I think there is enough data to show that if you continue, there is no benefit. In fact, you might be harming. So often we get this security that let this antibiotic continue, might do some good. But tomorrow, this patient may go to court and say that I have read on the internet that antibiotics should not be given. This patient was given antibiotics. Patient developed fungal infection, MDR, and died. Was this justified or not? So now you may be sued for something else. So we should be very clear and be confident of your decisions. Don't be under that, this kind of false security that I might be doing good for this patient. Coming to the nutrition, when do we start nutrition? I'll just give you some guidelines here that oral feeding in mild acute pancreatitis, as soon as abdominal pain is decreasing, there is no hurry to start on day 1 or day 2. You can take 2-3 days. No hurry in there. For patients with predicted severe means there is persistent SARS, some dysfunction, some hypoxia, And enteral feeding is the primary therapy in these patients, should be given. If patient cannot tolerate, put in a tube, preferably nasojejunal on day 3, 4. That's the right time to put in. And you can start with polymeric feed, start slowly and your goal is 25 to 30 kilocalories per kg with 1.5 gram per kg proteins. And rarely these patients require TPN. So when the patient is in the first week, improving or about the same, you continue intensive care, nutrition, no antibiotics. How about second week? Second week, we should continue enteral nutrition, intensive care if there is persistent organ dysfunction. Watch out for infection. This is the period when they might develop infection. Infection means infected necrosis. There are, of course, other causes of infection. And the suspicion for infection is if there is either new fever, so fever in first week is there because of pancreatitis, either there is a new fever or worsening of fever, or now counts are further increasing. They were 16, 17,000 at the beginning, came down a little bit, now going up again. Or you have procalcitonin again, normal, less, or now going up again. Because in the first week, you will find raised TLC and procalcitonin without infection as well. And or there is organ dysfunction, either new or worsening. Now you suspect in the second week, there could be infected necrosis setting in, and I'm a little worried. By the way, those who have organ failure in the first week are prone to develop infected necrosis in the second and third week. So we have to be careful about patients who have organ dysfunction in the beginning. And this is the time for a CT scan, not earlier. Now you suspect. So I need to know how much is the necrosis, where is the necrosis, how much peripancreatic necrosis, what is the fluid collection, what is the location. I need to be preparing myself and my radiologist that this patient may require some intervention. But this is basically the week for watchful waiting. Right now, we are not planning any intervention. Second week, no intervention, generally speaking. Watchful waiting, intensive conservative treatment. So this patient I referred to recovered after conservative therapy in second week, from second week onwards. So beyond second week, this is not I'm going to discuss, just some points. Continue enteral nutrition. Infected necrosis in this period is a major problem if your patient hasn't improved by this time. And if there is infected necrosis, conservative first is the approach. That means antibiotics, percutaneous drainage, followed by necrosectomy if required, which is required only about a third to max 50% of patients. And beyond 40, of course, I've shown you the slide in the beginning. You're all expert in that, putting in a metal stent and be happy. So ladies and gentlemen, I like to summarize by saying that first few days in acute pancreatitis are critical. Adequate optimum hydration should be done and not too aggressive. Analgesics, we feel opioids are better. There could be a role of epidural analgesia, which I have not discussed, but I think more data are required. Early enteral nutrition, we all know, should be started as soon as possible. No role for prophylactic antibiotics. And refer your patient to Dr. Arora if there is persistent SARS or organ failure in your setup. Thank you for your kind attention. Happy to take questions. Please.
Great lecture, Pramod. A few comments and question also. I mean, there is a lot of emphasis on early nutrition in acute pancreatitis, even for starting solid diets. You were there in best of the DDW and a lot of papers were presented.
Yeah.
That reduce the stay of hospitalization by starting early diet. The second comment is there is no added advantage of ringer over the normal saline in the large trials, in the best of the DDW which was presented, you know. The third thing is, whenever you have acute fluid collection, persistence fever, and you don't have a localized wall of pancreatic necrosis, sometimes you feel that you need to intervene. But because you have a diffuse collection here and there, inadequate drainage may not benefit. So this is a situation whether you continue giving antibiotics and wait for it to be walled off so that you will do better justice by endoscopic method, or should we go by percutaneous method and do the drainage?
Right. Thank you, sir, for this comments and questions. So with regard to the nutrition, I would say as early as possible, and two clinical guidelines are patient's pain is improving and there is no significant alias that patient is vomiting and there is a lot of distension or intra-abdominal hypertension is there. You can start day 2, day 3, day 4. There is no urgency to start on day 1 or day 2. Most patients won't like it, and they can because they have so much of pain. So within the first week for sure, and day 3, 4, usual time when you can start. And some studies show that there's no point going in from a soft diet to liquid diet and then solid. You can start with solid. And I think these are the patients who have mild or at best moderate disease. So they can start. Ringer, again, I said, general consensus is it is better than saline, but there are some observations that saline may be as good and ringer may not be that good. But I would suggest that ringer is not bad or worse than saline. So you persist with ringer. With regard to the third issue of fluid collection, that's a major area of controversy and indecision. So a trial by the Dutch people published last year, they compared early drainage in such patients versus delayed drainage. So you have a patient in second and third week of illness. What do? Drain now or later? So early versus delayed, they found no difference. Now that means that in second and third week, you keep giving antibiotics and wait, no hurry. However, it has to be individualized. If you have a patient on CT scan, which shows that there is a significant collection in one area, lesser sac, right paracolic, left paracolic gutter, and radiologist can put in a drain, patient is having fever, sepsis, organ dysfunction, put in a drain. There's no problem in there. So that is individualized. The treatment has to be individualized. You can't go by firm guidelines. And that is what this trial also showed. Sir.
It is always a pleasure listening to you.
Sir.
My question is, what determines the severity of pancreatitis? It is a tiny pebble which is transversing across the papilla. Suppose in your case, which you presented, you have an SGPT of 270. You think on day 1 US, if would have shown, would have prevented ERCP by stenting the CBD and prevented for going into severe pancreatitis?
So again,
just like PEP, earlier you intervened.
So your question is very early ERCP, within 24 hours.
Yeah.
So this is what the Dutch trial on randomized trial, they did very early, within 24 hours.
They did it in 72 hours, neophthalmos group.
No, not neophthalmos, the Dutch group, they published, I think 2 years ago, within 24 hours, they're very early, didn't find any benefit. Because most of the time when you go in, and there are logistic issues. I mean, patient comes today, I don't know how long is he having pain, maybe 12 hours, 16 hours. You may plan ERCP tomorrow morning, by the time it is gone. So in individual patient, if you see, today there is persistent of obstruction, you can go in and do it. But without cholangitis, none of the trials have shown benefit.
And what determines that it will be mild, moderate, or severe? It's the same stone which is passing by. Is it something to do with the genes or polymorphism of the pancreatic enzyme?
So we believe it is likely to be some kind of inherent host factor which leads to this severity, very similar to COVID. Virus is the same, only 1%, 2% will have that fulminant COVID. Why? Because they have an out of proportion immune response resulting in that. And something similar happens here. There is a possibility that those who are alcoholics have an underlying problem, they take a lot of alcohol, there could be toxic injury leading to more damage. But otherwise, in general, it is host predisposition likely to be genetic. We did some genetic polymorphism studies of IL-6, TNF-alpha, MCV1, didn't find except IL-6-1 polymorphism was slightly higher in those with early severe acute pancreatitis. But I don't think we have much knowledge, but likely to be host factor. Obesity, for example, is a well-known factor.
So, Lucid, Doctor, as usual. So I have two questions. One, many of these patients end up undergoing a cholecystectomy based on an ultrasound report of sludge in the gallbladder. So what is your take on that?
Simple message is look at the liver function test within the first 48 hours. If it is SGPT is raised, UL-FOS is raised, which has come down within next 2-3 days, it is likely to be biliary. Don't go by just imaging of sludge. Question at the back, yes.
Do we have any role of early EUS in finding out the severity of pancreatitis, whether it will be a necrotic one sooner or later in the first week?
Simple answer is no. The only thing one could do is a perfusion CT. We did a perfusion CT study and showed that if you do perfusion CT, you can find out some areas are underperfused. Likely is that they will become necrotic. But the clinical relevance of that is somewhat limited.
Dr. Garg, I think excellent talk. Yes, I want to ask you one thing. You said you start enteral feeding. Even if patient has a moderately severe pancreatitis, he has no ileus, he's not vomiting, there's no distension. Why should we not pursue with the oral feeding rather than
No, enteral means oral.
No,
By enteral, I meant oral.
Okay.
But if a patient cannot take oral, then nasojejunal. Enteral means?
And the second issue is about these collections. If patient has a collection and because second week he may not be having SIDS and this is probably the infection. Once you do percutaneous, also is a mess for the patient because first week you cannot do endoscopic treatment because there's nothing which can sort of keep the stent, whatever you use in position and it will be leakage. So why can't we pursue with antibiotics for at least another week and then to decide?
Exactly.
And follow the patient for that week. How is he doing? Other than going aggressively, because you see what we know, what we have learned, that acute pancreatitis, the fire is in the first 4-6 hours. That is, I think we are now treating a dead pancreas. So why should we sort of be too aggressive with these patients?
So I agree with you that if you suspect infected necrosis, start antibiotics. In the second and third week, do nothing. Wait for 2 days, 3 days, 4 days, 5 days, and then think of drainage, percutaneous, of course. The indication for going in percutaneously would be your patient is not improving, there is worsening of organ dysfunction or new onset organ failure, and you suspect this infection is causing sepsis. So if there is no response over next 3 to 4 days, that is the time to go in and put a drain and try and drain out whatever fluid you can. Couple of Chinese studies have shown that even if you have only ascites in the beginning, 100 ml, 200 ml, you drain it out, you might help the patient. I'm not sure about those findings, but there is a possibility if you remove the fluid, whatever is there, it might help. But I agree, idea is conservative and start only antibiotics in the beginning.
Thank you.
Two questions. Well, it was a nice lecture. See, there was some suggestion, I think the opioids that we administer for managing this pancreatitis, many times it's mentioned that they might sometimes produce spasm of sphincter fodi. Opioids that we use, like pentazone, etc.,
right,
they might sometimes produce spasm of sphincter fodi. The second question was regarding the same enteral nutrition. Is there a hard data to say that nasojejunal feeding is better than a simple nasogastric tube feeding? There's none, I think.
But there are not hard data to say nasojejunal is better than nasogastric. In fact, one RCT from our department showed they are similar.
They are similar.
So it depends on patient's tolerance. So you can try nasogastric initially. If the patient is tolerating well, I agree with that. With regard to sphincter fodi dysfunction, I'm not sure we can say that opioids might cause that and cause more problems. What has been shown experimentally that morphine causes more severe pancreatitis. So that's why morphine should be avoided. We use pentazocine, which is actually this kappa receptor agonist.
Excellent talk, Dr. Pramod. I just wanted to know, is there evidence of a golden hour in the first few hours of pancreatitis? If a patient presents in a tertiary care, you give fluid therapy, any modality which will change and alter the course will reduce the severity of pancreatitis? And do you believe in a concept of second hit hypothesis, which happens after 96 hours because of bacterial translocation if enteral nutrition is not started? So what is your take on it?
So first is, I wish I knew there is something that we can start. Our current thinking is that we may have to give immunosuppressive therapy on day 2, 3, 4 if we find a patient is having very early organ failure, because that is because of the severe out of proportion immune response. And the second point you mentioned about second hit, of course, in the late first week or early second week, there is a possibility of infected necrosis, particularly in those who have organ dysfunction. And that is what second hit is. That's what they get a problem. And that is the reason everybody is saying that start early enteral nutrition. So I agree with that. Ashish.
So if the patient comes with the deranged liver function test and it's obvious that it is biliary, when will you go do US and ERCP to remove the stone?
Most of the time you won't need to do ERCP. Most of the time.
If it is persistent.
But persistent, you go ahead and do.
But
depending on the
so
patient.
how much will you wait?
Huh? No, I won't wait. Day 3, 4, I find the bilirubin is going up. I will do ERCP if patient's condition allows me to do that. If a patient in the ICU, patient is on a ventilator, patient is very, having organ failure, it may be difficult to do. And in fact, in such patients, doing ERCP is very difficult. You find a lot of edema around, papilla may not be seen, papilla is edematous, you can't cannulate. So, you have to again individualize the treatment here. But most time you won't require it. Most of the time, yes. Yeah.
Supposing, Pramod, the surgery for this gallbladder is being postponed for a few days, would you not do a prophylactic endoscopic sphincterotomy to prevent further attacks of pancreatitis?
So most of the time it is actually delayed, not for a few days, for a few weeks in most of the hospitals, in at least in government setup. Although I would say that you should do as early as possible. So if there is any reason why cholecystectomy cannot be done, you could be justified in doing a sphincterotomy, but I will not do a sphincterotomy just because for some other reason the cholecystectomy is delayed. Do cholecystectomy. Thank you again.
Thank you, Chairpersons. For the next session, I'll invite Dr. Pradeep Agarwal and Dr. Deepak Lahoti to please moderate the session. I would request Dr. D.P. Chaturvedi, Dr. Harsh Saxena, Dr. Amit Sachan, and Dr. Ram Narayan Shah to please chair this session. Dr. Goenka will be joining on Zoom, so I would request AV to go live.
So good evening.
Good evening, Pradeep ji.
So Dr. Goenka is on Zoom, and all of us know pretty well that he's the head at Apollo Glen Angels, Calcutta. And over to you, sir, without any delay, for a talk on indeterminate biliary strictures, which in fact worry us most of the time.
Thank you, Dr. Pradeep. And I must thank Dr. Arora, Dr. Ashish for making this almost a routine in our calendar every year. I'm also thankful to the organizers for allowing me to join you virtually. I had planned to come today, but for some personal reason could not. I hope my slide is seen and I'm heard clearly there. So what I'm going to do is the next 20 minutes or so to talk to you about an important topic of approach to indeterminate biliary strictures. Now, this is an example of a patient which we managed only about last week. This patient had an ERCP done outside, and there was a narrowing in the hilum. This patient had an open cholecystectomy done earlier, and they were not sure whether they are dealing with a benign stricture or a malignant stricture. They did take a brush cytology, but the brush cytology was inconclusive. So when the patient came to us, we did a cholangioscopy, and the cholangioscopy showed these minute changes in the upper part of the bile duct. You can see a little bit of irregularity, some neovascularization, mild narrowing. We took a SPI-scope biopsy, which confirmed that this was adenocarcinoma. Patient had a lot of comorbidities, so we did a radiofrequency ablation, as you can see in the last slide. And then we had, because of financial reason, put double plastic stents. So this patient, we could diagnose and manage with the help of an advanced technique like cholangioscopy. So what I'm going to do in next 15 to 20 minutes is to give you an overview of how important it is to deal with indeterminate biliary strictures. And I did a PubMed search last week, and to my interest, we found that there have been 227 publications on indeterminate biliary strictures. But if you look at the breakup year-wise, almost all literature has come in the last 10 years. In the first 10 years from 1999, there were hardly any literature on indeterminate biliary strictures. Now, this is a list of various causes of biliary strictures. As you can see, the list of benign strictures, which constitutes only about 20%, but the list includes iatrogenic strictures, chronic pancreatitis, PSC, IgG4-related disease, infections, cholelithiasis, and so on. Malignant etiology constitute about 80%, and these includes cholangiocarcinoma, pancreatic cancers, gallbladder cancers, metastatic disease, and lymphomas. Depending on whether we are from South India or from the North India, the frequency of these malignancies would be different. Now, we have to understand what is indeterminate biliary stricture, and the definition of indeterminate biliary stricture is that stricture of uncertain etiology after a cross-sectional imaging, which can be either a CT or MRI, and ERCP with routine cytology. So after that, if we are not able to be sure whether it's a benign stricture or malignant stricture and what is the etiology, we should be calling them indeterminate stricture, and they constitute about 20% of all biliary strictures. So why it is important to understand and to determine the etiology? Because we must not be missing a resectable malignancy, and we must not allow an unnecessary surgery, because we know surgeries like this are usually large and may be associated with a significant morbidity and mortality. In fact, almost all centers which are oncology centers, and I would include Tata Medical Center from Mumbai in the same group, give us information that almost 20%, 15 to 20%, 24% is the range of the patient who was operated for malignancy are actually benign. So we are unnecessarily doing some surgeries in benign conditions, which can be tackled sometimes without surgery as well. So the differentiation between benign and malignant etiology, it starts with the clinical spectrum. So in general, a younger patient, those who have history of pancreatitis, biliary stones, and normal CA19-9, and elevated IgG4, and those who had a hepatobiliary surgery, we should think more of a benign disease. Whereas those who have weight loss, elevated CA19-9, long-term PSC, long strictures on cross-sectional imaging, asymmetrical strictures, and associated colorectal cyst or abnormal pancreatico-biliary junction, we should suspect malignancy. But we may be wrong many a time if we go by these criteria, because we know that 19-9 may be raised even in benign diseases, and in malignant disease, again, the sensitivity may not be very high. So these are the three pictures of strictures which you saw. And if you look at them, it may be difficult to differentiate on the ERCP. But let me tell you, the first one is a malignant stricture, the second one is a tuberculosis, and the third one is actually a Mirizi syndrome. So I think it is very important that we do everything possible before we operate on these patients to find out what is the underlying etiology. So histology is important. And whether it's cholangiocarcinoma, tuberculosis, rare disease like neuroendocrine tumor or IgG4 disease, we should try to get histology in majority of cases. So what are the various diagnostic modalities which are available to us for differentiating various etiology? Cross-sectional imaging, I briefly mentioned about it. ERCP and standard sampling, EUS and intraductal ultrasound, cholangioscopy, and confocal laser endomicroscopy are the various techniques which are available. We almost always start with cross-sectional imaging, which can be either an MRI or a CT scan. Now, if you find a mass like this, then you know that you are more likely to be dealing with a malignant process. But we also know that inflammatory masses are possible. Again, if the strictures are long and eccentric, then you would think more like it to be a malignant strictures. The tissue sampling on the routine ERCP, the standard of care has been brush cytology. Sometimes we use biopsies also fluoroscopically. But we know that the results are sensitivity-wise suboptimum. Now, we have to also understand that brush cytology has a technique. It shouldn't be a very casual brush cytology. We should at least have 2 passes, and each time we should move the brush at least 10 times up and down. So this is a systematic review of brush cytology and intraductal biopsy for malignant strictures, and look at the number of the studies, and the sensitivity of brushing on an average has been 45%. The biopsy is little higher, 48%. Even if you join both the brushing and biopsy, the sensitivity still is less than 60%. Of course, if you get a positive malignancy, then the specificity will be very high. Some of the techniques which has been added to brush cytology include digital image analysis and FISH. There are some papers on next generation sequencing, which seems to be promising, but is not available on a day-to-day practice. FISH is a good technique, but we don't somehow use it more routinely. Here we look at chromosome Sept 3, 7, 9, and 17 and look for trisomy and polysomy, which will be suggestive of malignancy. If we combine cytology, biopsy, and FISH, then the sensitivity can go as high as 82% and specificity can be as high as 100%. Somehow, FISH is not very commonly used by us gastroenterologists. Now, what about EUS in indeterminate biliary ductal strictures? Now, EUS is important, but if you look at the sensitivity and specificity, overall the sensitivities are again only about 80%, though specificity, as for any histology, would be high. Now, these are some of the studies which have been published for EUS in IBDS. In general, EUS is preferred when you're dealing with the distal biliary stricture because the sensitivity is higher and the chances of contaminating the field of surgery is lower when you're dealing with distal strictures. But in the proximal stricture, the sensitivity is low. And again, there is a risk that you'll be contaminating an area which you may not be operating and resecting later on. So I think in general, EUS is preferred when you're dealing with distal strictures. Now, this is a meta-analysis which looked at increased incremental sensitivity of EUS FNAC after an ERCP has been done. And if you look at an average from these 10 studies, about 16% of the patients, the sensitivity was added by including EUS FNA in addition to the ERCP. Now, let's now move and change the gear to cholangioscopy. We have been using till about 15 years back, primarily mother-baby scope, which were more commonly used for demonstration during various workshops. But these are fragile scope with poor irrigation, and now we have got away from them. We are hardly using them any further. Now, so in 2007, we got this spyglass direct visualization system, which is now called legacy system, in which you'll pass a probe to illuminate the field, and then you can take biopsies. And this is one of the images from my database, almost about 2008 or 9. You can see that the images are there, but not very good. So we move on to DS system in 2015, which is DS1 initially. The image quality was better. No separate probe was required. The best part was that it was easy to set up, plug and play, whereas a legacy system would take about 20-25 minutes to set up. This would take less than 5 minutes to set up. And now we are fortunate that we have a Spyglass 2 system, which was put into practice in 2018, third generation, with an automatic adjusting light and a much smoother movement of accessories. And along with this, we have now Spy Max, which takes almost double the size of the biopsy material as compared to the initial Spy Bite. So now this is some of the initial work on the Spyglass, which was with the legacy system. And this is some of the studies, including the one from Hyderabad AIG. And all these studies show that sensitivity was higher for visual examination of the strictures, whereas the specificity as expected was higher for the biopsy. So the reason was that there were sampling problems with the biopsy. So if the biopsy may miss a lesion, but visual examination was somehow better. We also look at it, this is a multinational study, a large number of patients. We found, again, a similar results in this multinational study. The sensitivity was higher for diagnosis as visualization, but of course the specificity was higher if you take a biopsy. So this is overall accuracy was 77% on visualization and 86% on biopsy or histology. So what are the criteria for differentiating benign from malignant strictures on Spyglass? These are some of our own images. You can see that these are projections here. There is eccentricity, and in this you see neovascularization. And these are some of the features of malignancies. Now, in benign lesions, on the other hand, let me go back. Sorry. Okay, now, I'm sorry, just give me a minute. Can you see the slides now?
No slides on the screens.
1 second. Just 1 second. Now, can you see that?
Yeah.
All right, sorry about it. So these are some of the benign lesions in from our database. So as you can see, there's a centrally placed lesion, narrowing. But then we must also realize that sometimes when there are stents placed earlier, the images may be confusing. This is a patient where the stent was placed earlier, and you may get some features which may make you think that it's malignancy. So you must interpret this particular situation a different way. Now, this is showing the specificity of the various characteristics for differentiating benign from malignant, and this is saying the specificity of the lesions for diagnosis of malignancy. Let me start from the left side. This is neovascularization. This will have a specificity of almost 100%. If you see these abnormal vessels, this is almost certain that you are dealing with a malignant lesion. When you have a polypoidal lesion like this, then it's a 77% specificity. When you have mucosal thickness like this, the specificity is 62%. And when you have infiltration like this, the specificity may be even lower. So if you find a neovascularization, as is shown in the rightmost images, then you are almost certain that you are dealing with a malignancy. Now then, we'll move on to the direct paroral cholangioscopy. This is the advantage that this is a large working channel, and you have enhanced endoscopy, which is possible like narrowband imaging. But the disadvantage is that you need to do a large sphincterotomy. You must have a dilated bile duct because these scopes usually measure 5.5 millimeter in diameter. So you should have a duct which is almost about 8 millimeter at least, and it's technically more demanding. As I said, the advantage is that you can do a narrowband imaging, and we all know that narrowband imaging can help us in differentiating the lesions much better than a white light can. And these are some of the examples of narrowband imaging at cholangioscopy. Now, there is a new type of cholangioscope which come in the market. We haven't used it as yet. This is multi-bend cholangioscope, direct cholangioscope, which have multiple bends at the end, in which can facilitate entering to the bile duct and visualization of the bile duct. Now, let me move on to the last modality, which is confocal laser endomicroscopy. We have used it to some extent in bile duct in our own centers. This is like an electron microscopy, and it's a magnified microscopy which goes through the ERCP channel, and there are Miami criteria for differentiating benign from malignant strictures. And there has been recently a Paris modification to increase the sensitivity and specificity. I'll just share you some of the features of benign versus malignant. This is how a normal confocal biliary epithelium looks like. And these are some of the patients with malignant biliary epithelium. So these are white bands which are seen, any band which is more than 20 micron in thickness, or a black band which is more than 40 micron in thickness, or a black spots like this are highly suggestive of malignancy. So these are some of our own images. You can see in the upper part. The one on the left side is suggestive of benign or a normal epithelium, when the one on the right side, very thick bands, both white bands and the black bands are suggestive of malignancies. So these are some of our own illustrative pictures from my database. Now, meta-analysis published almost about 6 years back has shown, including 8 studies, that sensitivity of confocal is almost 90% and specificity is 72%. So sensitivity-wise, scores over many other modalities. Intraductal ultrasound is used in only a few centers in the country, but can be very useful. It shows the disruption of the 3 layers of the bile duct, and it can show the polypoidal lesions, can also show the lymph nodes. Overall sensitivity is 93% and specificity is 90%. Now, some of the benign diseases, I'll just show you 1 or 2 pictures. This is IgG4 related sclerosing cholangitis. I know there is a lecture just after my talk on IgG4 related cholangitis. And then this is primary sclerosing cholangitis with a mass formation. We must remember these underlying etiologies when we're dealing with indeterminate strictures. So what's the sensitivity and specificity of various techniques which I talked about? So these are the various techniques which I've talked about. On the left side, this is the sensitivity. So if you look at the lower part of the slide, then the EUS-FNA, FISH cytology and histology combined, visualization at cholangioscopy, CLE and intraductal ultrasound has high sensitivity. Of course, the histological diagnosis would have more specificity, but with a lower sensitivity at ERCP histology, brushing, and so on, as I discussed. So I think we still do not have an ideal technique to differentiate benign from malignant strictures. This is the approach. There are many, many types of algorithm which are there available in the literature. But I picked up this because I thought this is one which is practical and is more likely to be used. So if you have an indeterminate biliary stricture, you will of course do a cross-sectional imaging and then review the cholangiogram. If it's a distal stricture, you may directly go for an EUS FNA and then decide based on the EUS FNA. If it's negative, then of course you'll go for more investigation. And if it's proximal stricture, then we would prefer an ERCP-based technique with repeated brushings, cholangioscopy and biopsies, and if possible, probe-based CLE. If it becomes negative and you still want to investigate further, then you must include PCLE and IDUS, introductory ultrasound, in your algorithm. And of course, at any stage, if you find evidence of malignancy, then you consider surgery and involve surgeons in your decision making. My last 1 or 2 minutes is, I think every word is moving towards artificial intelligence. And we have also done some work on machine learning for classification of indeterminate biliary strictures during cholangioscopy. And we collaborated with a number of centers all over the world. And we shared our data from both Spyglass DS1 and Spyglass DS2. And these data were fed into the machine. A large amount of data was collected, almost 227,836 training images, and then validation images of 56,000 images. And we got a very robust ROC curve from 25 centers, including 7 from Asia. And we found that it's very, very easy to differentiate normal from abnormal cholangioscopy. And now in the phase 2, we are working and differentiating benign from malignant strictures. These are early days for artificial intelligence in bile duct strictures, but I think they are very, very interesting time. So you will find a number of literature, a number of review articles which have been mentioned on approach to the management of indeterminate biliary strictures. There continues to be a problem in spite of all the investigations and the advantages which I've talked about, but I'm sure we are moving forward. Thank you very much.
Thank you, Dr. Goenka. Excellent talk. The floor is open for questions now. Any questions?
Excellent talk. This is Dr. Ashish. So,
yes, Ashish.
Once you have determined that, means after extensive investigation that it is indeterminate, and then after how long you'll again follow up, and what is the natural history if we found that it is indeterminate, how many eventually turn out to be malignant on follow-up?
I don't think we have hard data to share with you, Ashish. The issue is that what I'm trying to say is that before we discard any patient, that it is a non-operable patient, we must do everything possible to reach an etiology. If we have a strong doubt to suggest malignancy, then I would not go on waiting and classifying this as indeterminate strictures. I think there's no harm in operating on a patient with indeterminate stricture, provided the patients, they are not many of comorbidities. And even if it's a negative for malignancy after surgery, I would not wait for a long time and will operate on that. The idea only is that the figure of 20% of the patients being operated considering malignancy and turn out to be benign, we need to reduce that by using the various modalities which I've talked about.
Nice to hear from you.
Yes, sir. I'm sorry we missed you. I'm missing you.
Thank you very much. I just want to ask you that despite of making 10 passes with at ARCP and combining with biopsy also, why the sort of yield is only less than 60%? What wrong we are doing at ARCP? After all, you are doing the same thing with the cholangioscopy, except direct visualization. You're not audible.
Can't hear you. Dr. Goenka, you're not audible.
Please unmute.
Please unmute yourself.
Now I have unmuted. They had muted me from their end, I think. All right. So I think there are two issues in this. One is that technology. I mean, you would agree, Dr. Zarga, that we hardly spend time doing brush cytology. The rule has been that you should have 2 passes. I did not say 10 passes, 2 passes, but each time you should move the brush 10 times. I think that's what is the standard brush cytology technique is. But I agree with you that even you follow the standard brush cytology technique, in more than 30 to 40% of the patients, you will have a false negative brush cytology. And the reason basically is that you are doing it blindly. Number one, it may not be rubbing on the tissue correctly. And number two is that these are desmoplastic tissues. So they are fibrotic tissue, and it may not be coming out with the brush easily. So there's a lot of fibrous material in this. So when we are doing a biopsy, we are taking much deeper tissue than what we are doing with the brush cytology. I think that's a major difference. People have tried to take a brush before and after dilatation also, but I don't think there is a consistent outcome out of that.
My second point is that have you any experience with using a pediatric upper GI endoscopy, pushing it through the papilla and going directly for this?
No, I have never done it. I have never done it. I think even with so-called direct cholangioscopy, which are designed to enter the bile duct, the technique is demanding. In fact, initially when they were doing a balloon-assisted cholangioscopy, there were incidences of liver abscesses, and so it was initially discarded. So I think going with a normal pediatric endoscope into the bile duct, you may tend to fall back repeatedly. So I have never done it. Do you have an experience, Dr. Zargar, on this?
Because actually we're using a balloon, passing the balloon through the biopsy forceps, and just by once you inflate the balloon, the endoscope goes easily up.
Yes, the only thing is that once you pass a balloon, then your channel is occupied. So
you inflate the balloon, push the endoscope, then deflate it again.
So you deflate and then you bring out the balloon back outside. Now, only question is that then retaining the scope may be a little challenge, but I'm sure this is the technique, and you are an expert endoscopist. You can possibly get away doing anything.
Thank you very much.
Any other question? Dr. Goenka, I have a question.
Yes, Dr. Lawton.
What approach would you recommend to people who do not have spyglass in managing these indeterminate strictures?
So I understand that if you do not have a spyglass, you may not have a PCLE also. So we are working without a PCLE, without a spyglass, without an intraductal ultrasound. Then we're left with the standard technique of ERCP and brush cytology. I would say that please use whatever, spend some time taking a brush cytology. You must have an idea where you're taking a brush. You have done a cholangiogram, and you know where the stricture is. So I think even if we do a good brush, I am sure that we can increase the sensitivity from 30% to 60%. We must, I'm repeating this, the 2 passes, 10 movements of the brush each time at least should be done. People have used fluoroscopy guided biopsies also, but this will only add a few percentage more than the brush cytology itself. And I think EUS is a very important technology, and if you have an EUS, I think EUS can help us in getting an FNA, at least for the distal strictures.
Thank you.
If no more questions, I think we can wind up the session.
Thank you very much. Thanks. Thank you very much.
Thank you, Dr.
Thank you.
Thank you.
Now we'll break for tea for 15 minutes, then we'll reassemble.
We will welcome back. I request all of you to please be seated. We'll be beginning with the Pancreatico-Biliary session. Can I request everyone to be seated, please? We'll be beginning with the session. For the session, can I please invite Dr. P.K. Sharma and Dr. Kunal Das to please moderate this session. Also, can I please request Dr. Raju S. Chinna, Dr. Mohan Joshi, Dr. Neha Berry, and Dr. Kapil Sharma to please chair this session. Sorry. Can I please request all of us to be seated? We will be beginning with the last session for today, Pancreatico-Biliary session. For the same, can I please invite Dr. P.K. Sharma and Dr. Kunal Das to please moderate this session. Also, can I request Dr. Raju S. Chinna, Dr. Mohan Joshi, Dr. Neha Berry, and Dr. Kapil Sharma to please chair this session.
Good evening, ladies and gentlemen. I think we invite Dr. Nilay Mehta. Topic IgG4 pancreatico-biliary diseases. What is new?
Dr. Nilay Mehta is working in Zydus Hospital, Ahmedabad. He has been trained in Mumbai and he was our junior colleague way back. He is doing extremely well in medical gastroenterology. This is a topic which is very important. Diagnosis as well as the confusion from other disorders and surgery especially. Otherwise, unnecessary somebody would operate this patient or unnecessary an intervention could be done in a IgG4 issue. Nilay, please.
Thank you, sir. I thank Dr. Anil Arora, organizing team, for giving me this opportunity to speak on something probably which is new and old, but very important. So this is a 70-year-old woman presented with abdominal pain, jaundice, and mild itching for 10 days. Actually, patient was in Australia, where she underwent a CT abdomen and found to have a pancreatic mass and was told to go for further test and probably surgery because they thought it was malignancy. And the son lives in India, so they came down to India.
We repeated the CT scan, and CT scan showed an ill-defined mass in the head uncinate process of pancreas. You can see in arterial and venous phase, but also it showed thickening of the wall of the bile duct, and there was obstruction at the pancreatic level. The rest of the pancreas showed some cyst, but otherwise was normal. So the CT scan at our center was reported as an ill-defined heterogeneous mass with possible neoplastic etiology and possible metastatic lesion in left adrenal gland. So we did the EUS, and this is what the EUS showed. You can see a hypoechoic mass lesion in both head and body. So it was a huge mass in the head and pancreatic. But here, if you can see two, three things. One, the mass was mainly the enlargement of pancreas, but it was very hypoechoic. But what was most other important aspect was that there was thickening of the bile duct. And in fact, it was shown on CT scan, and they reported as probably cholangitis, but patient did not have fever. This is what was found on EUS. So the entire CVD and cystic duct was showing hypoechoic wall thickening, and it was, you can see there is obstruction at pancreatic level. This is CHD, and now you can see the entire hypoechogenicity of the bile duct wall. Even the pancreatic duct was showing hypoechoic wall thickening in entire length, and then we took biopsy from both head and body. And sent for histopathology. Histopathology did not reveal any malignancy. In fact, it showed significant plasma lymphocytic infiltration and significant fibrosis, as you can see over here. So we went for IHC. IHC CD138 was positive for plasma cell, abundant plasma cells. And then we did IgG4, which came positive, and it was more than 10 per high power field, which is the significant cutoff for diagnosing autoimmune pancreatitis. So this was actually a case of autoimmune pancreatitis and not a pancreatic malignancy, but that is how a patient presents in our scenario. We know that autoimmune pancreatitis are of two types, type 1 and type 2. In our country, most of the times it is type 1, while type 2 is more common in Europe and United States compared to Asia. These patients usually present with jaundice and abdominal pain, and they have associated IgG4 autoantibodies. Pancreatic imaging is classical, and we are going to discuss that. Pancreatic histopathology is classical for type 1 and type 2. The difference between type 1 and type 2 is mainly duct-centric disease. And it is associated with inflammatory bowel disorder, while type 1 is associated with IgG4 associated other organ involvement like bile duct, by salivary glands, retroperitoneum, aortitis, and other things which we'll discuss later. And they respond well to steroids. So these patients usually have acute presentation of, as we discuss, an obstructive jaundice and pancreatic mass. But mind you, these patients also can go on to have chronic pancreatitis like changes, and the patient late with steatorrhea and pancreatic atrophy. Fortunately, pancreatic malignancy is extremely rare, so they can have chronic pancreatitis like picture, but not pancreatic malignancy. Type 1 have predominantly extrapancreatic presentation, means autoimmune pancreatitis with the other organ involvement, mainly as we discussed, bile duct, nephritis or nephroma. I have seen renal lesions, and in fact, in one of the cases where we could not take biopsies from pancreas. Of course, the biopsy came negative from pancreas and lymph node, and then we took biopsy from the kidney, and it came positive for IgG4. So renal lesions, retroperitoneal fibrosis, aortitis, periaortitis, and that's why many times we do PET scan to confirm diagnosis of autoimmune pancreatitis. Diffuse lymphadenopathy is not uncommon in these cases, and of course salivary gland involvement is there. Typical imaging in autoimmune pancreatitis is either a mass lesion into the pancreas, or there can be a diffuse enlargement of the pancreas, what we call as sausage-shaped pancreas, with many a times we see a ream-like thing, and this is very common. And when we see this picture, it is almost, we are almost sure that this is autoimmune pancreatitis. You can also see, as we discussed, renal lesions. You can see periotitis, aortitis, and this is what also can be confirmed on MRI. And as I told you, in case of doubt, we want to see inflammation at other sites, we do a PET scan. This lesion is IgG4 associated diseases, so it will have IgG4, which would be rise. But remember, IgG4 is elevated only in 50% of cases of autoimmune pancreatitis. In fact, in 25% of the cases, it can remain normal. In fact, type 2 disease, type 2 autoimmune pancreatitis have more or less normal or mildly elevated IgG4. And other diseases like chronic pancreatitis or pancreatic cancer can have higher IgG4. So IgG4 alone will not guide you to confirm or rule out autoimmune pancreatitis. Autoimmune pancreatitis or IgG4 associated pancreatico-biliary disease have typical findings on pancreatogram. It can have a stricture, but normally it's a long stricture without significant upstream dilatation, or it can have multiple beaded-like pancreatic duct, but again, in between the strictures, the duct is not very much dilated. That is how you can differentiate between autoimmune pancreatitis and chronic pancreatitis. When a person has a pancreatic lesion and associated CBD, sclerosing cholangitis, we always think about autoimmune pancreatitis. And when we say autoimmune sclerosing cholangitis, it can have a stricture, but more importantly, these patients, what I showed you in my EUS video, they show very classical hypoechoic wall of the bile duct. And when you have these two combination, you have to think about IgG4 associated pancreatico-biliary disease entity. You have to differentiate it between variety of biliary stricture, mainly the primary sclerosing cholangitis, secondary cholangitis, and malignancy. In IgG4, as I told you, hypoechoic wall, and that goes through the entire wall of CBD and CHD many a times, or even cystic duct. There is an associated pancreatic involvement or other organ involvement in IgG4 disease. In case of primary sclerosing cholangitis, the strictures are mainly intrahepatic. Of course, you can have extrahepatic, but it is mainly associated with inflammatory bowel disorder. There is IgG4 high in case of IgG4 sclerosing cholangitis. In case of secondary cholangitis, you have stone disease. In case of malignancy, you can see a stricture with shouldering of the upper CBD. Of course, just by different features, you cannot 100% rule out all this etiology or differentiate between the different etiology. And sometimes that's why you have to do more tests. Histopathology is very classical in case of type 1 autoimmune pancreatitis, type 2 autoimmune pancreatitis. I showed you in my slide that this patient have predominant lymphoplasmacytic infiltration. They have significant fibrosis, and this fibrosis is like whirling fibrosis, which we call as a storiform fibrosis. They have obliterative phlebitis, and when you see all these things, you have to send this patient for IHC, and IHC shows IgG4 staining, and which has to be more than 10 per high power field. And if that is the case, it is type 1 autoimmune pancreatitis. Type 2 autoimmune pancreatitis is mainly duct centric, and here there is predominant something called granulocytic epithelial lesions with neutrophil infiltration. So it's not mainly plasma lymphocytic infiltration, it is mainly neutrophilic infiltration, and that is how you differentiate between type 1 and type 2. So how to diagnose AIP? Of course, if you have histopathology, what you discussed, you are almost sure that this is autoimmune pancreatitis, and probably you may not require too many corroborative evidence to confirm that this is autoimmune pancreatitis. But what if the imaging has shown changes of autoimmune pancreatitis, and I showed you on CT scan, on MRI, what is classical of autoimmune pancreatitis. So if those imaging findings are very classical of autoimmune pancreatitis, then you need just one collateral evidence, meaning that if you have imaging which is classical with IgG4 which is high, or some other organ involvement, or biopsy is positive. In our case, we did not go further because EUS was very classical of autoimmune pancreatitis, and biopsy was suggestive, very classical of autoimmune pancreatitis. So if that is case, you can say it is autoimmune pancreatitis. What if the classical findings are not on CT? Then you need at least two collateral evidence, meaning that IgG4 has to be high, and with that, either biopsy has to show the positivity, or the pancreatic or biliary lesions should be suggestive of autoimmune pancreatitis. However, sometimes and many a times this happens that everything is indeterminate, and then if you have a higher chance of autoimmune pancreatitis, what you can do is start these patients on steroids, and if they respond with steroids, then probably it was autoimmune pancreatitis, and if they don't, then you have to be extremely cautious saying that this is 100% autoimmune pancreatitis. So how to differentiate? If you have autoimmune pancreatitis like finding with other organ involvement like pancreato-biliary, sclerosing cholangitis, aortitis, salivary gland involvement, then you have autoimmune pancreatitis. Additionally, if you have IgG4 which is high, it helps. If you have duct, and we talked about what ductal changes are there in pancreatic, and bile duct changes in autoimmune pancreatitis. In strictures of pancreatic duct, autoimmune pancreatitis, rest of the duct is not dilated and rest of the gland is not atrophic. In chronic pancreatitis, you have stricture and upstream dilatation, and there is atrophy of the gland. Additionally, you have calcification. If you have malignancy, in fact, you have more atrophy, even more atrophy compared to chronic pancreatitis. So that is how usually you differentiate between autoimmune pancreatitis, chronic pancreatitis, and pancreatic malignancy. The highest atrophy is seen in chronic pancreatitis. So now coming to, once you have diagnosed it is autoimmune pancreatitis, what about treatment? Do every patient need autoimmune pancreatitis? No, asymptomatic patients can be observed, but all symptomatic patients should be treated, meaning if patient has jaundice, pain, back pain, or other symptoms, they need treatment. What if they are symptomatic? Other organ involvement also will need treatment. What if they are asymptomatic? In that case, if you have persistent pancreatic mass, which is going for more than 3 to 4 weeks, or if you have persistent liver abnormality, going more than 2 to 3 weeks, or of course, if you have IgG4 related disease with other organ involvement and they are increasing in severity, then you need treatment even if they are asymptomatic. How to treat? Glucocorticoids are the mainstay of treatment, and we always give these patients, start with 40 milligram of prednisolone, and we don't taper it up for 4 weeks. We give it for 4 to 6 weeks. We see for the response. Response is seen mainly by the imaging and partially by the IgG4. We don't rely IgG4 entirely. Imaging is the most important thing as far as the response is concerned. After 4 to 6 weeks, if there is a response, we start tapering prednisolone 5 milligram every week or 2, not very rapid tapering, and we give it for 12 weeks. Again, do imaging and see IgG4. If there is a complete response, then we stop it. But we always keep a watch on these patients. We ask the patient for new symptom or recurrence of the symptoms because relapse rate is high. Even if patient remains asymptomatic, we always do imaging and IgG4 at 6 weeks or 6 months. If there is no response at 4 to 6 weeks, always think about other diagnoses because we don't want to miss pancreatic malignancy over here. And pancreatic malignancy, which was missed and was operable, now has become inoperable. So that is the scenario we want to avoid. So if patient does not respond to glucocorticoids, we have to rule out by any means pancreatic malignancy. Of course, there is a small percentage of autoimmune pancreatitis which would not respond to steroid. So as I told you, glucocorticoids are the primary treatment modality for achieving remission. Glucocorticoid efficacy, means steroid efficacy rates are pretty high. In type 1, approximately 99%, in type 2, 82%. But relapse is higher for type 1. So response rate is higher for type 1, but also the relapse is higher for type 1, 31% compared to 9%. And those associated. So suppose you have a patient of pancreatic along with biliary sclerosing cholangitis like picture, they respond to steroids, but their chance of recurrence is high. Immunomodulatory agent like azathioprine and mycophenolate alone are ineffective in achieving remission. Rituximab, which is a new drug treating for IgG4, and it is very effective for all patients, including steroid responsive, steroid intolerant, or steroid refractory patients. All biliary strictures may not require ERCP, and we have treated strictures, bile duct strictures with mild jaundice, no itching, no fever, without putting a stent, just by steroids. So what about rituximab? Rituximab is a great drug for IgG4 related pancreatico-biliary disease, indicated when glucocorticoids are contraindicated or patient is intolerant or there is less than partial response to steroids, or you have multiple organ involvement along with pancreatico-biliary disease, then you need rituximab. Rituximab is indicated both for induction and induction of remission and maintenance of the disease. Normally 2 doses of rituximab are given, 1 gram IV, 1 dose and second dose after 2 weeks, that is 15 days. Response rate is to the tune of 90%, but again relapse is high to the tune of 21%. Relapse is more common when you have multi-organ involvement. For those patients who are at high risk of relapse, they need maintenance therapy. So you give treatment for 12 weeks. Not all patients would require maintenance, but those patients with type 1 and diffuse enlargement of pancreas, more than 2 other organ involvement, delayed radiological remission, or persistent high level of IgG4, or those who have relapsed for more than once would require maintenance therapy. You can give azathioprine for maintenance of remission. You can give prednisolone between 2.5 to 10 milligram. You can give mycophenolate. Also, you can give rituximab. Here, 1 gram is given every 2 to 6 months. It is extremely effective, but the chances of infection are high when it is given for a longer time. And when you are giving rituximab, always do total core antibody, because we know that rituximab is associated with higher rate of HBV reactivation. To end my talk, whenever you see a patient of suggesting acute autoimmune pancreatitis, you have to confirm it the way we have talked about. Start steroids, response at 4 to 6 weeks, go ahead and treat patient as autoimmune pancreatitis. If there is no response, then you have to think something else. If there is a response, but this patient has a higher chance of relapse, then you have to give maintenance therapy, either glucocorticoids 2.5 to 10 milligram, or azathioprine or mycophenolate, and in a small subset of patients, rituximab. Thank you very much.
Highly inspiring talk, sir. I'm wondering how to evaluate the case which you shown here if you don't find any mass, any lymph node. The case, only the diffuse thickening of bile duct starting from the intrapancreatic part till the hilum.
I have treated at least 3 patients just sclerosing bile duct without any pancreatic lesion. And we tried to do everything. Biopsy was not positive, but the bile duct was so classical. So then you have to see for the response to steroids. And that is what we do. You can do ERCP, you can do brushing, but then you have to just, so no pancreatic involvement, just the bile duct involvement. That's what you are saying? Yeah. So I treat them with steroids and see for the response. Yeah, and without any histopathological diagnosis.
Nilay, any old person, old lady coming with a pancreatic head mass, as a surgeon and as a surgeon's eye, we would think in terms of malignancy. Now it means that for every pancreatic mass or similar such lesion which you have shown, mandatorily you need to evaluate by EUS. That is what you want to advocate. And you think that the biopsy is always conclusive along with the other IgG markers and other things? Or can one, on the radiological basis, if you feel that this is IgG4 related or otherwise, can we give a trial of glucocorticoids without going to the crux of the histopathological diagnosis? The second question, which I want to ask you now, that if you take 15, 20 days or 3 weeks of corticosteroids, does your histopathology picture, the plasmacytic infiltration and other things, will they change if you give a course of glucocorticoids for a period of 3 to 6 weeks?
I'll
So
just add a question to this. that would
can I just, I would not remember otherwise. So the first question was what you do in case of doubt. Yeah. No, then you have to refer the patient where you have EUS facility. You just can't treat patient in 2022 just by clinical diagnosis alone, and you miss pancreatic malignancy. That's not done. So we always do EUS, but many a times you take EUS guided biopsy and your pathologist would say there are not enough plasma cells, so there is no point in doing IgG4. So what would I do? So I take biopsy again after some time. And I do PET. I very often do PET to see other organ involvement. So suppose everything is normal and there is no steroid response, then it is better to send this patient for surgery and have a negative VPUL rather than waiting and getting patient coming back to metastasis, and then you can't do anything. Second question was, yeah. So I've seen that everything becomes normal, but I have not taken biopsy again. But you have diffuse enlargement of the pancreas, it becomes normal. It shrinks actually. The mass is gone. The bile duct stricture opens up even without ERCP. But I don't know what happens to fibrosis, because fibrosis, does it reverse? I don't know. And I could not find anything in the literature, but my logic says probably fibrosis would not reverse 100%. It is impossible. This is a fibro-inflammatory disease. This is not just the inflammation. And this fibro-inflammatory disease does not occur just in the pancreas or the bile duct. It is everywhere. So if you have salivary gland inflammation, it's there. If you have renal involvement, it's there. So, but I have never taken repeat biopsy, so I would not be able to tell you. And there is not enough literature what happens. But I think fibrosis should remain there. Yeah.
So for patients with IgG4 related sclerosing cholangiopathy, it's important to differentiate from cholangio-CA. So would you recommend doing a cholangioscopy and guided biopsies for these patients before giving them a trial of steroids?
Yeah, cholangio-CA one, it will have a short stricture. Will not have upstream thickening. Of course, you can have it if you have placed a stent, somebody has placed a stent, or cholangitis. But then IgG4 cholangitis will not have fever. Malignant cholangitis means cholangitis secondary to malignancy will have fever. But of course, if there is doubt, it is better to do a cholangioscopy.
Especially for hilar strictures, sir.
Hilar stricture chance, see again, hilar cholangio-CA will have one stricture. IgG4 has more diffuse disease. In case of doubt, you can do cholangioscopy. Cholangioscopy in hilar stricture has a higher chance of cholangitis, that you should be aware of it.
One practical question as an endoscopist, Are these strictures are easy to pass by
Oh, yeah.
wire, or that they are difficult?
That would be
Dr.
very
Saurabh,
easy to
please.
pass.
Yeah, no, very nice talk. Thank you. So there are criteria proposed by Dr. Chari on diagnosis for autoimmune pancreatitis and cholangitis, the HISOR-T criteria, in which histology is a part. However, getting histology is always a challenge. Now, we had discussions regarding this, whether histological specimen from the pancreas with FNB needles, this is non-mass forming lesions. Would it be something worth considering, or it leads to higher risk of pancreatitis? And is that what
I
what is your
always take
thought on that?
FNB.
Yeah.
Nothing happens.
So regardless of the formation
Yeah,
of mass. or
lots
not.
and lots of samples in this pancreas going everywhere because I don't want to miss malignancy. So I take in fact 2 more, what is required, enough tissue, nothing happens.
Ampullary biopsy from
And about that criteria, I have those slides, but they are so confusing. I don't want to confuse everybody with those criteria. Yeah.
role of ampullary biopsy in diagnosis of IgG.
I don't take it. I try to take it every time it came negative.
Regarding the CA99 levels in these situations.
In any situation, CA99 should not be done if you don't see a mass. It's the most useless test if you don't see a mass in pancreas.
What about the cholangiocarcinoma?
If you see a lesion, then you do CA99. If you don't see a lesion, cholangiocarcinoma, cholangitis will have CA99, which is very high.
Not cholangitis, I'm saying cholangiocarcinoma with
In cholangiocarcinoma or even IgG4, if you have cholangitis, it can be sky high. CA99 will not help you.
I had a similar patient actually. He had a lower CBD stricture. In fact, if you go for some basic books also like Harrison's internal medicine also, if you see, they recommend now any patient who comes with a tapering lower CBD stricture, biopsies and everything negative on ERC, IgG4 should be a strong consideration. In fact, they said that this is now mandatory to get these levels in whenever you have an isolated lower CBD stricture. We got it in this. IgG4 was, I think, he was an elderly man. All the criteria that he mentioned on that were there in that patient. Elderly patient, he was a male patient. IgG4 levels are, I think, 6 times elevated. From the lab from where I got, the upper limit was around 2. I don't know what unit they were. It was more than, I think it was 12 almost. We did a sphincterotomy, took liver biopsies, that was negative, got a PET scan, nothing was there, pancreas was absolutely normal. We put a stent, still I was having tachycardia, what to do, just put a stent there. I explained to the patient also that there is a possibility, please come for follow-up. Now, more than a year has passed. His CA99 at that time, there was no frank cholangitis, but still it was 3,000. He has come now to me after 1.5, I think almost more than a year now. Absolutely fine. LFT is normal, CA99 is absolutely normal, but his IgG4 level is going up again. I had given him a trial of steroid, which probably responded. There clinically is absolutely fine, but IgG4 levels are again going up. So it's, I think, now 6 times elevated. So I have to put him again on steroid.
You have to put him on maintenance.
So this I have given him for 6 weeks. I will and then check again.
In fact, I had one patient where twice US FNAC done outside had shown malignant cell. I was not sure because there was a diffuse thickening of the bile duct. I checked it at 2 places, did not show malignancy. Put her on, young patient, put her on steroid, and after 4 years, she's still asymptomatic.
Last question, we'd love to.
Yeah, there is a lot of variability in the presentation of IgG4 disease. This may be a mass forming or even without any mass. And if there is the bile duct involvement, this may be higher or the lower down. And we have to continue for a longer time the corticosteroid or any other immunosuppression. If we give it for 3 months only, then almost always there is a recurrence.
I showed the criteria where you have to give maintenance therapy. So
you have shown that this is my experience. I must have treated maybe 15, 20 patients like this. And see, if the duct is dilated, there is a stricture at the lower end, and many times there may be a raised alphas only, even after the corticosteroid therapy. The IgG4 may persist, the raised IgG4 may persist for a longer time. So you have to monitor. And then the PAT is very important in the evaluation of the IgG4 disease. And we have seen recurrence also. And in the recurrence, they don't present with the pancreatic involvement. They come with the other organ involvement, maybe a salivary or the renal involvement. So this is a very interesting disease.
That's my one small question. I enjoyed your talk. Is IgG4 ever elevated in pancreatic cancers?
Yes, it can go up.
How much?
I don't
No,
know, but
that-
it
this
can.
my point is that
Yeah, in
if
small
you- is it-
percentage of pancreatic malignancy, the literature has shown that IgG4 can go even more than 2 times the upper limit of normal.
Usually in pancreatic malignancy, IgG doesn't go very high. So is it necessary to have a biopsy if you're a patient who has a mass and US shows there are no features? Why should we go for biopsy if IgG4 is very high? Because if he's a
I
pancreatic
showed a
malignancy,
slide. I showed a slide where I don't know. I can go back, but there even IgG4 in pancreatic malignancy were higher than 2 times the normal limit. As I told you, it is better to take biopsy. Now everybody has a US. It is better to take biopsy even if IgG4 is significantly high. I always take biopsy.
and second point is many of these patients in the course of disease get a renal involvement. What type of immunosuppression you would like to give them that time?
In fact, my patient had adrenal involvement. I did not show. We also took biopsy from the adrenal and showed the same changes. I think steroids are good enough to take care of almost all lesions. For maintenance, you can give and I give azathioprine, but you can still give low dose of steroids too if you don't want to give azathioprine. But and almost all my patients on maintenance are on azathioprine. Thank you.
Thank you for the session. For the next session, can I please invite Dr. Sudeep Khanna and Dr. Shrikant Mukhevar to please moderate this session. Also, can I request Dr. Apurv Pandey, Dr. Dibas Khatka, Dr. Fazal Rahman, and Dr. Amit Miglani to please chair the next session.
Good evening, everyone. The next speaker, every one of us, I'm sure know, is Dr. Roopjyoti Tarukdar, who has a lot of work in pancreatitis. And, I'm fortunate to know him as one of my earliest DNB who left me in lurch and went to the USA. But I'm glad he's in one of the best institutes in the country. So he'll be talking on mechanism and management of pain in chronic pancreatitis. Dr. Roopjyoti, please.
Thank you, Sudeep, sir. And it brings lots of memories from our old PSRI days. That's many years back. So let me begin with thanking Dr. Anil Arora and the whole team, Dr. Ashish, for his frequent emails and messages for this meeting. And thanks for bringing up this beautiful meeting also, almost like half of the full hall at 6:30. That's great, I think, sir. So my topic given is to talk about the mechanisms of pain in chronic pancreatitis and management. Actually, it's a very long talk. It will take 3-4 hours to go into the whole details. But what I'll do today is just touch upon the important aspects, and then maybe we can discuss more. So when we think about chronic pancreatitis, what comes to our mind is something like this. Atrophic pancreas, the dilated duct, lots of stone in the pancreas, strictures. This is a common picture that we think of. And whatever be the etiology, the traditional belief of pain is that the pain impulse will go from the pancreatic tissue through the spinal cord and then hit the thalamus, and the whole thing happens. But what happens to the patient who comes to us and tell us about pain is not only about the thalamic involvement, it's about their pain experience and pain perception, which is a whole lot of different conceptual issues, just rather than just the pain's signal to the thalamus.
And for this pain perception and experience, there will be lots of other involvement of the hippocampus, the amygdala, the prefrontal cortex, the anterior cingulate cortex. And these are the areas of pain processing, long-term pain memory, and emotional responses. And that is why probably different patients will report different kinds of pain, even to the pathophysiology is same. So this is what we'll be talking today. And since I told in the first slide, we think more about the ductal calculi, ductal strictures, and that's why most of the treatment are directed towards removing the ductal obstruction, doing surgery, endotherapy. But in that process, probably overlook the other pathophysiological processes that go in the brain. It's very important to remember chronic pancreatitis is a disease that is originating in the pancreatic parenchyma, not in the duct. That's why our thought should come out of the pancreatic duct and look at the disease from a holistic approach. So this is what happens very early on in the disease. The disease starts much before what we see in the form of stones and strictures. What happens here is the recurrent inflammation that goes within the pancreas, the recurrent acute pancreatitis episodes. That time probably we'll just see some strands and hyperechoic foci in the pancreatic parenchyma, but this is the classic progression of the disease. This is a young guy who presented to us in December 2014, recurrent acute pancreatitis. If you see here, the pancreatic duct appears normal, very slim. The pancreatic parenchyma is intact with some peripancreatic stranding. This is a recurrent acute pancreatitis. He comes back with recurrent pain in 2017, 3 years. And if you see a dilated duct, side branches, calcification within the pancreas. So this is the classic progression of our Indian patients who develop florid chronic pancreatitis within a short while from the recurrent acute episodes. So it's important to understand the way it presents. Of course, it may present as recurrent acute episodes, and the treatment of that is same as any other acute pancreatitis treatment. But there are 4 other types of pain that we need to recognize when we see this patient. Earlier, if you remember, there was a concept of Aman 1 and Aman 2 pain. So this is the classical Aman 1 pain, where there will be pain episodes with no pain in between. Those are discrete episodes which may be underlying acute pancreatitis or some mechanism going on. And the 3 other types are the persistent pain with slight fluctuation. There could be constant pain with exacerbations in between, or there could be constant fluctuating pain. And it is very important to understand the types of pain and how the pain is generated, and that helps us in dealing with this disease. So when we talk about pain management, the first thing is short-term pain management. Again, that is easy. All of you know, we can just follow the WHO pain ladder. Begins with NSAIDs, and then you can step up to the opiates. But one thing is very important. It's very important to avoid high potency narcotics. By high potency narcotics, I mean morphine derivatives, nalbuphine. Now there has been a trend in India to use nalbuphine more and more, fentanyl. This should be avoided because this has a tendency for dependence. Morphine-based derivatives can cause narcotic bowel syndrome. And if we use these agents for a long time, we may give the patient a new disease, narcotic bowel syndrome, rather than chronic pancreatitis pain. And it is also shown, which is not often discussed, is there is something called mast cell degranulation. Morphine-based analgesics can degranulate the mast cell in the pancreas. And mast cell has tryptase, which can perpetuate the inflammation of chronic pancreatitis. There are lots of basic science data, which I'm not going to today, but just suffice it to remember, high potency narcotics should be avoided, and medications like tramadol or tapentadol are good enough with similar efficacy but lower side effects. Now, if we go to the long-term management, so whatever be the pathophysiology, initially in the early stage of the disease, we do not see the stones and the strictures. And whatever be the pathophysiology, be it alcohol, be it smoking, be it genetic polymorphism, which can cause trypsin activation, inflammation, all these will cause activation of pancreatic stellate cells. And the pancreatic stellate cells are such that once it is like nuclear fission reaction, once it gets activated, it do not come back to normal in chronic pancreatitis. It will activate the other stellate cells around it, or it will activate itself by autocrine pathways. So what happens when there is too much of stellate cell activation? There will be a persistent pro-oxidant state, and that leads to lots of inflammation. And this becomes a vicious cycle. So once you get inflammation, whatever you do, the inflammation will go on. So this is definitely a target of treatment. And what I like to call this is a mechanistic target, because these are mechanisms of pain which is causing recurrent inflammation. So what this oxidative stress does is it will activate the pain receptors within the pancreas, like TRK, TRPV receptors, so which leads to action potentials, and this is called nociception. Since the basic pathophysiology at this stage is oxidative stress, the logical use would be of antioxidants. Now, which antioxidants to use? There are several antioxidants available in the market. So there has been several studies, and we did this meta-analysis collating all those studies, and what we found was antioxidant combination containing methionine has the highest efficacy to improve pain in this patient. And then yesterday we were discussing what the numbers needed to treat. So if we have antioxidant containing methionine, the numbers needed to treat is 5. So to treat one patient or make one patient free of pain, you have to treat 5 patients, which is pretty good. Anything below 8 is a good NNT. So it should be realized that the antioxidant that you give should have methionine in that combination. Now, it's very important again to understand which patient won't respond. I mean, it's not that any pancreatitis patient will come and you'll give on antioxidant for a whole lot of time. So it's important patients who are on active alcohol use or who are actively smoking, long duration of disease, elderly, chronic use of morphine or derivatives, these patients are unlikely to be responsive to antioxidants. Fortunately, our Indian patients are mostly idiopathic, young patients, and we don't use narcotics as often. So our patients are more likely to develop, improve with antioxidant therapy. And that's why methionine containing antioxidants should be initiated early on in our patients with chronic pancreatitis. Now, what happens in the next stage? So what I was talking about, the earlier stage of, again, by early and intermediate, I don't mean these are watertight compartments. There are a lot of overlaps. Just for making the concepts easier, I have divided into discrete components. So what happens in the intermediate stage, this is where the calcification, the strictures, the stones will start appearing. And at this point, the diagnosis is easy. You do ultrasound, transabdominal ultrasound, or even a chest, even an abdominal X-ray can pick up stones. So here, what is important for us to understand is to look at the parenchymal volume, how much parenchyma of the pancreas is left, the location of the calculi, is it in the duct, in the head region of the duct, body region, or panductal stones, the ductal morphology, if there is any stricture, and if yes, where. Because this will help us to determine the type of or the modality of treatment that we'll be using to treat these patients. And finally, most important to see if there is any local complication or mass lesion. We should not miss a pancreatic malignancy in this patient. So any doubt of a pancreatic head hypodense area on CT, they have to be evaluated thoroughly and rule out a pancreatic mass lesion. And these are now, I call them morphologic targets, because we have a morphologic change and ductal stones or strictures or biliary strictures. This can be treated by different endoscopic or surgical measures. And I think this stage of these features of the disease are the easiest to treat if you have the right kind of infrastructure and the right kind of expertise. So if the patients have a ductal stone that is large enough, more than 5 millimeter, the ideal choice also recommended with the ESG guideline is ESWL. Based on the stone burden, you can add do a sphincterotomy and put a stent, or opt not to put a stent. And smaller stone can be removed simply by endoscopy and balloon rolling. Now we have to understand again which are the patients who would respond to endotherapy. So a patient who has a solitary stone or a small bulk of stone in the head region, these are the patients who would respond better. And if you see, this is the beauty of ESWL. This is a patient, the pre-ESWL image showing dense stone in the head region, pancreatic duct head region. Post ESWL, these are pulverized. You can see the density has come down. There are fragments. And then after that, it's saline flush, the whole duct is clear. So you can see the morphologic response or the technical response immediately. For the clinical response, we have to wait for some time. So these are two of our studies that we published. And we have, I think, one of the highest series now recently published, 5,000 patients. So we can see that up to 60% of patients are pain-free beyond 5 years. So this shows the efficacy of ESWL. But if you encounter a patient like this who has a pan ductus and the whole pancreatic duct is full of stone, or stones are mostly in the tail region, or there are local complications, outlet obstruction or a mass lesion, these patients should not be treated with endotherapy. They should be directly sent to the surgeons, because endotherapy was the results are unlikely to be beneficial, or they may not be completely cured. So these are the patients who would benefit best with surgery. And the cherry in the cake here is if we do ductal decompression, be it endotherapy, be it surgery, before the development of diabetes, these patients, the development of diabetes in these patients are delayed by around 4 years. But if the patient unfortunately has diabetes at the time of endotherapy or surgery, the diabetes do not change. But if we can do it before endotherapy or surgery, the diabetes seems to be delayed, especially in the patient who has idiopathic chronic pancreatitis. We did not see that in the patients who had alcohol or smoking related chronic pancreatitis. And in patients like this, where you see upstream stricture, dilated duct, these are patients who respond better to surgery. And these are the patients where we can do a distal pancreatectomy and give them back their islets in the form of autologous islet transplantation. So again, I'll not show these features now. Now, many of you would probably ask me, does enzyme help in pain? Currently available the enteric-coated enzymes available in India are unlikely to help in pain, because they are not designed, their composition and their mechanism is not designed to help in pain. But non-enteric-coated enzymes could have some benefit. And this is a randomized controlled trial that we are doing. We call it AnyPERT. And probably in a year and a half's time, we will have the results. Now, many of these patients would come back to you with a relapse. Many of these patients do not respond adequately to the treatment that we give. What might be happening? So here there are two very discrete scenarios. In the first situation, the patient may have a persistent PD stricture, or he may have a new ductal calculi, may have a mass lesion or local complication. So if you deal with these pathophysiology at this point, the patient would be likely to respond. There will be another substantial group of patients who come back with pain, but they have an intact sphincterotomy, the duct is already clear, if LPJ was done, the anastomosis is clear, and they have a clear duct or very faint soft stones. These patients also have pain. So why are these patients coming back with pain or not responding? So here, let me introduce you a concept called sensitization. Okay. So what happens as the disease progresses, there will be lots of neural inflammation. So if you see here, these are different markers of neuropathy called fractalkine that is overexpressed. So that leads to neural inflammation, glial activation. There will be lots of neural remodeling, autonomic changes. So when this happens, what happens? There will be this pain, again, coming back to the old picture, with pancreatic nociception, the whole pancreatic segments which go through the celiac ganglion would get activated. But if this keeps on going for a long time, many months and years, what happens? There will be this neural inflammation will progress to the spinal cord, and the entire spinal cord gets activated. So many segments above the and below the T10, L1, L2 gets activated. So what happens at this stage, if food is there in the stomach, food is there in the intestine, then also the patient will perceive that as pain. So this is very typical of pancreatic neuropathy, and this is what I again call the mechanistic target. Now the problem is, and this will cause phenomenon like spinal hypersensitivity, and finally it leads to neural reorganization in the brain. And this was elegantly shown in this study published several years back. What the authors did was they gave electrical stimulation to the esophagus, stomach, and duodenum, and these are healthy volunteers. And these are the areas where they complained of having pain during the electrical stimulation. But if you see in the patients with chronic pancreatitis, the electrical stimulation in the stomach and duodenum resulted in pain in a much wider area. So this shows that more number of spinal segments are getting activated, and this is very typical of pancreatic neuropathy. But how to identify neuropathy in the clinic? So now several tests have come up. We are doing this kind of test in a research protocol. There are several instruments for pinprick sensation. Then this is something called a pressure ergometer. So what we do is we give different pinprick sensation to different dermatomes of the patient. And also we look for the pressure sensitivity and tolerance to pain and the pain threshold. And based on this, different calculations are used. And
we calculate and identify presence of neuropathy in these patients. And if the patient has sensitization only in the T10 segment, we call it segmental sensitization. If it is more widespread in different segments, this is called widespread segmentation. And this is very typical of pancreatic neuropathy and central neuroplasticity. Now, you may ask, these are all research tools. Why I'm telling you all these things? These are not available routinely. So we did this study to see if the QST parameters are, if we have some clinical surrogates that would indicate these QST parameters. This is still an ongoing multi-center study. We have recruited around 200 patients so far. So it is so interesting to see that 50% of patients had a change in pain character, 25% had involvement of new areas, and almost 1/3 of patients had no apparent trigger. They just suddenly started having pain out of no reason. And when we did a logistic regression, what we found was that there was involvement of new areas. If the patient has significant depression and if the patient has long-standing diabetes, these patients are likely to have neuropathic pain. And that is why it's very important to take a good history of the pain, the nature of pain, the trigger factors, what brought up the pain. So how to treat this patient? Okay, this is again another extension of our previous studies. This is something very new where we are. So I was the first healthy control, and this is a picture of my research coordinator doing it in another patient. So here we are combining QST with ECG and autonomic changes, and trying to find out some mathematical algorithm if we can predict the different neuropathic pain. So how to treat this patient? So there is a study that have shown that pregabalin helps in this kind of patient over a short period, and it can be used for a longer time. And we extended the study by adding antioxidant to pregabalin in these patients who come back with pain. And it seems to be working well for them. Even after 6 months of treatment, there was significant pain response. And many of these patients are still coming back to our OPD with very minimal complaint of pain. Now, again, I'll take another 2 or 3 more minutes. Once sensitization happened, then just like any other chronic illnesses, the patients will start having depression and anxiety. This is a long-standing disease. Patient come back to recurrent pain. So there will be some kind of anxiety, depression. And again, you may ask me, any chronic disease will have depression, anxiety. What's so different with chronic pancreatitis? So to answer that question, what we did was, in this study, we tried to look at the brain metabolites by using magnetic resonance spectroscopy. And we had around 50% of these patients had some degree of depression. And when we looked at the magnetic resonance spectroscopy, it was so interesting to see that the patient, so these are healthy controls, these are the brain metabolites in different areas. The anterior cingulate cortex, basal ganglia, hippocampus, prefrontal cortex. If you see in the hippocampus, compared to the healthy control, where you see this peak of metabolites, in the patients with severe depression, pain, and chronic pancreatitis, the metabolites were significantly reduced. And we did some kind of correlation analysis. Again, it may look complicated, but just to make it simple, the emotional function and the cognitive function of these patients correlated inversely or significant negative correlation with the left hippocampal and acetyl aspartate concentrations. And it was more stronger as the severity of pain increased, which means that this figure basically combines the degree of depression, severity of pain, and the metabolites in the brain. So it has to do something, the depression has to do something with the relapse or the response to pain. And what happened when we counseled this patient? We started counseling this patient in a very specific disease-oriented manner, not just a general counseling that nothing will happen, don't worry, not those kind of things. We spent 35 to 40 minutes with these patients and discussed with them about their disease based on their clinical features, imaging features, and responses, and what the future could be. And when they came back after 3 months, so this is the pre-education pain and depression proportions or levels. And if you see when the patient comes back after 3 months, then proportion of patient without depression, proportion of patient having significant pain improvement was much higher. We looked at more critically, post-depression, there was significant, post-counseling, there was significant reduction in the depression score, significant improvement in the emotional function, but also there was significant improvement in the pain score and episodes. Counseling had nothing to do with the pancreatic disease or inflammation. So why did they have an improvement in this pain score? So we believe because of counseling, probably there has been some change in the brain metabolites that has helped in coping of their pain. So to answer this question, actually, we are conducting this randomized control trial still on enrolling is on. We call it the PEP-CP, Personalized Education and Pain Response in CP. Again, maybe 1 or 2 years, I would be able to tell the mechanism, how could they have benefit in pain. So finally, ladies and gentlemen, I'd like to present this holistic insight of pain. Again, I had already talked about pain perception and experience. That's what the patient tell us, not just the transmission from the pancreas to the thalamus. Pancreatic morphology, pancreatic inflammation, we all know. Now we have more information or more data on the widespread sensitization, descending inhibition, altered brain metabolites. I had shown you data. Anxiety, depression, again, can be related to metabolites, again, lead to this perception. And there could be several other factors like stress, past experience, personality trait. I'm not sure if this causes brain metabolite alteration, but they definitely cause poor quality of life that could lead to pain perception. And this is something I am fond of calling as a maze of conundrums. And there are treatments of these parameters now. If you see here, there are antidepressants, endoscopic therapy, anti-inflammatory therapy. There are some papers on counseling, CBT, cognitive behavioral therapy, spinal cord stimulation, small studies, though we need to do more studies. But the problem is to pick up which patient would respond to which kind of treatment. So these are all overlapping. These are not watertight compartments. Everything are so overlapping and it's very difficult to find out. So I think at some point, our artificial intelligence may come to our help. We have just started thinking of using different AI machine learning modules to try to find out which kind of patient would respond to what kind of treatment. It's very early. Probably after a couple of years, we'll have more clarity. So finally, it's important to think out of the duct. We have to think of pancreatic pain, just not from the duct, but a holistic perspective. Majority of the pain as the disease progresses would be benefited by treating extraductal features like the brain, the metabolites, the depression, the anxiety. So finally, this is the take-home message. Antioxidants should be begun early on, but if the patient in an advanced disease have a very atrophic pancreas, no parenchyma is left, antioxidant is unlikely to help in those patients because there is no tissue for oxidative stress to get generated. Intervention, if in a symptomatic patient, if the patient is not symptomatic, no pain, we should not do endotherapy or surgery. And if the patient has symptom, we should do early intervention so that we can delay the development of diabetes. That's another benefit. Patient has sensitization neuromodulators, and all throughout the treatment, nutrition, personalized counseling is important. So finally, I'd like to acknowledge there is lots of people I have to acknowledge, but these bold guys are the people who are involved in these data that I had showed. Our granting agencies without whom many of the studies are not possible. And finally, I'll welcome you to Endocon at AIG next week, and then Pancreas, the IPC annual meeting next month in Delhi. Thank you, and I'd be happy to take questions.
Thank you, Dr. Rupjyoti.
Thank you.
It was an excellent deliberation of the different mechanisms of pain. As you can see that the topic is extremely complex. But I have one comment.
Yeah.
Most of in clinical practice, when you have a patient with dilated duct, and when you do stenting or remove the stone and reduce the ductal hypertension,
yes.
Majority of these patients, the pain gets relieved.
Agreed. Yeah.
So ductal hypertension and the obstruction to duct should be considered as one of the mechanisms.
Yes,
Said that,
yeah.
Another 2 or 3 things. What is the role of celiac ganglion block? That's number 1.
Yeah.
Secondly, majority of these surgeons, they do head coring, which gets relieved. So whether there is something like a pacemaker in the head, which is responsible for it.
Yes.
And third, you can take on this fentanyl patch as an analgesic.
Right.
These 2 questions.
Yeah, so 3 things. One, pancreatic ductal hypertension is definitely, no one has done a well-designed study to check the ductal pressure and remove the stone and do a ductal pressure again to see if it's reduced. But from our observation that remove the stone, as you said, and we also see that they get relief of pain. So it is believed that there is some ductal hypertension. If you remove that, pain come down. But there is a very elegant study from a Japanese group. It's a basic science study where they had taken pancreatic stellate cells in a Petri dish and put pressure, 80 milligram of mercury. And then the stellate cells started producing oxidative stress. So there is a logic of now, based on that study, it is sensible to remove these pancreatic stone, reduce the pancreatic ductal pressure, so the stellate cell activation comes down. And with that, inflammation is supposed to come down. So that is the basis of benefit of endotherapy. The second question, I'm glad that you asked about celiac block. If you remember in one of my slides, once sensitization develops, even if you remove the pancreas, the pain generates in the spinal cord, pain generates in the brain. So in that case, celiac block doesn't work. And then otherwise also in fact, I have in the last 10 years, I have just advised 4 or 5 patients, celiac block in 4 or 5 patients. I mean, you may not believe that, but that's true. So I don't prefer celiac block because these patients, when they come to a referral center, already have the sensitization. Their whole spinal cord gets sensitized. So if you do celiac block also, pain will still be generated from the thoracic and the lumbar segments. So celiac block, in my opinion, has not much of a role. And the third question, head coring. Yeah, again, that's a very individualized approach. Yes, if there is a head mass, I alluded that to in one of my slides, the dilated duct stone head mass, it's better to go for a head coring. And yeah, the earlier it has been believed, and even now it is believed that the head of pancreas is the pacemaker of progression of fibrosis, which could be true. But as the disease progresses, once the nerves are involved, the whole ball game becomes different. The nerve takes over, the spinal cord takes over. So initially, if there is a head mass with a ductal stone, head coring is going to help. But in the later stage of the disease, I think the patients will come back with pain. Fentanyl patch can be used as a rescue therapy. It cannot be a long term. If a patient has acute exacerbation of pain for a short while, yes. But I would not recommend fentanyl patch for a long term or with a recurrent use.
Excellent talk. You told that the spinal cord becomes sensitized and there's also pain memory.
Yeah.
So do you suggest that right from the beginning, we should liberally use the painkillers and NSAIDs so that the patient doesn't get the memory of the pain, and instead of giving off and on painkillers, whether we should use a liberal use of
a liberal painkiller will have their own set of side effects.
Yeah.
If we give NSAIDs, you know the side effect of NSAIDs, and the pain.
How to prevent the sensitization?
Because one is sensitization, one is you'll often see this in your patients, even in your family members. Different people will respond different ways to any kind of pain, not necessarily pancreatic pain. So even in the acute exacerbations, there will be a difference in. So that probably is to do with their own experience with pain, family history of pancreatitis, their personality trait. So I think it may not be a good idea to keep on giving painkillers with the hope that pain memory comes down. There will be many other layers which may be responsible for the pain memory. But if the patient, if you think that the patient has sensitization, then it would be a good idea to start a pregabalin or a duloxetine kind of medication.
I think just one question about the whole thing. We know in alcoholic pancreatitis, after some stage in their course of life, once the pancreas gets fully damaged, the pain ceases. And they don't have these issues of sensitization, other things.
Yeah.
Is it because of the excessive use of analgesics? They get this, and once we try to reduce it, some people are dependent on tramadol or other drugs that this causes rather than this thing is causing. And second thing, just with the same thing, that if we do a surgical procedure, because you cannot establish that kind of drainage, you know, you cannot take care of the many strictures by endoscopy.
Right.
And at least we have some retrospective data where it is better, pain relief is better with a surgical procedure than with the endoscopy treatment.
Yeah, so answering the first question, alcoholic and smoking related pancreatitis probably have some additional layers of mechanism, because if you remember that slide where I showed diabetes is delayed, it did not work with alcoholics and this smoking related patient. They have less pain. So one, of course, it could be because of the
frequent use of analgesics. And I'm not very sure, but idiopathic chronic pancreatitis happens much earlier. If we see now, but alcoholics and smoking happens later. So if we follow those alcoholic patients for a longer duration, probably we might get the sensitization because we get a short window of seeing them. So maybe if we follow them for a longer time, several days, probably actually in our center, I mean, we have referrals from different places. We do see these patients coming back with sensitization, even alcohol and smoking related.
Yeah, but your huge experience of 5,000 patients.
Yeah.
What happens in the natural history? Suppose you have a patient for 20 years.
Yeah.
Has the same degree of pain versus a person who's
No,
5 years.
same degree of pain is, again, the degree of pain or how the patient respond to pain is different, and it do not correlate to the severity of the disease. That's what I tried to say, because that will depend on the patient's personality, the other factors, the sensitization or his old pain memory, his experience, many other factors. I have not shown lots of data here, the different layers. So those are also affecting as the disease progresses, how the patient respond to pain. And therefore it's very difficult to say which mechanism is playing what role at a certain time point.
Last question, Dr. Mohan Joshi.
Mukhar sir, thank you so much. I have some comments. Being an endoscopist and surgeon, that pancreatic stones, when the pancreatic duct is riddled with stones and you try to fire with ESWL, large number of patients land up with massive acute pancreatitis. That you have to accept, number one. Number two, that if you have a massively dilated duct and stones with chain of leg appearance, surgery, that is pancreatico jejunostomy, simple technique is much better.
Yeah.
On many occasions, we have seen that the patient has got chronic pancreatitis, patient has got dilated CBD as well as pancreatic duct and stones. And my colleague is also here. We have done several PJ, that is Pusto's procedure.
Yeah.
Simple pancreatico jejunostomy, removal of the stone, that has rendered the patient pain-free, number one. And number two, at a later date, we could also remove, because that compression, inflammatory compression over the common bile duct has gone. So we could also remove these stents. This is very important to remember, that all the time, we may not need a head coring procedure.
Yep.
That is very important. These are my small experiences and comments, but it does induce acute pancreatitis, which we have seen on several occasions. And it is very difficult. In fact, if that debris is not removed quickly, it is always better that if you at all wanting to go for this procedure, then do not wait for the second procedure of ERCP and this thing. You put a nasopancreatic duct, if you can pass, that is, if you can put a nasopancreatic catheter and start flushing as soon as the thing is done, as soon as the pulverization of the stone is done, by and large, the stones recur. And the last comment is, on many occasions, you see no pancreatic parenchyma, hardly any pancreatic parenchyma, massively dilated duct, and no pain. Probably only pancreatic enzyme replacement is must, and that is enough.
Yeah, agreed.
Thank you. You want to ask? Thank you. Thank you. Dr.
Thank you so
Gupta.
much for kind hearing.
For the next session, I would like to invite Dr. Mukul Rastogi and Dr. Naresh Bansal to moderate the session. And Dr. Kiran Kumar Khanal, Dr. Abhishek Gupta, Dr. Alok Mishra, and Dr. Rama P. Goswami as chairpersons. The session is on cholestatic liver disease, and the speaker would be Dr. Bhaskar Nandi.
This is last topic before dinner. The topic is cholestatic liver disease, which is quite often challenging for hepatologists. And the speaker is Dr. Bhaskar Nandi, the renowned gastroenterologist. Dr. Bhaskar Nandi, please.
Thank you, Chairperson, sir. And indeed, it's a privilege to be here sharing the platform with you all. I thank Dr. Ashish, Dr. Anil Arora and his team for giving this opportunity. Announcing that it's the talk just before the dinner adds a lot of pressure. And obviously the pressure was that cholestatic liver disease as a subject is quite vast and it's quite an open-ended talk, very difficult to structure what all to leave and what all to cover. So what I've decided is to just touch upon various facets of this subject and maybe take on with a discussion with the audience on specific issues. This is a very cartoon which is well familiar to us. If we look at the formation of bile, bile is an aqueous solution which contains bile salts, conjugated bilirubin, phospholipids, anions, electrolytes, and water. Basically, 3 steps are involved in this. One is the uptake of the bile salts and formation of the bile, which happens to the basolateral membrane of the hepatocytes. And of course, its transition and reaching the canalicular membrane, where it is secreted into the canalicular bile ductules. And from then onwards, it flows down to the larger ducts and into the intestines. The point to be noted here is that it's an active process, and both the basolateral membrane and the canalicular membranes have got active transporters and receptors, which actually do this against the gradient. So there is a osmotic gradient over here, uptake of bile acids, sodium dependent, non-sodium dependent pumps are there, which pull in the bile salts. They are processed over there, conjugated. And once it reaches the canalicular membrane, we have the ATP acid binding proteins, which are very familiar to all of us, MDR1, MDR2, and MDR3, and the bile salt export pump. This is the rate limiting step. And of course, this bile, which is secreted into the ductules, is further modified by the cholangiocyte secretions. Cholestasis, if we look at this, any obstruction into any of these 3 steps can lead to cholestasis. So either it can be at the basolateral membrane of the hepatocytes, wherein you are drawing in the bile salts, the formation of the bile, or in the excretion of the bile through the canalicular membranes, or in the larger ducts where it is flowing down. So accordingly, the diseases are there. Within the hepatocytes, most of it are intrahepatic cholestatic diseases. Once you reach the canalicular membrane, you get a host of genetic disorders. And then, of course, the small ductules where primary biliary cholangitis comes in. And as we progress distally, we have the PSCs and, of course, bile duct stones, cholangiocarcinomas, and other tumor masses over there. So if these are the cholestatic liver disorders, I like to draw your attention to this circle, where we generally equate cholestatic liver disease with PSC, PBC, and such disorders. But if you look at it, about 50% of them are actually secondary sclerosing cholangitis. And it's a large group, which includes starting from toxins and portal hypertensive biliopathy, AIDS cholangiopathy, traumas, genetic deficiencies, and of course, a host of infiltrative diseases. Why this becomes important is when we are evaluating a case of suspected cholestatic liver disease, I think it's important to keep the list of secondary sclerosing cholangitis diseases, because they do require a ruling out, which is difficult, but mainly it requires a very good history to be taken for this. Now, what causes these cholestatic liver diseases? One is, of course, the cholestasis. Now, once there is cholestasis over here, it can happen because of so many etiopathogenic findings. It can be because of unknown environmental risk and toxins. Now, if we look at PSC, PBC, the 2 common disorders which we equate with cholestatic liver disease, they have a genetic predisposition. But I think environmental toxins, which we still don't know clearly, it could be drugs, it could be xenobiotics, it could be pollutants. There's so many things which we have not identified, which actually elicit an inflammatory response in a genetically susceptible person. But what triggers and maintains this inflammation is the cholestasis, and it does it in three ways. If you have cholestasis, there is ductal injury, ductal reaction, there is bile acid toxicity, the accumulated bile, and mitochondrial dysfunction. And finally, there are a lot of epigenetic and immunogenetic influences which actually drive this inflammation. Of late, another point which has come up into the pathogenesis is the gut-liver axis. When I reviewed the literature, I realized that if you look at cross-sectional studies, there is less in diversity in the patients who are having cholestatic liver disease like PSC and PBC. There are certain subgroups of microbiota which are more and some which are less, but could not find any single pattern, which can say that this microbial pattern is actually pathognomonic of PSC or PBC. I think a lot of work is required in that. A lot of translational research will be required in this. PSC is a prototype disorder of a gut-liver axis. So gut microbiome does have a big role to play in eliciting the inflammation and sustaining, and of course, leading on to end-stage liver disease because of continuous fibrosis, obliteration of the ducts, ductopenias, and all that. But then, as microbiota with all other subjects, I think more studies are required in this. And simple, as far as trials are concerned, antibiotics have been tried in PSC, vancomycin, FMTs are being tried. And the genesis is this, that gut-liver axis has got a lot to play in this. If we look, a cursory look at the major disorders, primary biliary cholangitis, PSC, and IgG4 related cholangitis, these are the three main autoimmune conditions which we are classifying under cholestatic liver disease. Though they have got a common pathogenic mechanisms, but if you look at PBC and PSC, their phenotype is much, much different. One disease in PBC, you have female predominance, they come at a much elderly age, whereas in PSC, you find it's in males, in middle-aged ones. But both the diseases may be very silent initially. It's only when they start progressing that the features of decompensation and end-stage liver disease comes in. The PSC patients are also saddled with recurrent cholangitis, and they have deepened jaundice because of the biliary obstructions, the strictures. So that is one different way they manifest as far as PBC is concerned. IgG4, we have had a session on this prior to this, and I think a lot has been discussed on that. This has to be always kept in mind when we are looking into a stricturing disease. And I think one of the big things in IgG4 is to look for associated involvement of the other organs. So that always is a sort of a giveaway if we are thinking of IgG4. And then, of course, we have to do the relevant test for that. Drug-induced is another point which we always have to keep in our mind. Now, the drugs can produce various injuries, bland cholestasis, cholestatic hepatitis, and of course, the inflammatory destructive. There are various drugs for this. There are mechanisms. The importance of this is that we should have these common drug lists with us when you are trying to evaluate a cholestatic liver disease and take a relevant history because of this. How do we diagnose? If the patients are usually asymptomatic and they come with a cholestatic picture of the liver function test, we do need to take a good history, a physical examination, and of course, followed by an abdominal ultrasound. I think it is in the first step that we look for causes of secondary sclerosing cholangitis. We look for drug-induced, and we also have to get a fair idea if we are dealing with IgG4 related diseases. I think this will be the first step itself. Then, of course, we do the serological test. If we get an AMA positive, the chances of PBC, and we evaluate on that length. But we also published a paper a long time back in which it was a case series in which we had about 6 patients without any pruritus who turned out to be primary biliary cholangitis. So even though pruritus is always taken to be a must, but then you have patients who do not have pruritus in such cases. After, if the AMA is also negative, you go for a good imaging, high quality imaging. It can be either an MRCP or an EUS. And of course, that helps us in the diagnosis of primary sclerosing cholangitis. But then comes the problem of a small duct PSC. If you do not get any cholangiographic changes, we go in for a liver biopsy and we actually see those fibro-obliterative changes in the ducts, which can give us a diagnosis of small duct PSC. And finally, of course, if everything turns out to be negative, we look into the genetic causes of cholestatic liver disease, the PFIC syndromes, which all come in. And if everything fails, obviously, we keep the patient or follow up and observe for development of further issues. This is just a slide to show about the treatment of pruritus, and usually UDCA we all prescribe for these conditions, but I think this particular has been a study on PBC and PSC, and they found that cholestyramine given in such doses, second line therapy, rifampicin, fibrates, bezafibrate if not available, fenofibrates, and of course we go down the list. So these all may be tried. Efficacy is around 50 to 60% of the patients get relief with such antipruritic treatment. Now coming over to the certain contentious issues in the management of primary biliary cholangitis. Now, is liver biopsy essential for the diagnosis? I think the answer is no. But then we all know in a post-transplant setting, if there's a recurrence of primary biliary cholangitis, how do we diagnose it? Because remember that anti-mitochondrial antibody remains positive even after the transplant. So bare picking up AMA positive does not mean there has been a recurrence. So if there is a rising ALP, there are a lot of causes of rising alkaline phosphatase in a post-transplant setting. So diagnosing a recurrence of PBC, I think was always a challenge, and it will require a liver biopsy to rule out more other common conditions, which may include anything ranging from chronic rejections to recurrence of disease. What do we do if we get an isolated AMA positive? I think these are all contentious issues. You have an isolated AMA positive in an individual, but alkaline phosphatase and all are normal. So a patient is otherwise asymptomatic. Does it call for PBC? Well, it has been shown in certain studies, in the follow-up studies, that these patients may go on to develop primary biliary cholangitis. So these patients should be always kept under follow-up. But whether we do a liver biopsy at this stage, I'm not very sure. The literature doesn't guide us on that. So this will be another contentious issues. One thing which I wanted to add here is that if you have AMA negative, there are anti-nuclear antibodies which are specific to PBC, like GP glycoprotein 210 and SP100. We can look for this. I'm not very sure how many labs are freely doing all this. But then if your AMA is negative, you have ANA which are specific to PBC. And it is documented that one of the serological autoantibodies are always present in a case of primary biliary cholangitis. You may have AMA negative, but then you will have these ones as positive. The concept of management of PBC has now gone over to risk stratification. Now, what it basically means is that, of course, you stage the disease, and depending on your stage of disease, you manage the cirrhotic, you manage the portal hypertension, you have supportive therapy. But if we talk of UDCA, which is always given in the case of primary biliary cholangitis, the question is that today we have got a second line therapy in form of obeticholic acid. How long do you give UDCA, and when do you decide that this first line drug has failed and we have to go over to the second line drug? So that's the question. And this particular study recently, which has come up, what it has shown is that so far we have been following up these patients clinically, and if they remain asymptomatic and the bilirubin and the serum alkaline phosphatase reduce, but they do not normalize, we take it as a responder. What this follow-up study with metabolomics and other protein markers has said is that you have to normalize bilirubin and you have to normalize alkaline phosphatase. If you don't do so within a period of 1 year, you can call it as a non-responder to UDCA and switch over to OCAs. So definitely in all these points, we like to have an opinion of the audience as to what do they do in their clinical practice, like when they actually switch over from UDCA to obeticholic acid, and what sort of an algorithm do they follow. Similar, some very novel therapies have come up in PBC. Just to complete my list, there are some certain drugs which are of proven benefits, like UDCA and obeticholic acid. There are certain drugs which have been absolutely given away, azathioprine and penicillamine, and some which are of unproven. For example, methotrexate and TNF alpha inhibitors. So they are still under trial. The novel therapies are basically all under ongoing trials or at the most phase 2 trials. Some promising ones have been the PPAR alpha agonist and the PPAR delta agonist. The fibrates, which have again come into this. The NOR UDCA, it has some better effect than the UDCAs, antifibrotic agents, immunomodulators. In fact, there was nothing much to speak because all of them have not entered into the clinical application and they are all undergoing studies. But then I think in the years to come, we may have certain more class of drugs apart from OCA to treat primary biliary cholangitis. Coming over to the PSC, I think PSC also has got a lot of problem. If you look into the question, is liver biopsy essential for diagnosis of PSC? I think the answer everybody will say is no, it is not required. Only in that subset of cases, maybe where you are thinking of small duct PSC or an overlap, you may be able to do it. What is the clinical significance of serologic markers in PSC? Do they actually tell you or prognosticate about the disease? Endotherapy in PSC, I think again will require an opinion of the house, how they go about it. And one thing is sure that there is no proven benefit of medical therapy in PSC as of now. UDCA and all, these drugs have not changed the course of the disease. Now, if we talk of diagnosis of PSC, how we do usually, we see the elevated serum markers of cholestasis, we do a cholangiography, we exclude the secondary causes, and we are happy that we have got a diagnosis of primary sclerosing cholangitis. Liver biopsy is indicated, I think, in 3 conditions: when you are strongly suspecting a small duct PSC. Small duct PSC, we all know, has got a much benign clinical course than the conventional PSC. There is less incidence of end-stage liver disease, less cholangiocarcinomas, but 25% of them, they progress to large duct PSC. And one more interesting thing which I found was that IBD is associated with PSC, we all know. In small duct PSC, it is Crohn's which is more prevalent than ulcerative colitis. If you have an overlap of autoimmune, I think a biopsy will be required to diagnose this. The treatment slightly changes. And of course, in a large group of secondary sclerosing cholangitis, biopsy may be required, especially for IgG4 related, where we can look for the IgG4 plasma cells. About the absolute cutoff levels of IgG4 in a suspected case of PSC, now we must remember that in a quarter of a patients of PSC, IgG4 may be raised. That automatically does not tell us that we are dealing with an IgG4 related disease. Either, of course, we need to prove it. But the cutoff level, which is more than 4 times the upper level of normal of IgG4, is almost diagnostic of IgG4 related cholangitis in this particular setup. Clinical significance of serological markers, well, they are all present in various percentages, but that has got no diagnostic specificity. But what has been shown is that anti-glycoprotein 2 and PR3 ANCA are prognostic antibodies in PSC as they identify patients at risk of severe disease, poor survival, and biliary cancer. So can we use this in the early stage of the illness to see which patients are going to have a downhill course? I think we all need to look into that and discuss. Now, coming into our endoscopic intervention in PSC, which we all do in whatever cases we see, the question is that when do you actually intervene with endoscopy in PSC? Now, you have a asymptomatic patients, let's say, who has not shown any features of decompensation. And the other subset of patient is you have who is having recurrent cholangitis. Now, if you get a dominant stricture, that is more than 75% of the duct Newman is narrowed, then I think you can go in. But the question asked here is that, do you do it on schedule whenever you see this, even before the patient is symptomatic, let's say with cholangitis, or do you do it on demand? Now, this one particular study has shown that in patients with PSC, timely detection and repeated endoscopic therapy for dominant stricture up to sustained resolution of biliary obstruction, even in the absence of laboratory or clinical signs of cholangitis, should be performed to prevent chronic liver damage caused by biliary obstruction and infectious complications. But I think this is, the jury is still out on this, and definitely we like to have opinion of the house as to when do they actually intervene in PSC? Is it on schedule? As soon as we see a dominant stricture, the best is to go in for a stenting with all its complications, because all said and done, ERCP in PSC patients is difficult. The strictures are tight as far as their locations. You can easily negotiate and deal with the strictures which are distally, but as we go on proximally, it becomes much more difficult. And how do you deal with it? You just do a dilatation, you place a stent. That has also got its limitation. What are your chances of introducing sepsis once you deal with this patient? So the question again, I come back to that, if we do it as a routine or we do it only on demand, I think that we can further discuss on this. Novel therapeutics in PSC, it's a continuing search. As I was mentioning about gut-liver axis, vancomycin and FMT has come in. Obeticholic acid is undergoing a phase 2 trial for the patients with PSC. And of course, the host of other novel molecules, but none of them is there in a clinical practice so far. The last slide on liver transplantation, well, it's a viable modality of treating it. And indications in cholestatic liver disease are many: PBC, PSC, secondary, PFIX, alligales, and all other genetic congenital conditions, infiltrative disorders. They are all indications for liver transplant. The only difference over here is from other chronic liver diseases is that you have got symptoms specific to disease which qualify for a transplant. You have got intractable pruritus, you have got metabolic bone disease, even extreme fatigue. They can all be listed as an indication for transplant, and you need not wait to have a decompensated cirrhosis or which we take in other chronic liver diseases. So this is one difference between indications for transplant in other diseases versus cholestatic liver diseases. The survival after transplant in cholestasis is good. Survival is as good as any. There are recurrent rates. In fact, PBC recurrent rates reach up to 40% over 15 years. And PSC also has got its recurrent rates. The challenge is to diagnose the recurrence, which we had discussed earlier. And I think it will always remain a difficulty because of a large list of differential diagnoses which can present in a similar way in a post-transplant setting. Then we often have seen patients who have got IBD and PSC, and the dilemma was that if I go in for a liver transplant, it is said that my IBD is going to flare up. The literature says that despite taking due precautions and surveillance, in about a quarter of IBD patients, it's going to worsen after a liver transplant, even if you have adjusted your immunosuppressions to this. Like it's known, tacrolimus and MMF both can actually worsen your IBD clinical course. And azathioprine is one which has been suggested to use in a post-transplant setting for this. So again, if this varies from center to center, how do they deal with it? And listening to the experience of people who have done many PSC and IBD transplants as to what happens to the colitis, what happens to the recurrence of liver disease, I think that will be interesting. So to conclude, rapid advances have been made in our understanding of the molecular mechanisms, genetic predisposition and environmental triggers. They play a key role. The gut-liver axis has a strong influence, especially in PSC. We have got a lot of novel therapies which were coming up, which require further studies. But at the end of the day, there is a need for a large amount of clinical and translational research to identify prognostic and diagnostic markers and therapeutic targets, both in PBC and PSC. This is the hospital where I work at. Thank you very much for your patience.
Thank you, Dr. Nandi, for the elegant talk and covering each and every aspect of the cholestatic liver disease in a short period of time. So my question to you that PBC patients or PSC patients, they are having low MELD score. So should this MELD exception is, criteria should be applied on these cases for the indication of liver transplant? Because the indication of liver transplant is in these diseases are intractable pruritus, which is not covered under MELD criteria. So they should get advantage of that, number one. Number two, they are more prone for the development of cholangiocarcinomas. So like SCC having MELD exceptions, so cholangiocarcinoma, which are prone to occur in this disease, they are also having MELD exception. And my second question is, what are the common causes of cholestasis post liver transplant?
Yeah, thank you for that. If we talk about cholangiocarcinoma in PSC, I think apart from very early Hyler, most of the centers do not accept cholangiocarcinoma for liver transplantation because of the high recurrence rates and the prognosis is not good. The Mayo protocol that we keep reading about external the EBRT and brachytherapy followed by chemosensitization and then for a transplant. I think that's a very restricted and vigorous selection criteria for liver transplantation. And these particular results have not been very well replicated in other transplant centers. So transplant for a cholangiocarcinoma is again a very, very difficult decision as to whether it is to be taken up or not. There are many from here from active transplant centers, and I think in many centers cholangiocarcinoma is not an indication for liver transplantation. As far as your MELD scoring is concerned, that was the point I was alluding to, that yes, there are disease-specific indications in cholestatic liver disease which actually do not qualify if you just go by Child's and MELD's criteria. As far as exception points are concerned, it is there, but I think I look at it this way, that if you're talking of a disease donor liver transplantation, I think all these points and this become very important, because who can jump the queue and then get it over it. This debate is still there whether, in fact, it has been noted that most of the cholestatic liver disease patients do not get a transplant because they do not get the exception points and they do not qualify as such. But in India, where we are talking of living donor related transplant, I think we more or less have given up on this particular problem about exception points. If we feel that yes, this is eligible for a transplant, a living donor actually doesn't have all these problems. As far as cholestasis post liver transplant, there are a large number of things. One is physiologically it may happen. Secondly, it happens in a host of conditions. In fact, some, of course, biliary strictures, which are common, ischemic strictures, and then it can happen with even hepatic artery thrombosis, which we have managed can lead to cholestasis. A lot of drugs which have been used have lead to cholestasis. In fact, there's a long list. In our experience, we have seen cholestasis in liver transplant patients, but I think they can be managed well. The problem is if you develop post liver transplant cholestasis, secondary sclerosing also, they actually go for a retransplant because they do not respond very well to the drug therapies, to the medical therapy.
So regarding cholangiocarcinoma, one comment I want to make. So previously, this cholangiocarcinoma was considered as a contraindication, but nowadays it is rather an indication for transplant in PSC or PBC. If the hilar carcinoma is there and less than 3 centimeter, and they follow the chemo radiation protocol, Mayo protocol, and after that the staging does not show any extrahepatic disease, then these patients should be well taken for liver transplant.
I have no two views on this. I totally agree with you that if we can be able to identify such a subset, yes, they are due. But I think our experience so far has been that, first of all, we are not able to pick up cholangiocarcinoma at that particular stage. And opinion of the house, I think, is most welcome on this. People who are in the transplant centers.
Dr. Harsh, please.
The first one is MELD scoring in West was not created just to say who should get liver first and who should get. It was also created so that who will be best served with the liver. When I worked in Canada, we were not saying that somebody is very sick may not get liver and somebody is relatively not sick gets liver. So the point is the donation will serve who the better. So jumping the queues in India because you can bring money and you can bring your own liver. sometimes I find not ethical, and especially in alcoholic, it's a big topic you can debate. I think I made a point everybody can discuss. The second, we talked about cholangiocarcinoma. Any kind of cancer gives you extra 10 points. So if you evaluate and you think it is a good, I agree with him, nowadays cholangiocarcinoma should be pursued for that. The third point which I want to make is the non-hepatic complications of PSC and PBC, like colitis and all. As far as understanding we have, these are due to the antibodies which are created in your body. So changing the liver will not change the other scenarios. And I have a long list of patients we followed and published also, that even post-transplant, you will get UC and in these patients, but not that fulminant. I don't know what happens. Maybe immunosuppression we use post-liver transplant, that's helping. That's all I want to say.
Hi. Good evening. A very nice talk. Since there was a topic of discussion was the cholangiocarcinoma in PSC and transplant, I happen to have been the part of the Mayo system for a while, and I published in this where we looked at our experience while I was at Mayo with transplant for the cholangio of CAs with PSC. I figured I'll just make some comments. I think it's a select group which were less than 2.5 centimeters in size, which were inoperable with a hepatic resection. And these patients were effectively downstage using the specific protocol. And I looked at the data myself, and there were about a third of patients who actually could not be downstaged. And they had metastatic disease on laparoscopy staging. So those were the ones who could not get transplant. And then there were also patients, and this protocol was actually replicated in multiple US centers. So, and then there were effective results with about 65% or more 5-year survival. So it is effective, and I think it's been replicated. I think the frequency of finding cholangio-CAs with PSC in India is probably exceedingly low. So I guess, therefore, probably we don't have enough experience here. So
when I say not replicated, I was actually talking about our conditions. And I think one of the biggest lacuna here is picking up cholangiocarcinoma in a case of PSC in time to actually qualify for this thing. And I really like to know that how do you follow up your PSC patients? What is your surveillance for cholangiocarcinoma in a patient with PSC?
Yeah, so for cholangiocarcinoma surveillance, usually annual MRIs would be something which was routinely followed to assess for dominant strictures, and if found, then further evaluation, which would be undertaken. Certainly at those days, cholangioscopy was not in vogue. Perhaps now there has been an evolution in terms of performing cholangioscopies in these patients. Although I do recall some of the people I had worked with were doing periodic surveillance with cholangioscopy guided biopsies in PSC patients, which is an expensive proposition, but really not evidence-based. Yeah. But I think that also there's added risk of infection in the Indian context. So I'm not sure if it's justified here.
Because usually if we find a dominant stricture and many centers do not have a cholangioscope, we used to take a breast cytology. We all know that the yield is very poor in a breast cytology. And so most of the times, I really like to know how to best follow up these patients with PSC so that we can pick up a cholangiocarcinoma, because that's a real risk if we are talking of PSC. Thank you for your comments.
CA 19.9 should also will be kept in the surveillance like SCC. In SCC, we have to do alpha-fetoprotein and ultrasound every 6 months. So similarly, we have to do CA 19.9 along with some imaging in the form of MRCP or.
See, it's the point about CA19-9 is if you have got a cholangitis or a recurrent cholangitis, your CA19-9 increases at that time. So maybe you wait again for 4 weeks, deal with the cholangitis, and then repeat all that. So theoretically, yes, I agree with all the comments over here. I was just talking about the practical real life situations. How do we go about it?
Sir, please.
Dr. Nandi, good talk. I just want to emphasize that alternative medicines responsible for cholestasis is an important entity in clinical practice. alternative medicines.
Okay, so very true. That should have been there in my drug list about the alternative medicines. They do
So
produce.
in COVID era, we saw a lot of patients with the alternative medicines developing cholestatic liver disease. And we thought the possibility of autoimmune hepatitis in such patients. And ANA is positive. And once we do the biopsy, there is no feature of which fulfill the criteria of ANA. So they are most of these cases were delayed and they respond to steroids well. So definitely alternative medicines.
COVID per se, when it causes hepatitis, you have intrahepatic cholestasis. Even
That is
without
different, but in
per
COVID,
se.
lot of patients using Giloy and Kala
That is
for,
very true.
yeah. So
Very true.
because of that, they have lot of injuries. Any questions? Any question from the house? I think we are running late, so we have to close the session now. Thank you so much, Dr.
Thank you,
Nandi,
sir.
for excellent.
Thank you for this last session. With this, we come to the end of today's academic feast. And we will now join in the Regency Ballroom for a gala music night and cocktails and dinner. Tomorrow's session will again begin from 8 a.m. with interesting sessions, Pearls in Gastroenterology, followed by endoscopy session. So we again hope to have a very good academic feast tomorrow morning. So I would like all of you to join at 8 p.m. in the Regency Ballroom. Thank you.